First session, better to have some more noise. Okay, good morning. Okay, very good. Welcome you all for this FDP on decoding effective communication skill in patient care. So this is the second such program we have conducted. In 2023, we conducted a similar type of program for especially the clinical side, clinicians. So this is the second such a program on effective communication skills in patient care. If you attended any of the MEU programs, we'll tell, even if you like or don't like, we'll tell you this point. So there are three domains: cognitive, affective, and psychomotor domain. Okay, it is a cognitive is something to do with knowledge, affective is something to do with the heart, psychomotor is something to do with the heart, it is a hand. So in the Indian medical system, what we are feeling is we are bombarding so much information to the student. He is having too much knowledge. Maybe probably he is good at a skill, but something he is weak at heart. To improve this heart, that is communication or affective domain. So this is comic, big heart or big head. We want some student or any clinician, doctor, who can have equal proportion or equal knowledge on all these domain, which is generally it is neglected, especially the affective domain. So we want to bridge this gap between heart and it is a brain and hand with this type of a workshop. And if you look at this, many of the it is a daily you'll be getting. So it is we are thinking many of the time hitting the doctor is one of the national sports. So why it is happening? Why it is happening? It is many of the time it happens because of lack of communication. So a bad communication ends a lot of good things. A good communication ends a lot of bad things. So with this intention, we are conducting this workshop. It is basically to improve the doctor-patient relationship and also to improve the communication, honesty, transparency, shared responsibility, empathy, sympathy, vulnerability. So in this today's session, we will be trying to cover the basics of this, and so that you'll be getting benefited from this workshop. As I said, you are seeing laughing faces, I will say. So we conducted in 23 this similar kind of workshop with your own colleagues as a participant, and the esteemed colleagues or faculty members, those who are sitting, so they have conducted this, they have assisted us in conducting this workshop. We are having the eminent resource person. There is a reason for selecting this eminent resource person. One of the reputed person is Dr. Ravi Vaswani sir. He is sitting last. He has graduated from Nair Hospital, Mumbai, and MD Medicine from KLE University of Belgaum. And he is a founder registrar of Enapoya University. And he is a course director of postgraduate PG diploma in clinics ethics at Enapoya. And he was the secretary, joint secretary in Enapoya Ethics Committee. I think, sir, if I'm right, so probably within 1 or 2 days, he is planning to stepping down from this post, right, sir? Okay. And he is having special interest in infectious disease, HIV, and COVID. He is a professor of Department of General Medicine at Enapoya Medical College. Next, we are having another resource person, Dr. Harsha Prasad L. He is a consultant pediatric hemato-oncologist and associate professor, Department of Pediatrics at KMC Mangalore. He has completed MBBS from VIMS Bellary, MD from University of Maharashtra, Sion, Mumbai. He has completed MRC Child Health, MRCP, and he has completed certified training at London. He is having several publications. He is an active member of very many professional bodies, including IAP, IMA. So welcome to Harsha Prasad, sir. A new pickup from this programs, he was not there. So we are having Dr. Yogesh Kamath, consultant hip, knee, sports injury specialist surgeon, Department of Orthopedics at KMC Mangalore. He has done his MBBS from University of Mumbai, MS from KEM Hospital Mumbai with the gold medal, and he has several fellowships from UK and Germany, and he has several index journal publications and several patents. He is a coordinator of Specialist Arthroplasty Forum, Karnataka State. Welcome to Yogesh, sir. Dr. Vishwaranjan Das, he is also new pickup, this time new pick. He is a PhD scholar at NITTE in Diploma in Football Medicine. He is a MPT, Musculoskeletal Disorders and Sports, and got secured 5th rank at RGHS and Diploma in Fitness Training, and he has completed BPT from Utkal University, Odisha. He is having several publications. Welcome to Vishwaranjan Das. The person behind this conducting workshop is this man. I am fortunate to tie him up for full day at MEU program, Dr. Vikram Shetty. He is keeping, it is a generally, he generally keeps on asking me when you will conduct this communication workshop. He doesn't need any introduction. He is a professor and HOD of orthopedics. Okay. Next we are having Dr. Karen. She is a professor of general surgery, and also she'll be joining late because of her OPD commitment today. And new and young and energetic, I will say. You know him, yesterday he is promoted as HOD, Dr. Shishir. So first program as HOD at MEU workshop. So this is all the resource persons for today. So that is about our faculty. Now it is a time for ice break. Even I don't know many of you. So I'll be asking I'll be taking the assistance of Dr. Ankita. She is also Professor of Community Medicine. Dr. Ankita to take over.
Good morning to all of you all. Good morning. Yeah, if you see your tables, there are some chits like this. Please listen now. The most important thing of a communication workshop is to listen, right? So I would like all of you all to take a chit from them. If there are any who don't have a chit, please let me know with a show of your hands. Everybody has one chit at least, right? So today we are in a communication workshop, and the most important thing in communication is to communicate about yourself, right? So I want you all to take 2 minutes and write something unique about yourself. Please don't say nice, I'm not a bad person, handsome, pretty, okay? Because even if you see any picture, no, say that you're seeing a photo album, whose picture do you see first? Your picture, okay? So for you, you are the most handsome or pretty person, and such adjectives are not very useful to identify yourself, right? So take 2 moments, think and write something about you which is unique, which can be identified by others. Did you understand? Take 2 moments. Name not to be written. Please don't tell name. Please don't have, you are not supposed to use your name. If you do not have a name, if you do not have your name, how would people identify you today here? Think and write. Did you get it? Should I be repeating myself? Very difficult, huh? Very difficult. Very easy. Giridhar sir.
Next task will tell you.
Yes. So think about yourself. What would be one unique identifying feature about you?
Don't write your name.
No writing name, okay? Names are not allowed, but you can write some identifying feature about you, which is very unique to you today. I'll give you a 1 minute time. Is that fine? Is that okay? Can I give you a moment's time? One minute. Sir is done. If he had early bird, jaldi 5, no? Sir would have won it. Yeah, make it into 4 folds. Please don't make it into 2 folds. Make it into 4 folds and put it into this. Please make it into 4 folds. Fold it twice. That's how you'll get 4 folds. Siri ma'am, no copying. Don't see. This is like heights. I've asked you to be very unique.
That's an amazing skill to copy in this section.
Yes, this is something that somebody should identify you. Don't copy it from others. Identity crisis agubidute. Haita. No writing your name. Anything about yourself that is unique to you today and that can be identifiable. Yes. Essay baribadi. Kelor essay baritavare.
Thank you. Dade?
Yes. Something very unique about you today. Yes.
Okay. Okay, fantastic.
No. We'll tell you what is it all about.
Super.
Dridhiman sir done. Innondu fold ಮಾಡಿ ಕೊಡಿ sir. One more fold. Yes. Sir, are you done? Yes, everybody has submitted. Siri ma'am is writing essay. Ma'am, MCQ question it is. Don't write essay. Yes, everybody else? Everybody has submitted? There. Okay. Now, we'll be shuffling these chits and we'll be shuffling these chits. As soon as you get a chit, please open and see whether it is you only. If it is not, then you can keep it with you. Please do not disclose it to anyone. Don't ask anybody, is this what you have written? Okay? That beats the whole purpose of
I think we played all this in medical school, no madam? Fish pond.
Yes,
Yeah.
somewhat similar to that. But then you used to write about others in fish pond. This you're writing about, this you're going to, we'll tell you what you're supposed to do. Just check whether it is not you. Okay, your chit, you have not got your own chit. If you have got your own chit, please fold it as you got it and put it back. Don't write your name. I hope okay, those people get disqualified, okay? Outright get disqualified. Oh, do sir, no problem. Your name you don't write. Did you get your own paper? If you have got, then please let me know. Please fold it into the same way and then put it back into the, shall we start from last, group 5? Who would want to volunteer? And we'll start with Giridhar sir, because sir put first. Sir, please sir. Please come forward. I'll tell you what you're supposed to do. Phone bidi sir, phone iga beda. Yes. So we have Giridhar sir here. Sir, so I will use sir as a demo. So sir is supposed to be reading what is there.
I'm a good listener.
1 minute, sir. 1 minute. Sir, you please listen to me, then we will go forward. Right? So you're supposed to be reading this and you're supposed to guess who could have written this about them, him or her. Okay? Fine? Don't exchange now and don't ask. Okay? Yes, sir. So you have 30 seconds to guess. Your time starts now. Read it out, sir.
Yeah. I am a good listener. I have never said die attitude. Die attitude.
I have never said I attitude. Can you identify who would have written?
No.
So, not so specific. Okay. Can we have...
He has to guess.
Yeah, you have to guess.
You guess, it's okay.
It is still open. 30 seconds into agilla. You guess ಮಾಡಿ. ಯಾರು ಇರ್ಬೋದು ಸರ್? ಲಿಸ್ನರ್ ಒಳ್ಳೆ ಇದ್ದವರು, ನೆವರ್ ಸೇ ಡೈ ಹೇಳೋರು.
By handwriting, it looks like a female.
Give up?
Just look their face, you get
Yeah. Madam over there? No.
No. Okay. Can I have, who has written this? I'm a good listener. Never say die. Sir. Sir. Yes. Do you know, sir? Yes. So can you just come and introduce yourself? Yes. Thank you so much, sir. Mike. Now you have to read your chit, okay? No. You first introduce yourself and then read the chit.
Good morning, everyone. Yeah, I'm Dr. Loyson. I'm assistant professor in general surgery. So I recently joined 2 months back. So good to know you all. Thank you. Hemodialysis. Yeah, Dr. Prajwal.
Okay. Big round of applause. Right. No, the thing is that all of us have 2 kidneys which do that function. That's why I was thinking what's so special about him, but still. Thank you. It's working?
Yes. Good morning, everyone. I'm Dr. Prajwal. I'm assistant professor in Department of Nephrology.
Yeah. What is your chit?
Silent person interested in communication skills.
Identify, sir. Spotter adu. Guess who could have written it? See, that's the thing. Many people fit that bill, especially men. Not me. I didn't put that shit. And I'm talkative. Krishna Sarala. He's not that person. No, guess. There are so many. 27 people are there. You can guess. Siri ma'am. Siri ma'am, correct? Okay. Round of applause. I think for the next time I should say keep a poker face also. Anyway, I'll keep that in mind next time.
Hello everyone, I am Dr. Siri Kandavar. I am an associate professor in Department of Anesthesiology. And my chit says from General Medicine Department, red shirt, thick frame specs.
Okay. So you identified. Finally, we have someone who didn't say I'm nice, polite, talking less. Okay. So we'll come to the end of that. We'll see how much of it. Yes, please come. Please come. Introduce yourself and read your chit.
Hi, I'm Dr. Nahel, Associate Professor, Department of General Medicine. My chit says, always have a plan B for my plan A.
Okay. No, sir, you have to guess who would have
Let me
written
see
it.
the face.
Yeah, you have to, please, you should not be giving away who has written it. Okay, unless it is very obvious, like how Nehal had written. Yes, who would have written it, sir? Don't look at me, look at them, ask them, find out who has written.
Sir.
Quickly. Drithiman sir, correct? Give a round of applause. You can put all the chits into this, which are used. Yeah, thank you.
Good morning, I'm Dr. Drithiman Shetty. I'm Associate Professor in Department of Pediatrics. And my chit reads, thoughtful to the extent of being lost, interested in philosophy and spirituality.
Okay.
With
Drithiman sir, ಅದು ಐಡೆಂಟಿಫೈ ಮಾಡಿ ಯಾರು ಅಂತ ಅಲ್ಲಿ ಎಸ್ಸೆ ಬರೋದವ್ರೆ ಓಕೆ ಮಾಡಿ ಓದಿ
Giridhar sir.
ಗಿರಿಧರ್ ಸರ್ ಸ್ಪಿರಿಚುಯಾಲಿಟಿ ಸರ್ Sir's
I
handwriting?
actually don't know.
Don't know? Okay. Who has written this? Okay. Krishna Sharan sir. Sir guessed it, right? Sir, idra ಒಳಗೆ ಹಾಕಿ. Thank you.
Good morning, everyone. I am Dr. Sharan, Krishna Sharan from Radiation Oncology. And my chit reads, an empathetic dermatologist. Now that should give me enough clue, but I don't know who is the dermatologist. Dermatologist.
Sir, dermatologist ಯಾರು ಇರ್ತಾರೆ ಸರ್? So you at least exclude who have finished and those whom you know. Then you guess.
Not sure. Not sure who is from dermatology here.
Oh, yeah. Empathetic dermatologist.
You are the one. No.
No. Okay. Give up, sir?
No, give up.
Not give up.
No, give up.
Give up? Okay.
Not waste time.
Yes. May I know who has written it? Yes. You are very close, sir. Thank you so much, Krishna, sir. Please come. Sir, Chitkodi, sir. Please.
Hi, good morning, everyone. I'm Dr. Sonakshi Mago, Senior Resident Dermatology. So my chit reads polite and generous.
That mostly defines most of us, I think. But you have to make a guess. You have to make a guess who would have written. Exclude people who have already finished. Some people who are not polite also. Hey, Papa said, don't. Pujita ma'am. She's very outright about it. She's not polite. Yes. Oh, your Papa sir. Give up?
Yes.
Who has written polite and generous? Okay. Please come. Yeah. Please put your chit into that. Please introduce yourself to the gathering.
Hi, I'm Dr. Shreyas Ray, Assistant Professor, Department of Urology.
What does your chit read?
I'm a left-handed physician in pink kurti.
Okay.
I think it's...
Very good. Excellent.
Medicine has plans. Medicine department has some plans.
Very good. They all color matched and came, I think. Almost shades of red. Yeah. Thank you. Sir, please keep.
Good morning all. I am Dr. Meghna. I am an assistant professor in Department of General Medicine. My chit reads poker face and sleepy in the morning. Niveda.
Anybody else? We can settle the score later during tea break. She's ever smiling actually.
No.
Give up? Okay, who has written this? Okay. Thank you. Please put the chit into that. Please introduce yourself.
I'm Dr. Akansh. I'm from Department of General Surgery. I'm a senior resident. And my chit...
Young aspirational. Okay. Young by age or young at heart, sir? Or madam? Okay, you have to guess, sir. Okay. Not him. Okay. Fine. At least at the end of this communication skill workshop, you should be able to... Who has to be able to find out who is young and aspirational, and all people who are there here, at least from which department they are, if not the name. May I know who has written this? Young aspirational. Okay. Please put in there. Please introduce yourself.
Good morning. I'm Dr. Landon D'Souza from the Department of Orthopedics.
He has got essay. Read.
Excellent critic and borderline narcissistic, tall, dynamic.
This if you are not able to guess. No, my first guess was sir only, still. Not narcissistic, but Papa.
Dynamic with a prominent nose. Good dancer and decent surgeon.
Good dancer and decent surgeon. Now that narrows down here. Okay. You were almost right, half right they were.
My intention was to kind of make people guess that. I'm Dr. Pujita from Department of Orthopedics. Yeah, and so I've got a very, like a single word answer, simplicity.
Simplicity. Ma'am, you have to guess, ma'am. Yaar anta helbek ನೀವು. Our handwriting. So, ma'am, you should know how Nirmal sir's handwriting is. Okay. Srinath sir. No idea. Okay, who had written simplicity? Can I have show of hand? Okay. Ma'am, please, the chit you can put here. Yes.
Good morning, everyone. I'm Dr. Niveda Ramesh, Senior Resident from Department of Psychiatry. So my chit says, last one to enter the hall today. So this, as I know, it's my co-SR, Dr. Yashwant from Department of Psychiatry itself, because I called him to come earlier. And he told me he went to Paneer campus.
See, their only communication gap was there. Yes.
Yeah, I'm Dr. Yashwant. I would have written the tallest, then I saw Nirmal sir sitting behind me. So I'm Dr. Yashwant, Department of Psychiatry, Senior Resident. Essay actually. Yeah. I'm a female surgeon working in ENT department. The next thing, I'm known for my facial features as I have a very small eyes and I love badminton. Someone is hiding behind, okay. It's Vaishnavi. Yeah. Sir. Oh, I didn't know the name.
Now you will know. Yes. Yeah. Okay, it's no problem. If you're able to recollect it, it's okay. That's fine.
Hello. Good morning. I am Dr. Vaishnavi Shetty, Senior Resident from ENT Department. My chit says, polite and ever smiling. I don't know who is it, but I'm just guessing it's because she was smiling throughout, so I thought it was.
You can ask her what is the secret behind her.
Ever smiling. Maybe that ma'am. There is no. No.
Okay. Got gender now. Yes.
Good morning. I am Senior Resident in Department of Cardiology. I would have written in even better if they would have told that they will announce it. I'm sorry. And I was also praying that someone who has written this chit should come earlier than me, because he has written I am from Department of Orthopedics and newly joined.
His is over.
Oh, sorry. His is over.
His is over.
One more newly joined. Department of Orthopedics means men only. So
No, not necessarily always. Okay. Yes, please put your chit in for that. Yes, thank you. Yes. Introduce yourself.
Good morning, everyone. Myself, Dr. Ansar, Senior Resident from the Department of Orthopedics. My chit is tallest person in the Department of Orthopedics in HEGDE, Nirmal Babu sir.
Very good. No doubts about that. Thank you for a very clear communication. Please come.
Okay, mine is, I'm Dr. Nirmal, Associate Professor from Department of Orthopedics, and mine says calm in the storm.
Okay. Sir, you have to guess, sir. Calm in the storm.
Calm in the storm. One is Srinath sir again, yes sir. Always calm in the storm.
Sir, allo ante, sir.
We have a senior most surgeon, might be he's so calm, he's sitting.
Calm alwa, sir.
No guess.
You have to say give up.
Please sir, you finished.
The
It's also
sir is
calm in the storm. Any anesthetist here?
They will calm the storm, sir.
Only.
Over.
So,
Siri ma'am is dead.
Nobody else? I can't guess.
May I know who wrote Calm in the Storm? Okay. Thank you for that. Chitti, you have to put it there. Thank you.
Good morning. I'm Dr. Suhan Shetty from Department of General Surgery. I'm a senior resident. So my chit says empathetic introvert.
Okay. Guess.
Okay. This is all group deals. Yes. Can you please put your chit into that? Yeah. Thank you. We have very few people remaining, I think.
Good morning. I'm Dr. Grishma, senior resident from General Medicine. My chit friends, I'm good with humans and pets.
Humans and pets. There are very handful remaining. Huh? Srinath sir. Pujita ma'am. Aitu, avrda aitu. Give up, okay? Okay. Yes.
Good morning. I'm Dr. Samantha from Department of Pediatrics. My chit says introvert and silent.
You have to guess. Give up. Who has introvert and silent written? Introvert and silent. Okay. Please come introduce yourself.
Good morning. Myself, Dr. Akhilesh, senior resident from radiology. My chit says, have an interest in general medicine and I am an introvert.
So many introverts, sir. You have to guess. From general medicine, there may be very few people. Correct? Okay. Yes, please. Huh? Medicine department has some deal. We'll talk about that later. Yes.
So, mine says lung doctor.
Okay. Giridhar, sir. Yes. No, you have to introduce yourself, please.
I'm Dr. Rohan from Department of General Medicine.
Okay, fine. Giridhar, sir. Chit Kalia. No, it's okay. Done. Everybody has this one. Srinath, sir is. Anybody else who's remaining? Krishna Priya, ma'am. Yeah, please come forward.
My chit says shy, soft-spoken and principled.
And? Principled.
Principled.
Principled. Okay, you have to guess. There are very few people who are remaining.
Ma'am.
Who? Krishna Priya, ma'am. She has not written it.
Yes.
Okay.
Good morning. I am Dr. Srinath Kamath, Professor of ENT. My chit says I am Associate Professor of OBG. So one OBG person is already excluded. So the one remaining is...
Krishna Priya, ma'am. Okay. Thank you so much, sir. I may know how many more are remaining. Overdone, sir, Daita. No, one more is there, no? Yeah, last one. I think by this, you introduce yourself, ma'am. There's only one person remaining. Two people are remaining. Sorry. My bad. Sorry.
Okay, I'm Dr. Krishna Priya, Associate Professor in the Department of OBG. My chit says, an introvert looking for and reading between lines. Sir?
Reading between the lines, correct? Okay. Sit, you can.
Hi, good morning. I'm Dr. Sridharan, Associate from the Department of General.
Sir has got essay.
Not able to read properly. Anybody is here from the ophthalmology? Okay. So, I'm known as a fun, happy, funny person, known to bake well, and known to have a bit more knowledge of ophthalmology.
Okay, very good. Thank you. Thank you so much. So we are done with all the introductions. Did you notice something when I asked you to write something about yourself? What did all of us write? Nice, introvert, silent, simplistic. But can anybody collectively recall and tell me what exactly I asked you to write today? Unique, identify yourself today. Okay, very few, I think only Meghna and Nehal and of course Nirmal sir, they were on dot because they communicated very correctly to tell that, their characteristics today as such what they were wearing, so it made it easy to identify. So even in communication, our communication needs to be very clear, and we need to, what we are thinking, often we don't write it, right? So this workshop is all about that, and I leave you into the able hands of our resource persons, sir. Over to you. Thank you.
Thank you very much, Kishan sir. So it's been a great ice-breaking session, and I'll try and remember most of the names. The whole idea here is we are here to learn to relate better to the patient, and for that there is clearly no fixed rules. There is a lot of theories, a lot of modules, publications and things like that, but it doesn't apply to everybody. So we have to make our own rules depending on the situation. The first thing I would like to say here is, it is not that experience matters. Of course, it does matter to a large extent. We get better at our technical skills as we get older, and we learn to read in between the lines. But it is some natural skills and body language which we innately carry with us as well. The other thing that happens to us consultants as we gray more and more is we can also develop attitudes, and we have certain bars. So the first, and of course, when it comes to academic and medical college environments, there are rungs of hierarchy. So that is when communications can also break down. So without going into why and the theory part, let us concentrate most on modules, and what we have in the first session is just a general talk about principles, maybe 5 or 10 minutes. Stop me if you get bored, and we will go on to each of you doing some kind of role play in situations that I think very general situations that we face on a day-to-day basis. I'm of course a not an authority on this. There are much more authoritative figures which will be handling, who will be handling breaking bad news and things which you know. So to say there are no rules, we often think we look great as communicating, because when it comes to determining treatments, we are telling technical things often. The important thing here is what are we perceived as. So that's why I put up this online shopping picture. This is how it can be a bit like that, which is why I think we've talked about this thing on videographing, because you may think, obviously you wouldn't say something unless you think it is right, but it is with you being watched around yourself 360 degrees to then reflect upon yourself how you come across as. And we've all known as staff, there have been more modules of late on training the trainer, which have been very well, kind of inculcated by the Royal College of England, where, you have cameras behind you, you have your cameras, your team sitting in front giving you feedback. And that's what I think we should do with today's session. So, India kind of recognized the importance of communication by the NMC in 2016 when they got that AETCOM. You're all aware of it. However, the UK had probably introduced it when I was there. It was in the curriculum recognized in a London university in right about 2008. What I think is important, what they have gone is developed 42 modules on this, if you look at the online website today, and we are trying to cover the important aspects in a few hours. But it is important that we train right from the beginning. When we train with doctors or to be doctors, we need to be trained on how to say to patients, importantly on what not to do. It is not uncommon that you have situations like this. We are discussing treatments, we are discussing pros and cons, and eventually something else comes in, takes the cake away. So what is probably important to learn first is what not to do. And particularly, we are all clinicians, we come to, I'll give an example here of taking a consent for surgery or any intervention. Even as a physician, you would be taking consents from patients for intervention. And now the WHO norms have come out. If you are doing the procedure, you have to take the consent yourself. It won't be recognized if your PG or your nurse or whoever it is takes the consent. It is important that I will just tell you my experience here from being abroad for a few years. In our systems, particularly in the academic setup, it might be accepted, but it is not accepted when it comes to the legal eye. In the UK, for instance, what I could see from the NHS, even 15 years ago, was the fellows who come in as junior doctors would not be half as good technically as our people are, because we go through very rigorous academic trainings. We are knowledged quite a lot as a training culture, and being high IQ individuals, we are among the highest IQ genetically in the world, and we know it as a country. But people across, as in native trainees from Europe, etc., were not very good when it comes to technically explaining information. That is what I realized first as a UK trainee in 2005, 20 years ago. But what they were trained at even then is what they were not supposed to do. A junior doctor would not fear, and even today we have to inculcate that culture. Please do not fear to tell your consultant what you don't know, because it then ends up into communication gaps or miscommunicating things to patients, especially when taking consents, which can then lead to medico-legal problems. So that aspect is important. There are, of course, various factors affecting communication depending on the culture followed, the health system, where money is involved, payments are involved, private hospital, healthcare, all that. Obviously, where doctor's time is involved, communication can be affected. Now, for example, in the US, it is predominantly a protection kind of environment because of the lawsuits and all are highest in the US. It is not antagonistic or seen as bad if a consultant tells you, my time is 15 minutes with you, my time is up, I cannot talk with you more. So, whereas in our situation, if you tell a patient that you're taking more than 15 minutes, they will see it as offensive, particularly in the elective setups. In the US, you can, the communication comes across quite a few people who see us and have consulted in the US have said that my communication was very negative. The doctor depresses you, telling you if I'm doing a certain surgery, so many things can go wrong. But even then, because it's all insurance, their conversion rates for surgery might be higher than us because it's a more structured specialty care. Ours is a more relatively unstructured general care where people do not, people approach the consultant directly. But we have to see the advantage that we have, that patients are actually getting a lot more for what they are spending here. In the UK, for instance, it's an entire national health system where any consultant will not be seeing patients who are not having appointments. There is no concept of walk-in. So when you go in the morning that you're going to see 15 patients, you can't see more than 15 or 17 patients, whatever it is, each patient has a designated 15-minute slot. The cushioning there is it's a national health system. So whatever it is, your team is there, everybody has accountability. Here we have teams, especially in the medical colleges, but the accountability to a large extent depends on pretty much the consultant. So we have a different system now where we are exposed to things from the world. We've got all the technicalities, but we have a lot of expectations to meet from people. So there are different challenges, especially because of the internet, that we have to incorporate things from the better parts of the world and probably do it at lesser costs as well. So, importantly, just a few principles. You want to build rapport. So you have to do something which interests the patient. That is where probably you develop your rapport. Now you want a certain thing done. You have to devise your way of doing it. And here there is no senior or junior, like I said. So, for example, you have somebody walking in with, an elderly lady who, you see is obese and make out she loves her food. You know the culture, you know the Mangalore culture. There's no harm talking about a little bit of, did you have prawn ghee roast or something like that? If you know. If you don't know, don't venture out saying that to a Brahmin lady. So things can be very, very fine out here. If you can converse a little bit in the language, it definitely makes a difference. It's not that language is very, very important, because you can still display a good amount with your non-verbal body language skills. At the end of the day, what patients want out there is, they don't see the big things we do. They don't see the achievements. They get distracted by the small complications. So you have to be very, very well, able to explain why things can go wrong in a subtle way. At the same time, take people into confidence. So a lot of things which are unsaid make a lot of difference, right from the way your room environment is, whether you've kept time or no, whether your team has unison, whether one member of the team says something different from all the others, can make a lot of difference. Right from the organization, the way your system is, how people have come across to people, to the patients, and so on and so forth. So, of course, there is no doubt that all those words matter, and we will be talking about it in modular situations. So, to go on from there, it is, like I said, again, junior, senior, doesn't make a difference. We will get to tasks and situations. What we want to do now is have 5 situations in day-to-day practice. So let us count about, for timekeeping, about 15 minutes per case, and we have very able actors and helpers, hopefully, who will help us carry it out. Bishwa, would you mind taking a chair and maybe coming here or something? So, I will explain situations to you, and we will take one situation per table. I think that is the better way to do it. So we want more involvement. We will break this up into 5 scenarios. So 5, these are all general scenarios, nothing specific. The technical part is immaterial as far as the quality of the discussion goes. What we are talking about is those 5 basic principles of whether you're listening to the patient, are you conveying things well, are you displaying your non-verbal skills well, and are you showing empathy. So we have the first situation there. Before that, the rules, 15 minutes per case. We want one table to primarily take up what came across. We will be enacting something for you in about 2 or 3 minutes. Dr. Kishan sir, do you mind keeping time and once we finish the first enacting, maybe 3 minutes or so, the next 8 minutes would be for one group to come out with what came out well, what didn't come out well in that particular situation. The other groups can then chip in with 4 minutes for one group, 4 minutes for the rest of the people. After that, while that happens, we want 2 or 3 people from that particular group to come and enact that situation again. So totally we'll take 15 minutes per scenario. Okay? So shall we go as 1, 2, 3, 4, 5? Is that reasonable? Oh, is this group 1? We'll start with 1 then. Okay. So group 1. We'll start first case scenario with group 1. So we've got an OPD situation here. The patient, you've got a cordless, right? The patient has come across with a problem, and the patient has been seen by the postgraduate of the consultant. This is a medical college. He is, he has been to other people for the same thing before. He's not terribly satisfied, and the PG has seen him, has prescribed something, but the consultant now walks in. Right, how there? Is everything good with you? How can I help you?
Sir, nimdu junior PG doctor nodide. He has seen me and he gave me some medication, but I am not very happy, sir.
Exactly what happened? See, you have a problem in your knee. It is a mild problem as far as I can see, and my fellow Dr. Ram has actually examined you well. I am very well aware of what exactly is the problem. I know you are walking around with some difficulty, but I'm sure this will get better over time. Why is it that you are not looking very happy?
It's been 6
Is it troubling you a lot?
Yes, it's been 6 months now. I had this injury while playing badminton in my hometown. Then I saw the doctor in Puttur. He also gave me the same medication, and it's been 2 weeks. I've not gotten better. Sir, I've got X-ray also. Your PG didn't see my X-ray also. Can you see the X-ray?
Oh, I thought I examined. I'm so sorry, so sorry. Let me have a look at the X-ray. Yeah, you know what? Initially, this was thought of as a hairline fracture, but actually these things happen sometimes when the joint gets irritated. You get a little inflammation, which might last for 2-3 weeks, but the X-ray is not bad. Trust me, it will settle down. Inflammation andre swelling bartade joint odage.
But I have been taking.
Kutkoli sir. No problem. Yeah.
I have been taking the same medication. ಈಗ almost 1 ತಿಂಗಳಾಯ್ತಾ ಏನು ಫರಕ್ ಆಗಲಿಲ್ಲ.
But this is a stronger medication. See, you've been to, I think, some general physician in Puttur. We are a specialist unit. This is a big hospital. This medication is much stronger than that. I think you're seeing it is because it is the same color. Yeah.
But
it is stronger. It will get better. Sometimes it takes time. If it doesn't get better, come back. We'll take a better quality X-ray or we'll do an MRI, okay?
So, ಇದು ಸೆಟಲ್ ಆಗುದಿಲ್ಲ ಅಂದ್ರೆ ಏನು ಮಾಡಬೇಕು?
Yeah, if it doesn't settle, we'll take a better quality X-ray or an MRI next time. Athwa nodva, if required, then we might have to go for surgery, okay?
ಹೌದಾ?
So, group 1. We are timing, right?
You can give them 30 seconds quickly, they can discuss.
Yeah.
Then come on.
So, we want you to discuss, come across with what came well, what didn't come well in that conversation.
The interview actually, the good things that happened was, one is I think the doctor displayed some physical contact with him, never lost his temper. Even though he displayed some impatience, he never lost his temper at any point of time. And he gave some time. At the end of the day, there is no denying that the doctor gave some time for the patient. Even though from the patient's perspective, it might not be deemed adequate. Under the constraints of time and schedules, I think we can give credit to the doctor for giving some time to the patient. On the negative sides, I think one thing is the doctor was not the physical cue. The physical cues were not good. Actually, I potentially found it threatening when he got up and tried to. And just when the patient was telling something, there was a bit of a threat perceived from from a third person's perspective.
Glad you picked it up.
Yeah, and other than that, he was dismissive of the patient's complaint, which I think again is not very unreasonable, because many problems are not solvable. Many problems are not solvable. Actually, all we can do is just reassure them. But maybe the reassurance could have been a little more convincing to the patient. Some use of inflammation and all might be misleading. But again, some effort was made to explain it, but not probably in enough detail. And maybe a little bit of jousting happened. Tiny bit of jousting happened where the Puttur doctor got some potentially unfair criticism for
Regarding the threat, I just recall an event which is actually an event. we had a professor in an ex-medical college where I studied. Every patient will do this, okay? He will do this to the patient and then stop. We know some does like this, but he does this. And one fine day, one old man made such a ruckus there. He spent 2.5 hours. How dare he touch my body? Means he has a habit of doing this instead of doing this. There's a difference between doing this. This is actual story. I know the person because he is my professor, and we had 2 hours just settling that grand old person who was next to him. I mean, that can happen. Sometimes what you try to be very good enough for, try to be very this much body can be, because he was trying to do something from your perspective is different, or somebody's perspective might look good. Individual variation perception will be there. Anything else? Yes, please.
X-ray.
No introduction.
I think that's the best. I think no introduction.
Exactly. That is the point that we wanted to make out as well.
How many of you actually go and introduce yourself when you go to casualty to see a patient? Please raise your hands.
Excellent.
Good. I specifically say casualty because, why did I say casualty? Anything else?
Because
Yes.
you are going to the patient.
We are going to the patient. Patient is not coming to us. We are going to the patient. Patient is not coming. Patient doesn't know who I am. If I don't introduce myself, definitely they will say tomorrow we went to the HEGDE medical, the PG chemist, how I went. That's it. Yes, sir.
Not allowed to complete patient's complaints.
Very good. Yes. In India, if you know, we have a very good study where doctors are known to put a break even before 15 seconds of patient opening the mouth. 15 seconds. You can, tomorrow you go back and see whether you really do that. I mean, for where I do it, right or not. 15, I don't even give that much. But then, if you really want to give a good hearing, please don't interrupt, at least for the first full stop what patient wants to put. For the first full stop what patient wants to put. Yes, Giridhar.
Frequent interruptions.
Very good.
Not check the reports carefully. Jousting. No plan. Better quality is a medical jargon. It will not convince the patient. Treatment plan was very obscure because first option was given better X-ray, then MRI, then again patient asked, went to surgery.
So if we are not clear what we want to tell, obviously patient will definitely not leave the place clear. They will become more confused. Best way is please make sure when you write your OP sheets or in your OPMR, a plan.
What is it?
There is a column. How many of you know there is a column which nobody else can see, only you can see it. Anybody are aware of that? We have created a column in the OPMR, only you can write, including your, what is the rate you have told the patient for the patient. There is a column, go back, OPMR C, there is a column where only you can see. If I go and see what Nirmal has written, I can't see what it is. So make sure that you write a treatment plan, at least for yourself. Forget about it. Next time when the patient comes, you know what you are told earlier. It just takes few seconds to document what you want to do. Yes.
Gadget distractions. Frequently looked at watch.
Yeah. Yeah.
Or why should you not look at the watch? What's the problem? Why you should not look at the watch? Any problem? Is that the only thing?
No. Directly telling the patient basically.
Yes. We are not. Fortunately, he did not pull out his mobile from the phone and then I on the box.
That will come in the next. That will come in the next one.
Compassion was lacking.
Compassion was lacking. Yes.
No, but at the same time, when the patient was disgruntled in the end, he got up, he went, he touched the patient's shoulder. So he did try.
But it was too superficial.
So what could be done to improve that, taken our day-to-day time constraints?
Yeah.
That is what we want next.
Yes.
Yeah.
Thank you.
Anybody else other than what he has told?
Yes.
Anything else? Quickly we go to the next scenario. Yes.
Yeah. What can be done in a?
We spoke to the patient about what the scenario is. Did we even ask him what he understood, what we have told him? Did he understand?
So this is called, what is that called as?
Constructive feedback.
You need to assess what you are.
Yes.
See, before the patient
Assessing.
leaves, did you understand? Do you have any other doubts? Anything else you want to ask? That is one single question. Do not let any patient get out of your chamber without asking, do you have anything else to talk? more often what happens, they would have come for something and you would have taken somewhere. Finally, they would not have, we would not have answered what for they are coming. So it's the best time to ask is, do you want anything else to be known from our end, or do you have any other queries? Please, yes, anything else? Pujita, you have anything coming?
Yeah, one pro was that when the surgeon spoke, he also gave respect to the postgraduate, saying so and so has also.
That's a positive one.
Yeah.
So yeah, we wanted some positives there also. One point to take also is, if you're postgraduate, all of us will have postgraduates, fellows seeing the patients. If the postgraduate is seen, I think it is our responsibility to know at least the name of the patient when we are walking in, and a little more about, what their situation is, how they are.
Yeah.
Fair enough.
That type of Ritik, Srinath, you have anything?
One positive point was, even though during the middle of the conversation, the patient party was offered a chair to sit.
Yes.
Yeah.
That is a very important thing. See, especially in casualty, you tell me, and how many of you actually offer a chair for the patient party? Can you make that at least from now on? We give an offer. There is an area, I thought we sit in that, we see patients in the trauma bay. I mean, little this side. There is a granite floor. I make sure that to at least give them 2 chairs and make them sit. There are, I know, in a casualty there will be more than 2. And sometimes you,
Actually, the table is so high, once you sit.
not that side, not that one, this side. That's what I said. For trauma, we people see on this side. I know there is a problem on that side because table is so high, it is acts as a barrier. For other people, for us at least, surgeons and other people, we have a small, which is of this side. We can sit on this side and ask them to give them 2 chairs and then talk. Make sure that you at least make them comfortable. Yes. We go to the next one.
The examination, patient was not examined.
That, yes, very good.
And at the end of the conversation, patient was told about the surgery, but exactly what surgery is required, that was not told.
We have just compressed it for a matter of few seconds.
Yeah.
So we start
Okay. We'll go to the next one.
I will go to the
Patient who's come, who has been recommended this doctor by somebody. He's basically been told by 2-3 people that he requires surgery, but he's quite determined that he doesn't want surgery. Yeah, and he's going to explore alternative methods and things like that.
नमस्ते कामत माम तू आमच्याकडे ना
आमच्याकडे नव्हे मामा. Dr. Ma'am, I have been told a lot about you. You know Ramamai from Kumta?
Kumta.
You operated on Ramamai's husband's auntie.
Correct,
Yeah.
correct. दोन्ही वर्ष झाले.
Yeah. Oh, Dr. Ma'am, she's great. She sits down and eats prasad at the temple. Yeah. So, Dr. Ma'am, you'll make my knee better, Ma'am.
Sure. We'll see. What happened?
See, about 6 months ago, you know this tennis club in Kumta? GM Kamath also told me about you.
Yes, he's a good friend. I often go to, when I go to Goa side, I take a halt there.
Oh,
He's a
Dr.
very
Ma'am,
good
you must make me better, Dr. Ma'am.
Sure. We'll see.
Yeah.
Okay.
So 6 months ago, I was playing badminton there.
Okay.
And that my son, he had peed on the floor. I didn't even realize. I put my, it is all because of him. I fell down, I heard a pop sound, and then my knee swelled up, Dr. Ma'am. I could not walk for 3 days. Then I went, they took an X-ray. Thankfully, Dr. Ma'am, no fracture. Oh, God has been very kind to me, Dr. Ma'am. But now I'm better, Dr. Ma'am. Now everything is fine. Now I can walk very well. Yeah.
Okay.
Yeah.
So the knee is better now, right?
Yeah.
Okay. How did you treat it? What did you do?
So I, you know that Dr. Padukone, he gave me medication. And my God, what a tablet, Dr. Ma'am, what a tablet. 2 tablets and my pain was gone.
Very good.
Then I went to, in Gokarna, we have a nice Ayurvedic center. I have been having daily, Dr. Ma'am, oil massage. Super, Dr. Ma'am, look, Dr. Ma'am, look. Yeah. It's absolutely fine.
Okay.
Yeah.
So then...
now, Dr. Ma'am, just tell me I don't need anything else doing to it. This report is there.
Okay. No, let me not see the report. We'll see the report later. Let me examine you.
So the doctor conducts a detailed examination. We don't have an examination couch here. And following the examination, he's seen the reports and he's now telling the patient.
So, ma'am, तुमच्याकडे at least 2 injuries आला. Okay. I've seen the knee. I saw the MRI. See, this is a mechanical problem. Now, तुमच्या कारवा तू काहींचं Kumta. Now from Mangalore to Kumta when you go, there is a big breeze comes, right?
Yeah. That bridge which fell down, Dr. Ma'am, last year. Yeah.
Did the breeze automatically got repaired or they had to repair it?
How can a bridge repair? It was water flowing under the bridge, no? You know the rain that comes in our area.
Correct.
Yeah.
So this ligament is like the breeze for the knee. So once it is broken, it is broken. So it is a mechanical problem. So there are various treatment methods which helps to get rid of the pain. But once the ligament is gone, it cannot regenerate or cannot repair on its own. So we have to do a small keyhole surgery to make it better.
Dr. Ma'am, no surgery please. You just touch me, do anything. I will take any medicine. Expense not a problem. You know, my father was in the same hospital. He got a heart attack, he got better. On the last day when we went, he got infection. And my grandmother also died in the same room. So I don't want to, I just came to see you. Dr. Ma'am, you just touch my knee and do something.
See, what has happened with your grandmother or your relatives, that is probably a different scenario. So I cannot comment on that.
Dr. Ma'am, I'm very scared.
Correct.
Yeah.
See, who is the one who wants to get better off, or who wants to get better with the treatment? Who wants to go back to badminton?
No, but you'll make me better, no? That's why I came to you from so far.
Correct. But see, this is a mechanical problem. This has to be operated. It's a small surgery. It's up to you. I cannot catch hold of you and do the surgery. If you want me to help you, then I can offer you the treatment. Otherwise, I do not have any magic medications which I can give you and immediately the things get better. Life has to carry on like this.
We'll stop here. Group 2.
Table 2, please. We give 30 seconds. Others can just note down what they have not told.
Yeah. So we'll stop at 5 minutes with table 2, 5 minutes with you.
I'm Suhan from Department of General Surgery. So this scenario had more of pros than the cons. So the only negative things were like, though patient didn't introduce, doctor didn't introduce himself. It seems like patient already knew the doctor and doctor knew, so the rapport was good.
Particularly that situation where the doctor doesn't need to introduce himself. Yeah. So you don't waste time because here you've got a very talkative patient. You want to maintain your time. Otherwise, you know, Konkanis, they will keep talking. I'm one of them.
That's the ideal patient.
Yeah, anyway. So otherwise, you know, there are patients. I'm not trying to discriminate, but anyway.
There was a deviation from the main topic itself at many points.
Precisely. That is where the doctor has to tone down, and that can be a fine skill.
Yeah.
So that can be taken as a negative point here.
Yes.
Because that conversation took a lot of time, and if you have 10 out of whatever in your consultations like this, you're going to waste time talking about the birds and the bees.
Yeah. That's what doctor could have actually put some effort to come to get.
So we want to discuss how to do that. So last time we didn't do a reenacting. We want somebody from your table to think, and for 2 minutes think how to tone down a patient talking. I'll be the patient again. You'll have to tone me down. Okay? Whichever of you. Okay.
So positives. Going to the positives. Doctor was conversing in the patient's language, so which is a positive.
In the sense,
Konkani.
or the flow of thought.
In the both.
But that flow of thoughts is not good also. That is not good also. You don't want to divert away from the topic as well.
It's both the things.
Things.
One is your language, because we get in SHEMA, we get quite a bit of Malayalam speaking
Yes.
language and other languages also. If you can learn few words and it really helps them, you may not be able to learn everything. For us who are there for 20 years, okay, we have reasonably learned enough to communicate. For newcomers, there are few very young surgeons. So you can start learning few words, okay? It need not be entirety. but then that will help to build a rapport.
That initial contact which makes the patient more comfortable.
Couple of words, it could be anything from their culture. Could be something about food, could be something about dressing style. At FRCS level, they English call this as brownie points. So you're not given marks for saying things, but you say, okay, you're 75, but you look so young. That gives them a nice feeling, that gives them a confidence to the doctor, even if you don't know the culture, whatever it is.
So next doctor chose to examine the patient first before seeing the report, I think, which is a very good approach. Though the patient offered for the reports first, he examined the patient in detail, then he gave a verdict. And he provided the very good analogy to make the patient understand why it can't be treated with the medications which was patient adamant about.
The other common problem which normally we ask is, you need to say something, for example, sir says you have to do an angiogram, and is it not risky? How are you going to tell in that, like an example for that?
Yeah.
You see, just give an example. Because this is a day-to-day problem. You will tell something, they will ask, risk will ask. They will ask, does it not have any risk? Now I am giving a situation to cardiologist. He comes for angiogram. They will ask, sir, is there no risk when the angiogram is being done? How do you explain in a common term language?
First, I'll not tell about firstly, I'll tell the benefit of the procedure. So, the benefit, if the procedure benefit outweighs the risk, so first I'll tell how will it benefit. So 95% it will benefit, and there will be a risk because every procedure do have, and compared to whether it is the acute or whether it is a
forget all of the technical part. I want you to tell in patients common day-to-day actions where he's going to take a risk for doing something. I'll just give an example. You want to tell, okay?
Taking a flight current scenario.
See, the patient would have come, say 60, patient has come to you. I just give you an analogy because everybody has faced the same question as clinicians. They ask you, is there no risk? What is the risk? How are you going to? Patient has come to see you all the way from Sirsi. Would have come in a car or a bus. On the road, they would have seen few accidents. Yes? Or it say, exactly, that is what I give. I'm just giving what I give. Because while coming from Sirsi to here, you would have at least seen 1 or 2 accidents or 1 or 2 vehicles being done. Or you would have yourself by, I mean, it's polite this time. I say by 100 times when you drive, once or twice you would have had a puncture. I don't say accident, but I say puncture when they talk to you. But other situation I say, you would have seen somebody else being. So there is a risk for you also when you come from there to here, there is a chance of getting whatever problems you can face. But likewise, but still you wanted to come here. The same analogy, like they try to give a Sharavati bridge, you can give a accident or something else. I'm just giving this one. Yes, next please.
So patient also mentioned that he has taken some alternative treatments, but the doctor chose not to degrade any alternative medicine. He kept quiet.
If somebody says I have done Ayurveda, I have done homeopathy, you just say those events. What is your response? Or they'll ask the other question commonly. Can I go for massage, Ayurvedic massage? What is your response? What do you do?
If you believe it, you can try it. If you believe it, you can try it. No harm. But I mean, that is provided the patient is not at extra risk of the delay, the damage due to delay. No harm in trying it. But in our experience, it does not work. If you feel that that will work, definitely.
This is one way of talking. I'll just put a pause because if I comment the next answer, what is your next answer?
I say I'm not trained in that. I have no idea about the treatment.
That is the answer we should come.
That's what we generally say.
We are trained in allopathic system. We are not sure Ayurveda or homeopathy works in the situation. But delay in coming back to allopathic treatment after going all around could cost you something. Are you ready for this? It's your choice. Hope you understand the difference between what Sharan said and what Vipin Babu said. Okay, next.
Also, patients seem to have high expectation from the doctor that he also mentioned if you touch it will, I'll be okay. I think the doctor handled it well and he gave the proper suggestion of treatment. Okay. And also he at the end of...
Common statement, you know what is it? You're all... Devru.
Yeah.
The moment the patient said you are Devru, please take for sure he is the next patient who goes to you.
Yes.
And I tell by my experience in my life, Only one case I have against me, the patient who fell on my feet when the mother died, and I have a case against him. Next.
And at the end, doctor explained his expertise, and he gave the option, and he didn't force the patient to take the option. He told, and he left the patient to make a choice. Take a choice.
Excellent.
Good. I mean, we should appreciate them. They actually picked up the exact points.
Yeah.
Can you have a round of applause for them? Any other team you have finished? Sir, from your team, ma'am, Siri, Vaishnav, you want to tell anything? Other than what they have told, it could be, or anybody else.
Now we need one more doctor.
Patient is not very clear with what his complaint is.
That is always the situation. That is always the situation.
And I don't think he's looking for any treatment because he's like, I'm okay, I'm fine with everything.
No, we know we get all those sorts of patients. So we can't.
You have no choice to select what type of
We have
patient
no,
you want.
exactly.
But you can use your time with caution with such patients whom you think are just a waste of time. But at the same, don't brush them off. There could be something else.
Yeah. Do you want to try being a doctor and I'll be the talkative patient again? Anybody? Should we do that again?
Come, no.
Anybody wants to?
It's all about learning.
Yes, let's do that.
Yeah, Babu, come. We'll give you a samosa.
You be the talkative patient. You be the talkative patient. Yeah. So he's the talkative patient.
Okay.
Yeah.
I hope there is no other
You go.
I hope there is no other comment to the previous
speak.
scenario. We'll close with that. Any others? Sir, 1 second. Just hold. You say.
When you want to pursue the patient, especially in an elective setting, it may not be in a single setting.
I will be the father.
To pursue the patient to follow one treatment, it may not be in a single setting. You can give the patient enough time to come back and take a decision.
How many of you actually, in reality, when you see your patients in outpatient, you suggest something? For example, you could suggest a surgery or you could suggest medical management or something. You tell a patient, can you just go out 10 minutes, take your time, discuss, and then come back to me? Raise your hand. Very good, very good. I mean, that should be the way. Because the worst decisions are taken when patients are there in front of you for the first time and doctor and patient are there without, they are under so much of duress. Please don't pressurize them to take a decision then and there. Give them a time, 5 to 10 minutes, let them go out in their private space, speak to whomever they want, have any clarification, come back, clear, and then go ahead. Anything else, sir? That's a very good suggestion. Thank you. Yes, we'll go to the next scenario.
Doctor, namaskara. Namaskara, doctor. Doctor, ನೀವು ದೇವರು doctor. என்ன ಮಗ doctor.
Namaskar, doctor.
Doctor, ಕುಮಟಡೆ ಸುಭಾಷ್ ಮಾಮ್ ಸುಭಾಷ್ ಮಾಮ್ ಗಂಟು ಫಸ್ಟ್ ಕ್ಲಾಸ್ ಅಂಡ್ ಡಾಕ್ಟರ್ ಮಾಮ್ ಯಾ ಹಾ ಏನು ಮಗ ತೊಂದ್ರಿಜಿ ಡಾಕ್ಟರ್ ಮಾಮ್
So doctor, 6 months back, I was playing badminton with my friends, and that day that floor was wet, and I fell down. I had a little tuck sound to my knee, and then it was very painful. I had to stop my game, but I did exercises, I did Ayurveda, I did some lepa. Now I'm better. See my knee is absolutely fine. I can bend and straighten. So in Madbeku.
So what is your complaint right now? What happened?
No, I had knee injury, but now it is better. I thought, I've heard a lot about you. I heard that with your touch, patients are getting better. My grandmother also had knee replacement surgery with you. She's running now. She's going to beach now every day. So she told me, I have to see you only.
Okay. So at present, after that pain has subsided, you don't have any other complaint after that?
I don't have pain, but I can't play badminton.
What happens?
Sometimes I just feel the knee suddenly slips. I feel like I might fall. So my dad told not to play.
Okay.
Dr. Ma'am, he's 25 years old. He's not even married. What surgery and all, Dr. Ma'am?
No, I'll just say.
He's not even married. 25 only. small boy.
We are not going to, I've not mentioned anything about surgery. First, I'll examine you. I'll see what the problem is and then we'll take it further.
I want to fix his marriage for next year. I hope we can fix the marriage. Yeah.
I would have actually cracked a joke over here to the patient, but I don't think knee has nothing to do with the marriage. The other part should be okay. So yeah, I'll examine it. So and so. I did a test where I just pulled your leg and I see that there is a little instability in your knee. There is a ligament that holds both femur and the tibia together, the thigh bone as well as the bone down. I think that is stone, but I think I can confirm it only after getting an MRI done.
We have MRI,
Oh, okay.
Sorry, we didn't show you.
Okay, thank you.
No, because they said in that MRI that ligament is stone. That's why we thought you will make it better just like that.
See,
I'm really worried about him.
The MRI clearly says that there is a ACL injury, anterior cruciate ligament. Anterior cruciate ligament is basically a ligament that connects your thigh bone to your bone on the leg. If that is torn, it usually doesn't repair by itself, like you told earlier. The same sentence I'll use, the same thing that he told earlier. So surgical treatment is advised, but there are people with ACL, torn ACL, who doesn't undergo surgery. They strengthen their muscles in such a way that it doesn't, cause further damage. But that is not a complete treatment, but you can try that as well. But there are few cricketers I know who's after an ACL injury is not undergone an ACL repair, but they're not playing actively right now. But they're living, because they also didn't want surgery. But as a doctor, I would suggest you to do the surgery. But if you're not willing, we can opt for the other thing as well.
Doctor, I'm a bit scared of surgery. My uncle had a heart attack in the same hospital. And my granny after the surgery had little pus coming from the knee. So I'm very scared of surgery. Can we not manage this without surgery?
That's what I said. Managing depends on, you need a complete treatment or you just want to manage and go to it. If you want to play shuttle and further, I think you need to undergo surgery. But if you can go without playing any games in future, you can manage without surgery as well. And talking about the cardiac and the pus, every situation is different, everything is different. We cannot be same. So you don't look like your grandmother because you are different individual. Exactly. So treatment and the outcome can be different for different people.
Okay, we'll think of it and get back to you.
Please do. Thank you.
So what was the plus point in that?
I think the first appreciation should go to the delegate coming and suddenly walking.
Well done. Really well done.
If Nirmal can actually do this every day, he's going to overtake me for sure. Okay, yes.
So you saw how he gave the options. He was with the patient and then he said, if you really want to achieve a level of activity, this is what is better. So on and so forth. Shall we go to the next one?
Any other critical comments? Because there is, I think most of the things are discussed. Which is the next group three? You have anything to comment? Yeah, Siri, you should comment. Your best friend is comment, doctor.
One thing is doctor offered seat even to the patient party who, that is
very important. You offer seat not only to the patient but also the patient party. That makes really sense. Okay.
but did he introduce himself that part?
Yeah, that depends.
Yeah, because
we discussed earlier. If you are going to a common area, you need to introduce. They are coming to your consultation room with your name appointment. Might skip out. Yes.
Then few medical terms were used. Femur.
Whatever we do, I think it is everybody's inherent problem that we cannot conclude a conversation with the patient without using a jargon. Anybody is fully confident that you can do consultation without putting a medical term? Very difficult, I know. But what you can do is you can reduce the number of jargons what you use. Okay? You cannot get away from it. There could be some words you may not find a word from it. Alternatives, or the alternative word could be very difficult for them to say.
In between.
I mean, understand what you're trying to say. Yes.
And he gave alternate options, treatment options.
Correct.
Yeah. Then.
Yeah. So we'll quickly run to the third because it is the same thing. The next is about medical jargon, really. So we will try and see what alternatives we can get. We would probably like another role play for the same situation. So here you have a patient and the patient's son. So here is the elderly patient. You want to? Yeah. Anyway, it's okay. It's okay. He's the elderly patient, and this is the patient's son. Okay. Yeah. Okay.
Namaskar, doctor.
Namaskara. Namaskara. Please sit down. Yes. How can I help you today?
Doctor, bala pain undu.
Oh.
Red divasai pain undu.
Oh. Sorry, Anna, Tulu वंते बरपुज्जी वंते बरपुंडू मैं हिंदी में बात करूं आपको समझेगा
रिपोर्ट नोडिद्रा
मैं आपको थोड़ा हिंदी समझेगा हाँ नमस्कार अन्ना थोड़ा मैं कन्नड़ा ट्राई करता हूँ हाँ तो आपका सिचुएशन मैंने अन्ना को पहले देखा था मेरा टीम ने भी देखा है तो हम बेसिकली ये सेकंड सिचुएशन में मिले हैं उनका एंजियोग्राम किया है अभी एमआरआई एंजियोग्राम विद कॉन्ट्रास्ट करना पड़ेगा स्कैन मालपले स्कैन मालपेरे उंडू
सर्जरी बोर्डू
वो डिपेंड करता है अन्ना वो बेसिकली स्कैन में देखना पड़ता है कि ब्लॉक कितना परसेंटेज है अगर 80% से ज्यादा है तो आपको सर्जरी लगेगा अगर 50% तक है तो स्टेंट में हो जाएगा
ಅಲ್ಲ ಅದು ನಮ್ಮ ತಂದೆಗೆ ರಿಸ್ಕ್ ಆಗೋದಿಲ್ವಾ ಯಾಕಂದ್ರೆ 80% ಬುಕ್ಕಲ್ಲಿ ಓದಿದ್ದೇನೆ ಅಲ್ಲಿ ಮೊನ್ನೆ ನೆಟ್ಟಲ್ಲಿ ನೋಡಿದ್ದೇನೆ ಹಾಗೆ ಮಾಡಿದ್ರೆ ಇದಾಗ್ತದೆ ಅಂತ ಹೇಳಿ ಇವರು ಪಾಪ ಈಗ ಅಟ್ಲೀಸ್ಟ್ ಓಡಾಡ್ಕೊಂಡಿದ್ದಾರೆ ನಾಳೆ ಮತ್ತೆ ವಾಪಸ್ ಹೋಗುವಾಗ ಇಲ್ಲದಿದ್ರೆ ಎಂತ ಮಾಡೋದು
ಸಾರಿ
ರಿಸ್ಕ್
ಸಾರಿ ಅಣ್ಣ ಗೊತ್ತಾಗೋದಿಲ್ಲ ಒಂದೇ ನಿಮಿಷ ನನ್ನ ಕಲೀಗ್ಗೆ ಹೇಳ್ತೇನೆ एक मिनट आपको मैं ट्रांसलेटर लेके आता हूँ सिस्टर को लेके आता हूँ हाँ सिस्टर ने सो आई गेट द सिस्टर गेट हर टू ट्रांसलेट एंड ऑल दैट सिस्टर ने मेरे को समझाया ये इसी वजह से डेफिनेटली रिस्क है लेकिन इनका सिचुएशन ऐसा है कि इनको अभी पेन हो रहा है ना अभी घर में बैठे भी उनको पेन हो रहा है तो वो सिचुएशन में हमको रिस्क बराबर जानने के लिए ये एमआरआई विथ कॉन्ट्रास्ट करना पड़ेगा कॉन्ट्रास्ट के बाद ब्रेन का पूरा स्कैन करना पड़ेगा ब्रेन में खून पहुंचता है कि नहीं देखना पड़ेगा हार्ट में खून पहुंचता है कि नहीं देखना पड़ेगा उस हिसाब से सर्जरी में ऑपरेशन थिएटर में लेके जाना पड़ेगा कि स्टेंट में होएगा वो हमको पता चलेगा ऑपरेशन थिएटर में लेके जाना पड़ेगा तो उनको यूरिन रिस्क का इन्फेक्शन है वहां भी कैथेटराइजेशन करना पड़ेगा
ತುಂಬಾ ಖರ್ಚಾಗತ್ತಾ
ಅನ್ಸುತ್ತೆ
नहीं अभी खर्चा का हमारे पास ऑप्शंस है हमारा हॉस्पिटल में बहुत सारे कार्ड्स एक्सेप्ट होते हैं आपका आयुष्मान में भी आपको 50% कंसेशन मिल जाएगा हमारा डिपार्टमेंट है आपके पास जो है वो देखो मैं डिटेल में आपसे बात करवाता हूँ
ತುಂಬಾ ರಿಸ್ಕ್ ಕಾಣ್ತಿದೆ ಬೇಡ ಮಗ ಬೇಡ
ಹೋಗುದಾಗದ್ರೆ
ಹೋಗು
ओके ग्रुप 3
Language barrier, translator.
No, this is the third one. We'll do this quickly.
There's not much more.
Yeah.
Yes.
Yeah.
One is
two more actually. Whatever. We'll do one. Yeah.
One more page.
Fair enough.
Yes.
did not introduce himself, sir. He was respectful but did not introduce himself.
Okay.
It was a language barrier.
Language barrier. Now, how do you overcome your language barrier? That's the common problem what we have in KSHEGDE. Yes.
This is exactly what we wanted to highlight here.
We keep the translator inside the room than going out and
Yes, so that is called planning before the patient comes to you. If the patient is a Malayalam speaking or patient is a language which you don't speak, it is ideal to have a translator. You may or may not use a translator, but it is better to keep a translator. Introduce them that if there is any communication problem between you and me, this translator is there to help you out. Okay? It's good to have before rather than call it between, but the least you can do is call at least later.
So what we do at our setup is, when somebody comes, we tell them, these are the languages we can talk briefly. Sometimes what happens, patient will be talking some different language which might be difficult for the surgeon. So we tell, okay, I have got so and so person. Sometimes, our fellows also speak multiple languages. So you tell them, okay, I know this much. If there's any help, I'll take it from I'll get help from my fellow. So patient gets that confidence, okay, the team has fully equipped with language, take care of the language barrier as well.
Another thing, language barrier, yes sir.
Ask the patient party whether they have understood what they are told.
Yes.
That's a nice one, actually.
The other thing, commonly the language barrier comes is when we take the consent. I think most of the time when we take consent, it's better you have a proper person who is going to tell, because otherwise the expectations of the patients and your deliverables may not match at the end of the day. Yes?
A complex medical and technical terms were used, sir, which was not a...
Yes, so what do we do about it?
Sorry, I would rather think the other way around, even though the discussion had a lot of...
Basu Prabhu, I'm doing a lecture. Can I call you back later? I'm doing a lecture. Yeah, nothing urgent, no?
No, it all depends on the
thank you,
perception.
thank you.
For some it could be very complex diagrams what we use, for some others he was actually trying to put it as simple words as possible.
Should be asking the patient party whether he has understood what he has told.
That's a good one.
That's a very good one, reflecting whether they have understood or not. Yes.
Good thing is that understanding the situation to the patient, whether it needs urgent attention or not. It was
Okay, right. Anything else?
Financial concerns were tried to address. Were tried to address with a possible schemes and all. That was very good thing.
That is a common situation what we all have. The major problem at our hospital, what I recognize is, patient comes with the perception that everything will be free, because it is been known at certain places that they get it under HEGDE, but during discussion you realize that that is not covered, or it is partly covered. How are you going to address them? There could be so many ways, each doctor has their own ways of addressing. You can even take the help of the insurance department, the counselor. Some of the departments have counselors, Cardiology has, also has, fortunately more departments. Those are the people who are going to help you out with facilitating what treatment they need. They will get in spite of whatever little financial, everything cannot be solved, partly can be done. Anything else? Any other?
Just to add one point with regards to using translators. Should we use translators or interpreters? We need to use translators, not interpreters. And that's the instructions we need to give to the translator, that you tell what I am saying to the patient as I say it, and reply whatever they are replying. As they reply it, you want to translate and give it to me. I will do the interpretation.
Because
so that's an important.
When they use a postgraduate as translator, they actually become interpreters. I don't know how many of you I have experienced that. Especially when you use a postgraduate as translator, they invariably become interpreters. They will put their masala into that and give it. Idea is to have a staff nurse or somebody else who have not much of knowledge of what we do. That will more translation, less of interpretation. Anything else? Yes, please.
So I think when we explain about these procedures, we can try explaining them with some non-verbal communication like diagrams.
Some diagrams, some models, computer, electronic things.
So
absolutely.
Give them more time to process what's actually happening
Yes.
and arrive at a better decision.
That's a good one.
That's a very good one.
Yeah.
Please make it a habit, at least. See, we don't have systems everywhere. I mean, you may be sitting in a LT, you may be in a casualty where you may not have a system to show an actual picture of a femur or an actual picture of heart. Okay, some of them have an actual model. You can have a mobile also show them pictures. That's one way. The simplest thing what is available is a white paper in front of you and a pen. You try to draw a simple diagram, show them what is being done. As you all know, those pictures will be there permanently. Permanently in the patient's brain. What you speak may not be there when you go out.
Correct.
Okay? Make sure, even if you want to write one or two complications in the same picture, write it. That will help you out to facilitate discussion later on if there is a complication.
Yeah.
That we have told and we have documented.
And there is little downside of digital uses of devices like telephone, phone or computer. Sometimes it can be unknown also. So the patient might perceive it in a negative way that the doctor is least bothered about my problem and stuck to his phone. So make sure it is very clearly communicated. So it's a very thin line. You want to honor the patient and realize you're trying to help the patient, but it has gone in a negative way.
At the same time, Nirmal was showing his phone. You know, people who ask about Google can be counteracted with Google. You know, in the sense, show them, you know, you can vote for yourself and show them some pictures from your phone as well.
One last. Yeah. So the biggest fear for the patient was risk. So we did not address the risk actually. So a majority of the risks which are associated with the procedures can be tackled, and we should always emphasize that we have a efficient team and all the good equipments to tackle even the complications, and even the whatever complications are majority are minimal. Only thing they think that risk is death. So that we can address in that.
Okay.
Yeah.
Fantastic.
Last one information, because all of us are in HEGDE. How many of you are aware there are places in HEGDE hospital where there is both audio and video recording? 1, 2, 3, 4, 5, 6, 7. Can you tell where this area is?
The pre-op area near the changing, the heat is changing area, there is a outside ICU. When you come.
One area, correct. Second? Not there.
Outside the MCU.
Huh?
Counseling room is outside the
Yes, it has. 2. Then there is one more.
Outside the special ward, pre-op area also, there's one.
That's the same thing. That's the same thing. There's one outside near that PICU on the way, the typical. There is one more there. These are 3 areas. Currently, you have both audio and video recording. Why is this important? You would have promised something, you would have told something, tomorrow something. There is something for us to another backup.
Yeah.
Okay, that's the reason. In case you are expecting some problem, please instruct medical superintendent to retrieve and store whatever you are told for your future reference. Tomorrow you only have to save your nobody.
But
again,
doing that, potentially reaching the confidence.
No, you have to tell. No, that's what I'm trying to say. By 5 days, you tell you are under recording. You have to tell.
So
I have gone one step further. People don't believe. I have one in my clinic.
yeah, that's a very good one. Yeah. Oh. Yeah. No, but
It is against. I don't recommend this. It is not as per ethics, but I am doing for some other reasons that I have it.
no, but what is acceptable also right next to our ICU where critical things are taken. I'm sure we'll cover it in Dr. Yeah. So, or you can have it in OPD where you're making decisions. Every OPD, a good equipped OPD can have a counseling room with a camera there.
And you
So,
should ideally put a board outside this room
is being recorded,
So that
which is
we have-
perfectly acceptable.
What to do about the other way around? Like if the patient is recording you.
See, there are 2 things what can occur. Sometimes patient comes with hidden things which you cannot recognize. Okay, there is no way you can recognize that. You can't help it. But somebody is openly recording. You know they are holding like this and recording. You can tell them, since you have not taken my permission to record, I would not like to. But if you really want, then yes, you should take my permission then. When you talk with the live camera, you know what you are talking. They can't simply come like how we can't take and directly take their recording without their consent. They also can't take recording without the consent. Somebody has a different perspective. Harsha?
I myself usually say to the patient, you can record if you want because a lot of information we have been given here, you might not be able to recollect. But please promise me that you will not share it with them.
That you can.
You cannot.
They're unable to share.
No, finally it is.
WhatsApp next is in the
Finally
WhatsApp.
the trust is what works. It's not the.
Krishna sir, I can just beg to differ. Because many times they offer a second opinion. They would have recorded some doctor's opinion and they play it in front of us in the consultation room. That they will do. Once they record, you know that it's all over the world.
Correct, but at the same time, finally it is a trust. And
No trust.
as long
No.
as, as long as you are not doing anything, you are not saying anything bad or behaving badly or doing anything in bad intention, I don't think you should worry about it.
No, that's a different thing, but they will share it all over the world. And second thing,
If they share the very issue, what you told, as it is, there is no problem.
But
the problem is they can anytime share it.
Sir, in this generation of AI, I think you should not even ask them, because these guys can even edit the video.
one round of, I wanted to ask.
Yeah, exactly. So with this artificial intelligence going around everywhere, I think that is another thing that we'll be scrutinized for.
Yeah, and one more thing is they can take it easily out of context.
Yeah.
Let's discuss about the
Anyway, great. We'll, for the interest of time, we might have to wind up a session here. Couple of comments from people. What I was going to be a busy consultant with phones in my earphones here as I consult a patient who had come on time. Vikram walks into the OPD saying, "Hey Yogesh, I need you to see my mother. Can you see her now?" And here is a patient who is slightly breathless. Okay, so all this happens to us from time to time. You know, somebody who's waiting, we need to see some colleague's mother, something like that. So how do you tackle this? Some points. Okay, great. Anything else?
If the patient you are seeing is sick, you can always tell your colleague that.
Precisely. So if the patient is distressed, the colleague should also understand. It is important because the colleague is a fellow doctor as well. We appreciate that he's busy, but at the same time a sick patient requires that person who's already in. Anything else?
We should explain them precisely when we will back, maybe 5 minutes or 10 minutes. rather
Correct.
than like-
Correct. Take their permission and handle the situation as the case may be. Great. So thank you all. I hope this was a useful session. Yeah.
Number one, avoid counseling on phone. The patient relative will be there and they'll say, "My father is there, will you please explain to him?" Avoid that as far as possible. Be open, tell them we are more than welcome to let anyone come inside here, but it should be face to face. Rather than, or they say, "My doctor is there in so and so place, can you please talk to him and explain to him?" Avoid talking to anybody on the phone because you can't see that person. That's one. Second thing is, when you're assessing the understanding of the patients, don't ask close-ended questions which will only give you yes, no answer, like "Mansalai," you will get an answer saying yes, which he may not have understood, but he will be thinking I should say yes. Ask them what they've understood. So ask them open questions so that they can't just answer yes or no. And the third point is, you saw Yogesh touching Nirmal's feet saying, "Devru, Devru, Devru." So don't get flattered if a patient calls you God and something goes wrong. It takes very little time for them to reverse the letters.
Right? You're staying there after that? Okay, right, okay, fine. Before going to the next session of breaking bad news, let me ask you, how many of you have not broken bad news so far? I guess everyone has broken bad news, right? Okay. In the next 90 minutes session, what I am going to do, first 10 minutes I will just talk about why we need to go through this process, what is the framework we can adhere to when we break the bad news. And next, we have got 5 groups. There will be 5 scenarios. And the first the session Yogesh and his team enacted, here you guys are enacting and we are criticizing the rest of the members. So the scenarios we will give you after my session, the brief talk. So what is the most thing bad about breaking bad news? It's always not easy. It's never easy rather. And doing it well is always an uncomfortable act. So what is bad news? So many things you come across, but bad news in a clinical scenarios, condition or scenarios, any news or information which affects adversely and significantly to the patient's views of their future. It could be a diagnosis, it could be a poor prognosis, it could be a treatment failure, it could be a surgical complication or transition into a palliative care. It could be a situation where there is feeling of no hope. Especially the oncologists come across very often. And anything which upsets their lifestyle. So breaking the news, for example, for a MRCP clinical scenario, the communication skills station was breaking the news of a type 1 diabetes in a 13-year-old boy. Why that's bad news? Of course, it's the lifestyle completely upsets from that teenager. So why it matters? So already you talked about the doctor-patient relationship, how it will affect in terms of the interactions and relationship with the doctors and patients. And communication is the key. Similar to the breaking bad news, it is very much unavoidable. Many doctors try to avoid this telling the truth to the patient. At the same time, many families try to avoid to hear those news as well. It's often difficult. It's more than just duty. Some people say that let the counselors come and speak to them. Refer to the psychiatrist team to come and talk to the whatever the bad going to happen, the cancer diagnosis or the going into palliation. That's not solution. Each clinician, whichever specialty they are in, they should be equipped with the breaking to break the bad news. And remember, poorly handled conversation will be remembered forever. At the same time, investing good time to break a bad news will develop a very good relationship for next few months or weeks or long, whatever in oncology I'm talking about. In the rest of the specialties, it may be a long journey, but the foundation of that journey, you will put it at the time of first interaction of breaking the bad news. So, working up, doing it in the right way is extremely important. What are the shortcomings? You must have seen quite a few videos of breaking bad news in the YouTubes. Most of them are from the Western countries and developed countries. But in India, the situation is quite different. Everyone will agree because of various reasons already mentioned. So the biggest problem we face is time. But at the same time, some of us keep on telling time, spend more time in the canteen and have a cup of coffee. But when we come to the declaring or breaking the news, we don't have time. Understanding the patients and parents. So that's extremely important. We assume things about the patients always. We are judgmental as well, so they may not understand. They are Ayushman scheme, they are not able to pay. Yesterday I had a conversation when saying about some complication happened following a cardiac angiogram and developed a large DVT. And of course patient is extremely anxious, he had started going up and various other problems. But the doctor felt that parents are, patient and relatives are too much troubling me. I am not getting anything more by spending more time on that. And I wouldn't agree for whatever that doctor said. We will discuss during the scenarios. And the already mentioned, the first picture was, we see more of litigations, I wouldn't say litigation, rather than fighting, in the quarreling in terms of in the emergency situations. Why all this happens? Because we are not equipped in the breaking the bad news. And we are allowing the juniors to declare the death, juniors to break the bad news. That should not happen. The senior most person in that team has to take the lead to break the bad news. Poor communication in the team communication. So what one person, the assistant professor says, the professor will not know. What the senior resident says, spoke, the other team members will not know. So we don't document, we don't communicate each other in what exactly. When it comes to a private care, we phone them, what did you tell, what was the conversation you had with the patient, but we don't talk about that in a case of government settings and the medical college teaching hospitals. No follow-up plan. Now, Vikram earlier said that we need to giving time for the patients to allow to make a decision. Here, we need to have a follow-up plan. After breaking the bad news,
invariably we need to have a follow-up plan, at least follow-up contact, because they are quite distraught after listening to the news, and after going home they might speak to various people. There should be some number where they can get access to the doctors. When it comes to India, apart from these, family-centric decision making. So here, patient doesn't make decision for themselves. Somebody else makes decision for the patient. So sometimes you have spoken to the patient and to father and mother. They agree whatever you say. But some relatives pitch in and the situation completely goes haywire. So you need to know the patient's autonomy, right to information, and it's a balancing act. You can't deny the family feeling as well. So you need to negotiate it such a way that there is no conflict. Patient literacy barriers. So many of the patients are illiterate. Now in the Dakshina is very good and Kerala is, most of them are literate in that matter, but some language barriers will happen. Stigma around the illness and death, especially cancer and other problems. Ethical conflicts with regards to the informing to the patient. So many of the times whenever you go a cancer or anything, please don't inform to the patient. Please don't inform to my wife. So this is a common scenario. How do we go about that? Practice of therapeutic privilege. This is something common in India. The family feels that if you break the bad news to that patient, then the problem is far more than the treatment. So that's why called as therapeutic privilege. So again, we have to negotiate it that. And truth dumping, this is many doctors we do. So give all the information whether they want to receive it or not. Then we are clear. We have told everything to the patient. We have done. So this is kind of feeling many doctors will have. What are the barriers to the breaking bad news? Not sure what the patient is expecting, not sure what we are going to tell, we don't know how to deliver this news, and lots of emotional impact. And the doctors would have given very optimistic, that's very good scenario. Ella chanagagtade, ಏನು ತೊಂದರೆ ಇಲ್ಲ, ಏನು worry ಮಾಡಬೇಡಿ, very optimistic picture. And you are the one again had to go back and tell the breaking bad news. So where are we? So that all the big barriers and causing troubles. Which is considered as hardest part of breaking bad news? Can anyone tell? Initially, okay. Initiation, anything else?
Dealing with patient parties' emotions.
Okay. Hardest part is when we talk about, look at, when enact the scenarios is keeping silent, allow silence. When we break the bad news, there will be emotional reactions. It could be a denial, it could be acceptance, it could be a cry, the non-verbal cues from the patient. We keep on talking, but we need to stop there. Allow silence. That is the hardest part in a breaking bad news. So various protocols are there when the just framework. If you have got something structured plan in your mind, you can deliver in that way. So the most critically appraised and evidence-based is the spikes protocol. Then ABCD, the announcing, building rapport, communication, declaring, and empathy. Breaks also similar, background check, rapport, developing. All these are similar each protocols. So, but the most important here is voice control. We should be very in soft voice, but doesn't mean that we are submissive. Some people, doctors will, as if something they have done the wrong thing and going and telling very soft way and to the breaking bad news. That's not. We need to be assertive but not arrogant when we what we say about voice control. And body posture, it's always at the level of eye to eye. We should not sit and they should not stand. At the same time, they should not sit and we should stand, and it's kind of patronizing them as well. So the posture, if the barrier is not there, that would be very good. Open up posture and talking to them. And nodding. Whenever they say, we have to be active listeners. So we have to the active listeners, not just listening, nodding, and eye contact, good eye-to-eye contact. With this background, we'll just talk about the spikes framework. In the spikes, S stands for setting up of the interview, the setup. So in that, you need to have a very quiet, confidential, private room. If it is with the AV, audio-visual recording is there, good. And you keep your mobile at least in a silent mode. So that should be, the environment should be. And when you go and greet, if you already know them, had a few conversations, there is no need to introduce. But if you are meeting them first time, and then you need to introduce yourself, sit down and make them comfortable. And the participants, you need to know the patient and family members well. And you need to have an adequate time. The one thing which you cannot compromise is time. I'm sure everyone is complaining about time. As I said, investing time at the time of breaking bad news will help to it's a foundation to the further treatment plan. It will be very, very easy if you do it in the first instance the right way. So, P stands for perception of condition or seriousness. So, we need to know how much the patient knows. So, when Yogesh did the first session, no one has commented that. He came up and the patient was telling about you had a knee pain and how is it and etc. But it was kind of, it wasn't open-ended questions such as what made you to come here. He should narrate his story. You need to listen to the story. Many of the times 2-3 minutes, but it look as if it's 5-7 minutes because we are not a good listeners. So allow them to tell the story, then you address those issues. So here you can ask how much you know about your condition so far, what you have been told so far. So even whenever you do these things, perception and etc. I would say always, Vikram also mentioned, it's always better to speak to the language what the patient knows if you can. There is no one-upmanship. We don't need to speak in English to them, completely different. So always, even try to speak few sentences of their native language. That is important to build the rapport. And accept, please doctors, accept the denial from the patient party. So this is, many of the times they don't. It took for me almost 2 weeks for the patients and relative to convince a palliative care setup from the cancer point of view, second, third relapse. But it took 2 weeks, but I pursued. It was so much stress for us. Doesn't mean that at the end it was good. There wasn't any complaint. They accepted the truth and moving on. So what I'm trying to say, in the initial 2 weeks was denial. Invitation from the patient to give information. So this is again in India very, very important. How much information patients wants to know. We can ask them. They know that some test we have done. They are expecting some results. So do you want us to tell all the results and etc. Majority of them, they want to hear from us. So usually you give them information. Some they don't want to know. If they don't want to know, fair enough, we will tell. Usually at that setting, they may want to know it later. So the K stands for knowledge. So this is the most important part of the breaking bad news, giving information in the right way. So knowledge, warning shot means always whenever we say they're expecting, you need to prepare them. Nimma blood reports nirikshe reeti illa. Is it serious? Yes, it is serious. We don't need to make it trivial. If it is serious, it is serious. So open up those questions, warning shot, need to be clarity. You need to be good with your subject as well. There will be a lot of questions with coming to the particular, whatever the very alternative treatments or opportunities. So you need to be good at your topic, what you're going to talk. Aligning means if the patient knows something, if you already talked to them, in the previous setting, you can continue from where you have started. So say again for in oncology, we did say that there is some problem with your back of spine, there was a mass. So from there we have done the biopsy, it is showing something. So start from there. Chunking means give small information, don't bombard with the information, give couple of sentences, wait, then give couple of, don't keep on asking, are you with me? I know how you feel, I know how you feel. So this, don't keep on telling that. Once you can mention that, and honesty. Don't know. No need to pretend. The E means explore emotions and sympathize. This is also extremely important. Observe the patient body language, observe their reactions, identify those reactions, say, I know it is so upsetting you, ಎಷ್ಟು ಕಷ್ಟ ಆಗ್ತದೆ ನಮಗೆ ಗೊತ್ತು, here we are for you to help, and validate those feelings and tolerate silence. When they start crying or anything, don't talk. Please wait, don't talk. And what I feel, if they don't cry during the breaking bad news, that means it's not right. In the sense, there will be some trouble in the future. Not to make them cry, that is our not intention, but remember that some of the majority of my experience is that way. So to summarize, at the end you summarize please. So tell that what we have talked so far. Most important is follow-up plan. Don't tell nothing more we can do. What we can do, please tell them. What we can't do, that also you tell them. So if for every bad news there's something you can do. So always tell that. So there should be some good about it as well. Sometimes bad news may be there. If you do that, he will be much better. There will be something, for example, amputation. If you do that amputation, there are prostheses there. Still he may be able to go. There may be some person who can run with the spring or whatever. So give the positive out of it and follow up plan. Don't end it because they will be completely distraught. Give some number or counselors numbers or your junior numbers who can feed back to you and call them back. So that's about spikes. So we will go back to the spikes framework. We will share the scenarios to each group. There are 5 groups. So take couple of minutes for discussion among the group. To the process, not to the content. However, we chose the scenario such a way that one or the other doctors in that group will be to that specialty. So however, the most important is content. Sorry, process, not to the content.
Sir.
10 minutes, 2 minutes to prepare themselves and 10 minutes for each.
First Bakras for this role play. So we have a scenario where I'm an obstetrician and during a routine 20 weeks anomaly scan of a primigravida conceived 6 years post marriage, a serious anomaly, fetal anomaly has been detected which might be life limiting or require significant medical intervention. Kindly communicate this to both parents. Okay. So we'll have to start the scenario.
Please.
So I'm Dr. Pujita. Kutkoli, bani kutkoli. Namaste, bani kutkoli. ಹೆಸರೇನಮ್ಮ ನಿಮ್ಮದು ಹೇಳಿ. ಆಯಿತು, ಈಗ ಎಷ್ಟು ತಿಂಗಳಾಯಿತು ಪ್ರೆಗ್ನೆಂಟ್ ಆಗಿ? 5 ತಿಂಗಳಾ? ಓಕೆ. ಅದೇ ನಿಮ್ದು ಅದೇ ಟ್ರೀಟ್ಮೆಂಟ್ ತೊಗೊಂಡು ಪ್ರೆಗ್ನೆಂಟ್ ಆಗಿದ್ದಲ್ಲಮ್ಮ, ಶುಗರ್ ಸಹ ಇರೋದು. ಓಕೆ, ಸ್ಕ್ಯಾನ್ ಮಾಡಿಸಿ ಬಂದಿದ್ದೀರಾ ಇವತ್ತು? ಓಕೆ. ಸೊ ಅದೇ ಬೇರೆ ಯಾರಾದರೂ ಇದ್ದಾರಾ ನಿಮ್ಮ ಜೊತೆ? ಇಲ್ಲ ನೀವಿಬ್ಬರೇ? ಆಯಿತು, ಓಕೆ ಕೂತ್ಕೊಳ್ಳಿ. ಅದೇ ಸ್ಕ್ಯಾನಲ್ಲಿ ಏನು ಹೇಳಿದ್ದಾರೆ, ಏನು ಗೊತ್ತಿದೆ ನಿಮಗೆ ಇಲ್ಲಿ ತನಕ? ಸ್ಕ್ಯಾನಲ್ಲಿ ಏನಾದರೂ ಹೇಳಿದ್ರಾ ನಿಮಗೆ? ಸ್ಕ್ಯಾನ್ ಡಾಕ್ಟ್ರ್ ಏನಾದರೂ ಮಾಡುವಾಗ ಹೇಳಿದರೆ? ಓಕೆ ಫೈನ್. ಅದೇ ಸ್ಕ್ಯಾನ್ ರಿಪೋರ್ಟ್ ನಾನು ನೋಡಿದ್ದೀನಿ. ಓಕೆ, ಅದೇ ಸ್ಕ್ಯಾನಿಂಗಲ್ಲಿ ಅದೇ ಸ್ವಲ್ಪ ಸಮಸ್ಯೆ ಇದೆ ಅಮ್ಮ ಮಗುಗೆ ಅದೇ ಹಾರ್ಟಿಂದು ಸಮಸ್ಯೆ ಇದೆ ಅಂತ ಕೊಟ್ಟಿದ್ದಾರೆ ಸ್ಕ್ಯಾನಿಂಗಲ್ಲಿ. ಓಕೆ, ಸೊ ಅದೇ ಆ ಸ್ಕ್ಯಾನ್ ರಿಪೋರ್ಟ್ ನೋಡಿದ ನಂತರ ಇದು ಹಾರ್ಟಿಂದು ಸಮಸ್ಯೆ ಸುಲಭ ಅಲ್ಲ. ಒಂದು ಮಗು ಹುಟ್ಟಿದ ನಂತರ ಹಾರ್ಟಿಂದು ಸರ್ಜರಿ ಎಲ್ಲ ಬೇಕಾಗಬಹುದು. ಇಲ್ಲಾಂದರೆ ತುಂಬ ಪ್ರಾಬ್ಲಮ್ ಆಗ್ತಾ ಇದ್ದರೆ ಮತ್ತೆ ಕಷ್ಟ ಆಗ್ಬೋದು ಡೆಲಿವರಿ ಆದ ನಂತರ. ನಮ್ಮದ್ರಲ್ಲಿ ಟೀಮ್ ಇದೆ, ನಾವು ಸಹ ನೋಡ್ತೀವಿ. ಪೀಡಿಯಾಟ್ರಿಕ್ ಕಾರ್ಡಿಯಾಲಜಿಸ್ಟು ಇದ್ದಾರೆ, ಪೀಡಿಯಾಟ್ರಿಷಿಯನ್ಸು ಇದ್ದಾರೆ. ಒಂದು ಒಪಿನಿಯನ್ ತೊಗೋಬೋದು ಮುಂದೆ ಏನಾದರೂ ಡಿಸಿಷನ್ ಮಾಡೋಕ್ಕೆ ಮುಂಚೆ. ಓಕೆ, ಆ್ಯಂಡ್ ಅದಾದಮೇಲೆ ಏನಂತ ಪ್ರೊಸೀಡ್ ಮಾಡೋಕ್ಕಾಗತ್ತೆ. ಬೇರೆ ಏನಾದರೂ ಇದೆಯಾ ಕೇಳೋಕ್ಕೆ ನಿಮಗೆ? ಹೌದು, ಸ್ವಲ್ಪ ಸೀರಿಯಸ್ಸೇ ಇದೆ. ಬಿಕಾಸ್ ಫುಲ್ ಟೀಮ್ ಇನ್ವಾಲ್ವ್ ಆಗಿ ಮತ್ತೆ ಮುಂದೆ ಏನು ಮಾಡಬೇಕು ಅಂತ ನೋಡಬೇಕಾಗತ್ತೆ. ಒಂದು ಹಾರ್ಟಿಂದು ಸರ್ಜರಿ ಇದ್ದರೆ ಇಲ್ಲಿಗೆ ಮಾಡೋಕ್ಕಾಗತ್ತೆ, ಇಲ್ಲ ದೊಡ್ಡ ಹಾರ್ಟಿಂದು ಸೆಂಟ್ರಿಗೂ ಡೆಲಿವರಿ ಆದ ನಂತರ ರೆಫರ್ ಮಾಡೋ ಅವಶ್ಯಕತೆ ಆಗ್ಬೋದು. ಫೈನಾನ್ಷಿಯಲಿನೂ ನಿಮಗೆ ಅದೆಲ್ಲ ಇದು ರೆಡಿಯಾಗಿರಬೇಕು ಒಂದು. ಆ್ಯಂಡ್ ಕಾಂಪ್ಲೆಕ್ಸ್ ಸರ್ಜರಿ ಅಂದರೆ ದೊಡ್ಡ ಆಪ್ರೇಷನ್ಸ್, ಒಂದಲ್ಲ 2-3 ಆಪ್ರೇಷನು ಬೇಕಾಗತ್ತೆ. ಅದು ನಾನು ಹೇಳೋದಕ್ಕಿಂತ ನಿಮಗೆ ಪೀಡಿಯಾಟ್ರಿಕ್ ಕಾರ್ಡಿಯಾಲಜಿಸ್ಟ್ ರಿಪೋರ್ಟ್ ನೋಡಿದ ನಂತರ ಕೌನ್ಸಿಲಿಂಗ್ ಮಾಡೋದೇ ಬೆಟರ್. ಅದೊಂದು ಆಪ್ಷನ್ ಇದೆ. ಬೇರೆ ಏನಾದರೂ ಕೇಳೋದಿದೆಯಾ ನಿಮಗೆ?
ಇಲ್ಲ ಅಂದರೆ ಬೇರೆ ಏನಾದರೂ
ನಿಮಗೆ ಅದೇ ಇದು ಇಂಥದ್ದು ಸಮಸ್ಯೆ ಬೇಡ. ಲೈಕ್ ನಿಮಗೆ ಈ ಮಗು ಏನು ತೊಂದರೆ ಇಲ್ಲದೇ ಪ್ರಾಬ್ಲಮ್ ಇಲ್ಲದೇ ಮಗು ಬೇಕು ಅಂದರೆ ಒಂದು ಇದು ಟರ್ಮಿನೇಟ್ ಮಾಡಿಸ್ಬೇಕಾಗತ್ತೆ, ಮಗುದು ತೆಗೆಸೋ ಅವಶ್ಯಕತೆ ಆಗಬೇಕಾಗತ್ತೆ. ಹೌದು ಸರ್. ಅವ್ರದ್ದು ಸ್ವಲ್ಪ ರಿಸ್ಕ್ ಪ್ರೆಗ್ನೆನ್ಸಿನೇ ರೀ, ಶುಗರ್ ಎಲ್ಲ ಇತ್ತು. ಅದೇ ಗೊತ್ತಾಗ್ತಿದೆ ಸಮಸ್ಯೆ ಇದೆ. ಐ ಕ್ಯಾನ್ ಅಂಡರ್ಸ್ಟ್ಯಾಂಡ್ ಹೌ ಯು ಆರ್ ಫೀಲಿಂಗ್, ಬಟ್ ದಿಸ್ ಇಸ್ ದಿ ಆಪ್ಷನ್ಸ್. ಸ್ವಲ್ಪ ಯೋಚನೆ ಮಾಡಿ, ಯು ಕ್ಯಾನ್ ಗೋ ಬ್ಯಾಕ್, ಥಿಂಕ್ ಓವರ್ ಇಟ್ ಆ್ಯಂಡ್ ದೆನ್ ಥಿಂಕ್ ವಾಟ್ ಯು ವಾಂಟ್ ಟು ಡೂ. ಟೇಕ್ ಸಮ್ ಟೈಮ್, ಡಿಸೈಡ್ ಆ್ಯಂಡ್ ದೆನ್ ಕಮ್ ಬ್ಯಾಕ್. ಆರ್ ನೀವು ನಿಮ್ಮದು ರಿಲೇಟಿವ್ಸ್ ಜೊತೆ ಮಾತಾಡಿ ಬರ್ತೀರಾ, ಏನಾದರೂ ವಾಪಸ್ ಬರ್ತೀರಂದರೆ ವಾಪಸ್ ಬನ್ನಿ. ಇದೇನು ಇವಾಗ ಎಮರ್ಜೆನ್ಸಿ ಏನು ಡಿಸಿಷನ್ ತೊಗೋಬೇಕು ಅಂತ ಅವಶ್ಯಕತೆ ಇಲ್ಲ. ವೆಯ್ಟ್ ಮಾಡಿ, ವಿ ಕ್ಯಾನ್ ಡಿಸೈಡ್ ಆ್ಯಂಡ್ ದೆನ್ ಗೋ ಅಬೌಟ್ ಇಟ್.
She confirmed whether they want someone else to.
Cross-checking the identity of the patient. At least I have had many situations where because of getting introduced to wrong patient, I was told wrong thing. Even yesterday I had one, after my surgery, there were 3 patients, I told something else, something else the patient. I mean, that happens. Please cross-check before you break that news, very important. Thanks.
The second thing is, in the beginning itself, she asked if there was someone else they would want to be included at the time of discussion. Because many times termination of the baby, it's a family decision. It's not just the husband and wife who are involved in the discussion, especially after 6 years of marriage.
Very good point. Yes.
Then she confirmed the background of the patient. She said 6 years married life, they already had risk factors like diabetes and had conceived after infertility treatment. And she confirmed whether they were already informed about the problem at the radiology department itself, so that she knows from where to start.
And that's a good thing, because sometimes, sorry, what? Sometimes what happens, before, even though you think you are the first person to disclose, they would have not got the report by someone, or they would have read the report unofficially, or something would have happened. So you can know actually where to start from. If they are already aware what the problem is, it becomes more easier to break a bad news. Sometimes if they are totally maybe doesn't know anything, then you have a daunting task of starting from zero.
And while discussing the different options, she told in the beginning itself that it will be a multidisciplinary treatment where pediatricians, pediatric surgeons, everybody will be involved. She told there's nothing that can be done now, and whatever has to be done, if they're interested in continuing the pregnancy, would be handled after the delivery.
So she is basically given a good treatment option. Even though it's a bad news, there is some ray of hope. You can do something, yes.
And she clearly told that the plan of action would be better discussed by the pediatric surgeon rather than she herself. So that there's no confusion. There should not be that she says something else and the surgeon says something else. So she clearly told in the beginning itself that the better counseling would be done by the pediatric surgeon. She also discussed about the financial aspects of it.
Okay. Anything else to add?
Has she addressed the emotional aspect of the...
The emotional aspect, actually, she could have addressed better by putting the ball in their court. She could have told them, you have an option of going ahead with surgery, but you need to understand that the baby may not be healthy and you'll be subjecting the baby to multiple surgeries without knowing the final outcome, instead of directly giving them the option of termination. So it's like you decide whether you want your baby to undergo multiple surgeries or you want to take the decision of termination of pregnancy now itself. Because when you directly say someone who's conceived after infertility treatment, the option of termination, that is the reaction you will usually get.
Okay, right. One thing I think when you are trying to break bad news, you need to give quite a bit of pauses. I felt she was the more dominant character. She was talking little more, agree, 100%. So nothing wrong, I don't think it's wrong, but I'm just trying to, there is another viewpoint. There, when you're breaking bad news, you try to give a little pause, allow them to recur, she didn't bombard anything very bad. I mean, she was trying to give some solace, but too fast, too much of words.
She was doing you a favor by saving your time.
Yes, that's true. That's true. Okay, fine. Any last comments from your side? Or any other batches wants to say? Yes.
When the one was put into the pediatric cardiologist go, she could have been meeting a forming team and discuss something like that.
Multidisciplinary kind of team together, sitting together and talking to them. That's that's all the follow-up plan. So she had some follow-up plan. So that should be sufficient unless they come back, unless they are not satisfied.
Yes, sir.
There's a flip side to that.
Yes.
Football. You're sitting there, the patient party gets a little.
Yeah. No, then there is one more flip side. What I recognize is what we call as football. The casualty patient comes. I know it is chest injury. I don't do. So I football to. No, surgeon will come and speak the bad part of it. They will tell no, neurosurgeon will come and speak. It does occur in real life situation. Sometimes in this situation, yes, what she has done is reasonably good, but other situation where you have day-to-day with multidisciplinary, there should be one person communicating. That's what I believe in. One person. At times you can take somebody's help, but you are the one face, single face, who is going to be communicating the vaccine.
Okay, next is yours. You're coming. Who is coming? Other than those already coming.
ಸೊ ಮೊನ್ನೆಷ್ಟು ನೀವು ಅಡ್ಮಿಟ್ ಆಗಿದ್ರೆ ಕೆಮ್ಮು ಕಫ ಅಂತ ಸೊ ಸೂಜಿ ಪರೀಕ್ಷೆ ಮತ್ತು ನಾವು ಇದು ಮಾಡಿದ್ದೇವೆ CT ಸೊ ರಿಪೋರ್ಟ್ಸ್ ಎಲ್ಲ ಬಂದಿದೆ ಸೊ ನೀವು ಈಗ ಇವತ್ತು ಒಬ್ಬರೇ ಬಂದಿದ್ದೀರಾ ನಿಮ್ಮ ಜೊತೆ ಇದ್ದಾದ್ರು
ಡಾಕ್ಟ್ರ್ ಇಲ್ಲ ನಾನು ಒಬ್ಬನೇ ಬಂದಿದ್ದೀನಿ ಡಾಕ್ಟ್ರೆ ಅಂದರೆ ಯಾರು ಬಂದಿಲ್ಲ ನನ್ನ ಜೊತೆ
ಓಕೆ
ಮನೆಯಲ್ಲಿ ಏನೋ ಬೇರೆ ಫಂಕ್ಷನ್ ಇತ್ತು ಡಾಕ್ಟ್ರ್ ಅದೇನು ನಾನು ಕ್ಯಾನ್ಸರ್ ಡಾಕ್ಟ್ರೆ ಅದೇ ಯಾರು ಬಂದಿಲ್ಲ ನಾನು ಒಬ್ಬನೇ ಬಂದಿದ್ದೀನಿ ಅವ್ರಿಗೆ ಬೇರೆ ಏನೋ ಫಂಕ್ಷನ್ ಎಲ್ಲ ಇತ್ತು ಡಾಕ್ಟ್ರ್ ಏನೋ ಕ್ಯಾನ್ಸರ್ ಡಾಕ್ಟ್ರ್ ಅದರಲ್ಲಿ
ಮೊನ್ನೆ ಹೇಳಿದಾಗೆ ನೋಡಿದಾಗೆ ಕ್ಯಾನ್ಸರ್ ಥರ ಇತ್ತಂತ ಸಂಭಾವನೆ ಇತ್ತಂತ ಹೇಳಿದ್ದೇನೆ ಸೊ ಈಗ ಸೂಜಿ ಪರೀಕ್ಷೆಯಲ್ಲಿ ಕನ್ಫರ್ಮ್ ಆಗಿ ಬಂದಿದೆ ಕ್ಯಾನ್ಸರ್ ಅಂತ
ಏನು ಪ್ರಾಬ್ಲಮ್ ಇಲ್ಲಲ್ಲ ಡಾಕ್ಟ್ರೆ
ಸೊ ಅದು CTಯಲ್ಲಿ ಬೇರೆ ಕಡೆ ಸಹ ಹರಡಿದೆ ಲಿವರಲ್ಲಿ ಎಲುಬಿನಲ್ಲಿ ಸೊ ಕಂಡೀಷನ್ ಸ್ವಲ್ಪ ಬ್ಯಾಡ್ ಉಂಟು
ಅದು ಗುಳಿಗೆ ಔಷಧಿಯಲ್ಲಿ ಸರಿ ಆಗ್ತದಲ್ಲ ಡಾಕ್ಟ್ರೆ
ಕ್ಯಾನ್ಸರ್ ಅಂದರೆ ಈಗ ತುಂಬ ಕಡೆ ಹರಡಿದೆ ಸೊ ಪ್ರೋಗ್ನೋಸಿಸ್ ಸ್ವಲ್ಪ ಬ್ಯಾಡ್ ಇರ್ತದೆ ಅಂದರೆ
ಡಾಕ್ಟ್ರೆ ಪ್ರೋಗ್ನೋಸಿಸ್ ಅಂದರೆ
ಈಗ ಸರ್ಜರಿ ಮಾಡೋ ಜಾಸ್ತಿ ಏನು ಉಪಯೋಗ ಬರಲಿಕ್ಕಿಲ್ಲ ಇದರಲ್ಲಿ ಕೀಮೋ ಮಾಡಿ ಇದು ಮಾಡಬೇಕಾಗ್ತದೆ ಸೊ ಅಂದರೆ ನಿಮ್ಮ ಜೊತೆ ಯಾವ್ದಾದ್ರು ಇದ್ದರೆ ಅವ್ರನ್ನ ಕರ್ಕೊಂಡು ಬಂದರೆ ಕ್ಲಿಯರಾಗಿ ಎಕ್ಸ್ಪ್ಲೇನ್ ಮಾಡ್ಬೋದು
ಅದೇ ಡಾಕ್ಟ್ರ್ ಈಗ ಯಾರು ಬಂದಿಲ್ಲ ಬಟ್ ಅದೇ ಟ್ರೀಟ್ಮೆಂಟ್ ಅಂದರೆ ಅದಕ್ಕೆ
ಮಾಡಲಿಕ್ಕೆ ಇನ್ನು ಕೆಲವು ಪರೀಕ್ಷೆ ಮಾಡಬೇಕು PET CT ಮಾಡಬೇಕಾಗ್ತದೆ ಬೇರೆ ಕಡೆ ಹರಡಿದೆ ಎಲ್ಲೆಲ್ಲ ಹರಡಿದೆ ಅಂತ ನೋಡಲಿಕ್ಕೆ ಸೊ ಅದಾದಮೇಲೆ ನಿಮಗೆ ಪ್ರೋಗ್ನೋಸಿಸ್ ಹೇಳ್ಬೋದು ಎಷ್ಟು ಸಂಭಾವನೆ ಉಂಟು ಇದರಲ್ಲಿ ಕ್ಯಾನ್ಸರ್ ಅಂದರೆ ಎಷ್ಟು ಕಾಲ ಬದುಕುವ ಸಂಭಾವನೆ ಇರ್ತದೆ ಎಷ್ಟು ಕಾಲ ಇದಾಗುವ ಬೇರೆ ಏನು ಕಾಂಪ್ಲಿಕೇಶನ್ ಆಗುವ ಚಾನ್ಸ್ ಇರ್ತದೆ ಹೇಳಲಿಕ್ಕೆ ಇನ್ನೂ ಕೆಲವು ಟೆಸ್ಟ್ ಬೇಕಾಗ್ತದೆ ಸೂಜಿ ಪರೀಕ್ಷೆ ಕೆಲವೆಲ್ಲ ಟೆಸ್ಟ್ ಬರಲಿಕ್ಕೆ ಬಾಕಿ ಉಂಟು ಕೆಲವು ಮಾರ್ಕರ್ಸ್ ಅಂತ ಸೊ ಫುಲ್ ಕಂಪ್ಲೀಟ್ ಬಂದಿಲ್ಲ ಅದು ರಿಪೋರ್ಟ್ಸ್
ಈಗ ನೀವು PET CT ಮಾರ್ಕರ್ಸ್ ಅಂತ ಹೇಳಿದ್ರಲ್ಲ ಡಾಕ್ಟರ್ ಅದು ಅದ್ರ ಬಗ್ಗೆ ಹೇಳ್ಬೋದು ನೀವು
PET CTಯಲ್ಲಿ ಬೇರೆ ಕಡೆ ನಾವು CT ಮಾಡಿದ್ದು ಬರೀ ಎದೆ CT ಮಾಡಿದ್ದೇವೆ ಅಷ್ಟೇ ಸೊ ಅಲ್ಲಿ ಎಷ್ಟು ಹರಡಿದೆ ಅಷ್ಟೇ ಗೊತ್ತಾಗ್ತದೆ
ಲಿವರ್ ಅಂತ ಹೇಗೆ ಗೊತ್ತಾಯ್ತು ಡಾಕ್ಟರ್ ನಿಮಗೆ
ಆ PET CTಯಲ್ಲಿ ಸ್ವಲ್ಪ ಭಾಗ ಅಬ್ಡೋಮೆನ್ ತನಕ ಕಾಣ್ತದೆ ಸೊ ಇಲ್ಲಿದ್ದ ಭಾಗದಲ್ಲಿ ಲಿವರಲ್ಲಿ ಸ್ವಲ್ಪ ಹರಡಿದೆ ಅಂತ ಬಂದಿದೆ ಅದೇ ಕರೆಕ್ಟಾಗಿ ನೋಡಲಿಕ್ಕೆ ಅದು ಜಸ್ಟ್ ಕ್ಯಾನ್ಸರ್ ಅಂತ ನೋಡಲಿಕ್ಕೆ PET CTಯಲ್ಲಿ ಗೊತ್ತಾಗ್ತದೆ ಎಂತಕ್ಕಂದರೆ PET CTಯಲ್ಲಿ ಅದು ಕ್ಯಾನ್ಸರ ಅಥವಾ ಬಿನೈನ್ ಅಂತ ಸರಿಯಾಗಿ ಗೊತ್ತಾಗ್ತದೆ ಸೊ ಕ್ಯಾನ್ಸರ್ ಇದ್ದರೆ ಅದರಲ್ಲಿ ಒಂಥರ ಲೈಟ್ ಥರ ಇರ್ತದೆ ಅದರಲ್ಲಿ ಸೊ PET CTಯಲ್ಲಿ ಕ್ಯಾನ್ಸರ್ ಅಂತ ಇರುವ ಭಾಗ ಎಲ್ಲ ತುಂಬ ಜಾಸ್ತಿ ಡಾರ್ಕ್ ಇರ್ತದೆ
PET CT ಅಂದ್ರೆ ಅದು ಹೋಲ್ ಬಾಡಿ ಸ್ಕ್ಯಾನ್ ಅಂತ ಹೇಳ್ತಾರೆ
ಹೋಲ್ ಬಾಡಿ ಸ್ಕ್ಯಾನ್ ಮಾಡಬೇಕಾಗ್ತದೆ
ಮತ್ತೆ ನೀವು ಬಿನೈನ್ ಅಂತ ಹೇಳಿದ್ರಿ ಅದರ ಅರ್ಥ ಏನು
ಬಿನೈನ್ ಅಂದರೆ ಅದು ಜಸ್ಟ್ ಚಿಕ್ಕ ನಾಡ್ಯೂಲಾ ಅಥವಾ ಕ್ಯಾನ್ಸರ್ ಅಲ್ಲಿಂದನೇ ಹರಡಿದ ಕ್ಯಾನ್ಸರ್ ಅಂತ ಸೊ ಬಿನೈನ್ ಅಂದರೆ ಜಾಸ್ತಿ ಪ್ರಾಬ್ಲಮ್ ಇದೆಲ್ಲ, ಅದು ಮ್ಯಾನೇಜ್ ಮಾಡ್ಬೋದು. ಕ್ಯಾನ್ಸರ್ ಅಂದರೆ ಅದು ತುಂಬ ಬ್ಯಾಡ್, ಇನ್ನು ಹರಡುವ ಚಾನ್ಸ್ ಜಾಸ್ತಿ, ಅದು ಪ್ರಾಗ್ನೋಸಿಸ್ ಸ್ವಲ್ಪ ಬ್ಯಾಡ್ ಇರ್ತದೆ ಅದರಲ್ಲಿ.
ಮತ್ತು ಕೀಮೋಥೆರಪಿ ಅಂತ ಹೇಳಿದ್ರಲ್ಲ ಡಾಕ್ಟರ್, ಅದರ ಸೈಡ್ ಎಫೆಕ್ಟ್ಸ್ ಏನಾದರೂ ಇದೆಯಾ, ಅಲ್ಲ ಏನು ಪ್ರಾಬ್ಲಮ್ ಆಗೋದಿಲ್ಲ?
ಕೀಮೋಥೆರಪಿಯಲ್ಲಿ ಸೈಡ್ ಎಫೆಕ್ಟ್ಸ್ ಇರ್ತದೆ, ಅದರಲ್ಲಿ ಇನ್ಫೆಕ್ಷನ್ಸ್ ಆಗುವ ಚಾನ್ಸ್ ಇರ್ತದೆ, ನಿಮಗೆ ಸೈಡ್ ಎಫೆಕ್ಟ್ಸ್ ವಾಮಿಟಿಂಗ್, ನಾಸಿಯಾ ಅದಾಗುವ ಚಾನ್ಸ್ ಇರ್ತದೆ. ಸೊ ತುಂಬ ಸೈಡ್ ಎಫೆಕ್ಟ್ಸ್ ಇರ್ತದೆ. ಅದೆಲ್ಲ ಆಪ್ಷನ್ಸ್ ನಾವು ನಿಮಗೆ ಮೆಲ್ಲ ಹೇಳ್ತೇವೆ, ಫುಲ್ ರಿಪೋರ್ಟ್ಸ್ ಬರಲಿ. ಅದೆಲ್ಲ ರಿಪೋರ್ಟ್ ಬಂದಾದ್ಮೇಲೆ ಪುನಃ ನೆಕ್ಸ್ಟ್ ಟೈಮ್ ಬಂದು ಮಾತಾಡ್ತೇವೆ. ನಮ್ಮ ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ಆಂಕಾಲಜಿಸ್ಟ್ ಇದ್ದಾರೆ, ಅವ್ರ ಹತ್ರ ಹೋಗಿ ನೀವು ಇವತ್ತು ಮಾತಾಡಿ ಬರ್ಬೋದು. ಅದೇ ಫುಲ್ ಕಂಪ್ಲೀಟ್ ರಿಪೋರ್ಟ್ ಬಂದಾದ್ಮೇಲೆ ಅವ್ರು ಸ್ವಲ್ಪ ಪೆಟ್ ಸಿಟಿ ಹೇಳ್ತದೆ, ಅದೆಲ್ಲ ಆದಮೇಲೆ ನಿಮಗೆ ಫುಲ್ ಕಂಪ್ಲೀಟ್ ಆಗಿ ಹೇಳ್ಬೋದು ನಿಮಗೆ.
ಇದು ಈ ಆಯುಷ್ಮಾನ್ ಸ್ಕೀಮಲ್ಲಿ ಬರ್ತದಲ್ಲ ಡಾಕ್ಟ್ರೆ?
ಅದು ಆಂಕಾಲಜಿಸ್ಟ್ ಅಂಡರ್ ಅಡ್ಮಿಟ್ ಆದರೆ ಬರ್ಬೋದು, ಅದು ನೀವು ಹೋಗಿ ಒಂದ್ಸಲ ಮಾತಾಡಬೇಕಾಗ್ತದೆ. ಅದು ನೋಡುವ, ನಾವು ಈಗ ಫಸ್ಟ್ ಎಲ್ಲ ಸ್ಟೆಪ್ ವೈಸ್ ಹೋಗುವ. ಫಸ್ಟ್ ಈಗ ಈ ಥರ ಕ್ಯಾನ್ಸರ್ ಅಂತ ಬಂದಿದೆ, ಅದು ಎಷ್ಟು ಪ್ರೋಗ್ನೋಸಿಸ್ ಅಂದರೆ ಎಷ್ಟು ಹರಡಿದೆ, ಎಲ್ಲಿ ತನಕ ಹರಡಿದೆ, ಅದೆಲ್ಲ ಗೊತ್ತು ಮಾಡಲಿಕ್ಕೆ ಇನ್ನೂ ಟೆಸ್ಟ್ ಮಾಡಬೇಕಾಗ್ತದೆ.
ಫೈನಲ್ ಸ್ಟೇಜ್ ಅಲ್ಲ ಡಾಕ್ಟರ್ ಇದು?
ಅದು ನೋಡಲಿಕ್ಕೆ ಪೆಟ್ ಸಿಟಿ ಮಾಡಬೇಕಾಗ್ತದೆ. ಬಯೋಪ್ಸಿಯಲ್ಲಿ ಸ್ವಲ್ಪ ಬ್ಯಾಡ್ ಬಂದಿದೆ ಇದು ಕ್ಯಾನ್ಸರ್.
ಆಪರೇಷನ್ ಏನಾದರೂ ಮಾಡ್ಬೋದಾ, ಅದನ್ನು ತೆಗಿಬೋದು?
ಅದು ನೋಡಲಿಕ್ಕೆ ಅದೇ ಆಲ್ರೆಡಿ ಸಿಟಿಯಲ್ಲಿ ಹರಡಿದೆ ಅಂತ ಉಂಟು ಇದರಲ್ಲಿ, ಲಿವರ್ನಲ್ಲಿ. ಅದು ಕರೆಕ್ಟಾಗಿ ನೋಡಲಿಕ್ಕೆ, ಅದು ಕ್ಯಾನ್ಸರ್ ಅಂತ ನೋಡಲಿಕ್ಕೆ ನಾವು ಇದು ಮಾಡಬೇಕು, ಪೆಟ್ ಸಿಟಿ ಮಾಡಬೇಕು. ಎಲುಬಿನಲ್ಲಿ ಸಹ ಕೆಲವು ಏರಿಯಾಸ್ ಉಂಟು ಹರಡಿದಾಗೆ ಅಂತ, ಅದು ಪೆಟ್ ಸಿಟಿಯಲ್ಲಿ ಸರಿಯಾಗಿ ಗೊತ್ತಾಗ್ತದೆ. ಒಂದು ವೇಳೆ ಅಲ್ಲೆಲ್ಲ ಹರಡಿದೆ ಅಂತ ಹೇಳಿದರೆ ಸರ್ಜರಿ ಮಾಡುವ ಆಪ್ಷನ್ ಸ್ವಲ್ಪ ಮಾಡಲಿಕ್ಕೆ ಕಷ್ಟ ಆಗ್ತದೆ, ಕೀಮೋನೇ ಮಾಡಬೇಕಾಗ್ತದೆ.
Okay.
Everything the patient was asking. After the patient asking, the doctor was explaining it. So if now imagine, so in starting, again start from the start. When the patient entered, you can ask the patient whether he wants to hear the news before he has a relative next to him, or he needs someone because he had told.
You want to know whether there's a bias.
Someone else.
Yeah,
He did ask.
Hasn't the patient party come with him?
Yeah, but
He told that no, I came alone.
came alone. So do you want to hear the news even if you have come alone and get someone or something? Second thing, the PET CT which was being advised for the patient should be explained more about before the patient itself asking for what is it about and all that stuff, and how much does it cost approximately, and otherwise it was explained very well, I feel. He spoke about talking to other disciplines. You can also take a call wherein we speak to a different discipline and come, as I told previously, and talk one person way.
Okay.
And that's it.
Fine. Anything else?
The patient is potentially in denial, sir. Actually, he is repeatedly asking, "Ella sari agtadalla, ella sari agtadalla."
That's a normal behavior. I think every patient always believes that he is perfectly fine and he doesn't have a problem. Even if
he is asking it repeatedly, basically he is in potential denial. I think that has to be broken.
Yeah,
has to be broken.
That is where the communication comes. Like how well you can convince and tell, no, this is not the real story, there is something else. So at least when he is leaving outside, it should be clear. Okay, when coming, he can be in denial. But when he is leaving, you can cross-check whether he is at least.
But if he is repeatedly denying, then we have to give it a break and ask him to come again after.
Yeah, you can do that. There's nothing harm. You can actually call somebody else. See, what happens sometimes, you may not understand everything at point of time. We believe we talk something. When you actually go out and ask them, they would not even keep 30-40% of what we have spoken. So it's at times better to give a break, ask them to get someone else, and then continue the discussion. Anything else? Yes, Srinath?
Insurance, when you are asking about Ayushman Bharat scheme, you have given a little more information about
Okay.
scheme which is used.
Okay, okay, Vash, you wanted to say something? I thought so. You were.
Voice control. Modulation.
So few things I would have done little differently. It was looking like question and answer session. So probably we should have gone to this setting was okay, but when it come to the perceiving of understanding, how much he know, he did mention that he has talked to him before. So he assumed that patient knows, but ideally what you know so far happening to you. So he would have opened up. I have done, you said other day you have done the scanning and etc. So I am here to now tell you this information about the scan results. So that way of knowing understanding the patient, how much they know what so far, that was helpful. He invited the patient to whether to know the reports, relatives, and those parts of covered. Knowledge, the giving knowledge, probably the process here is, as I said, if it were opened up continuously, then he could have given small information at one go. Say. So he did mention about few medical jargon like chemo, benign, many chemo nowadays, many patients know chemo, fair enough, but you could say that some medicines called chemotherapy, drugs called chemotherapy, etc. So then there was some follow-up plan also involving the surgeons, etc. So sometimes if you are not planning to do and giving the information also not good. So to the point for that session would be the right thing. So PET scan, fair enough if he is asking, because the patient was kept on asking those. Or if you are at your level, you could just transfer the care to the oncology team. They might be doing all these things, but they will tell you in better way and when you meet them. So this is the way. So anything else?
Anybody else? Final comments? Okay. That's 16-1. 16-1, sorry. Quick.
ಮೈ ಲೆಗ್ ಇಸ್ ಹರ್ಟಿಂಗ್ ಡಾಕ್ಟರ್. ಸೊ ನೋವಾಗ್ತಿದೆ, ಗೊತ್ತಾಗ್ತಿಲ್ಲ, ಜೋರು ನೋವಾಗ್ತಿದೆ, ಅಂದ್ರೆ ಕಾಲು ಹಂದಾಡ್ಸ್ಲಿಕ್ಕೆ ಆಗ್ತಿಲ್ಲ.
ಓಕೆ, ನೋವುಂಟು, ತುಂಬಾ ಬಹಳ ನೋವುಂಟು ಅಂತಲ್ಲ ಕೆಳಗಿನ ಭಾಗದಲ್ಲಿ.
ಪೇನಿಗೆ ಏನಾದರೂ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡಿ ಡಾಕ್ಟ್ರೆ.
ಪೇನಿಗೆ ಮೆಡಿಸಿನ್ ಕೊಡುವ ನಾವು, ಅಂದರೆ ನೋಡುವ. ಓಕೆ, ನಾವು ಈಗ ಮೆಡಿಸಿನ್ ನಾವು ಸಾಧಾರಣ ಸ್ಟ್ರಾಂಗ್ ಮೆಡಿಸಿನ್ ಕೊಡ್ತಾ ಇದ್ದೇವೆ. ಬಟ್ ಇದು ನೋವು ಈಗ ನಿಮಗೆ ಆದದ್ದು ಸಣ್ಣ ವಿಷಯ ಅಲ್ಲ, ಸಾಕಷ್ಟು ದೊಡ್ಡ ಸಮಸ್ಯೆ. ಆ ಕಾರಣಕ್ಕೆ ಬೇಕಾಗಿ ನಾವು ನೋವಿದ ಮದ್ದು ಜಾಸ್ತಿ ಮಾಡುವ, ತೊಂದರೆ ಇಲ್ಲ. ರಾಮಪರೆ, ನಾನು ಆ್ಯಕ್ಚುಲಿ ನಿಮ್ಮ ರಿಪೋರ್ಟ್ಸ್ ನೋಡಿ, ನಿಮ್ಮ ಪರೀಕ್ಷೆ ಮಾಡಿದರೆ ಆಧಾರದ ಮೇಲೆ ನಿಮ್ಮ ಹತ್ರ ಹೇಳೋದು ಸ್ವಲ್ಪ ಅಲ್ಲ, ಸಾಕಷ್ಟು ಕಹಿ ಇರುವ ಸಾಧ್ಯತೆ ಉಂಟು. ಬಟ್ ನಾ ಸತ್ಯ ವಿಷಯ ಹೇಳ್ತಾ ಇದ್ದೇನೆ ನಿಮ್ಮ ಹತ್ರ. ನಿಮ್ಮ ಹತ್ರ
ಕಾಲು ಸರಿ ಆಗ್ತದಲ್ಲ ಡಾಕ್ಟ್ರೆ? ಇಲ್ಲ, ನನ್ನ ಫ್ರೆಂಡ್ ಬರ್ತಿದ್ದಾರೆ, ದೇ ಆರ್ ಆನ್ ದ ವೇ.
ಹಾಗೆ ಬಂದ ಮೇಲೆ ನಾವು ಅವರಿದ್ರೆ ಒಳ್ಳೇದಾಗ್ಬೋದಾ ನಿಮಗೆ?
ಅದು ಐ ಮೆಟ್ ವಿತ್ ಅನ್ ಆಕ್ಸಿಡೆಂಟ್, ಅದು ಕಾಲಿಗೆ ಗಾಯ ಆಗಿತ್ತು.
ನೀವೇನಾಗ್ತೀರಾ ಇವರಿಗೆ? ಪಕ್ಕದ ಮನೆಯವರಾ? ಕೂತ್ಕೊಳ್ಳಿ.
ಅಲ್ಲ, ಇವರು ಆಗುದಿಲ್ಲ ಅಂತ ಹೇಳಿದ್ದಾರೆ ಡಾಕ್ಟರ್, ಎಲ್ಲ ಸರಿ ಆಗ್ತದಂತೆ.
ಕೂತ್ಕೊಳ್ಳಿ. ನಾ ಆ್ಯಕ್ಚುಲಿ ಹೇಳೋದು, ಈಗ ನಿಮಗೆ ಹೇಳೋದು ಕಹಿ ಇರ್ಬೋದು, ಬಟ್ ಸತ್ಯ ವಿಷಯ ಹೇಳ್ತಾ ಇದ್ದೇನೆ. ನಮಗೆ ಈ ಪರೀಕ್ಷೆ ಆಧಾರದ ಮೇಲೆ, ರಿಪೋರ್ಟ್ಗಳ ಆಧಾರದ ಮೇಲೆ ನನ್ನ ಅಭಿಪ್ರಾಯದಲ್ಲಿ ನಿಮ್ಮ ಕಾಲು ಉಳಿಸೋ ಸಾಧ್ಯತೆ ಬಹಳ ಕಮ್ಮಿ. ನಮ್ಮ ರೆಕಮೆಂಡೇಶನ್ ಆ್ಯಕ್ಚುಲಿ ಕಾಲು ಕಟ್ ಮಾಡಬೇಕಾಗಿ ಬರ್ತದೆ.
ಅದು ಬಿಟ್ಟು ಬೇರೆ ಏನು ಆಪ್ಷನ್ನೇ ಇಲ್ಲ ಸರ್.
ಈ ಪಾಯಿಂಟ್ ಆಫ್ ಟೈಮಲ್ಲಿ ಪರೀಕ್ಷೆ ಆಧಾರದ ಮೇಲೆ ನಾವು ಕಾಲನ್ನು ಇಟ್ಕೊಳ್ಳೋ ಪ್ರಯತ್ನ ಮಾಡೋದು ಸಾಕಷ್ಟು ರಿಸ್ಕಿ. ಈಗ ಕೆಲವು ನಾವು ಕ್ರಶ್ ಆಗಿದೆ, ಅಲ್ಲಿ ಇಂಜುರಿ ಕ್ರಶ್ ಆಗಿದೆ. ಕ್ರಶ್ ಆದ ಕಾರಣ ನಿಮಗೆ ಅದರ ಸಂಪೂರ್ಣ ಸರಿ ಮಾಡುವ ಸಾಧ್ಯತೆ ಸಾಕಷ್ಟು ಕಮ್ಮಿ.
ಅಟ್ಲೀಸ್ಟ್ ಟ್ರೈ ಆದರೂ ಕೊಡಬೇಕಲ್ಲ ಡಾಕ್ಟ್ರೆ? ನನಗೆ 25 ಇಯರ್ಸ್ ಮಾತ್ರ, ಕಾಲಿಲ್ಲದೆ ಹೇಗಿರುತ್ತೆ?
ನಮಗೆ ಹೇಳಲಿಕ್ಕೆ ಸುಲಭ, ಹೀಗೆ ಮಾಡಿ ಹಾಗೆ ಮಾಡಿ ಅಂತ, ಬಟ್ ಅನುಭವಿಸೋರಿಗೆ ಗೊತ್ತು ಎಷ್ಟು ಕಷ್ಟ ಅಂತ ಹೇಳೋದು. ನಿಮ್ಮ ಕಷ್ಟ ಕರೆಕ್ಟ್. ನಾವು ಇದರ ಬಗ್ಗೆ ನಾವು ಡಿಸ್ಕಸ್ ಮಾಡಿ ಯೋಚನೆ ಮಾಡೋದು. ನಮಗೆ ಬೇರೆ ಟ್ರೈ ಮಾಡೋದು, ಈಗ ನಾವು ವೆಯ್ಟ್ ಮಾಡೋದ್ರಲ್ಲಿ ರಿಸ್ಕ್ ಇಲ್ಲ ಅಂತ ಹೇಳಿದರೆ ನಾವು ವೆಯ್ಟ್ ಮಾಡ್ಬೋದು. ಆ್ಯಂಡ್ ಈ ಪಾಯಿಂಟ್ ಆಫ್ ಟೈಮಲ್ಲಿ ನಾವು, ಅಂದರೆ ನಾನು ಈ ಕಾಲು ನೀವು ಇಟ್ಕೊಳ್ಳೋದ್ರಿಂದಾಗಿ ನಿಮಗೆ ಜೀವಕ್ಕೆ ತಕ್ಷಣ ಈಗ ಬರುವ ಕೆಲವು ದಿವಸದಲ್ಲಿ ಅಪಾಯ ಆಗುವ ಸಾಧ್ಯತೆ ಅಂತ ಇಲ್ಲ. ಆ ಕಾರಣಕ್ಕೆ ಬೇಕಾಗಿ ನಾವು ಜಾಗ್ರತೆಯಲ್ಲಿ ಮಾಡಿ ವೆಯ್ಟ್ ಮಾಡೋದಾದ್ರೆ ವೆಯ್ಟ್ ಮಾಡ್ಬೋದು. ಬಟ್ ವೆಯ್ಟ್ ಮಾಡಿದ ಮೇಲೆ ನಿಮ್ಮ ಅಪೇಕ್ಷೆ ಏನು ಹೇಳಿ?
ಕಾಲು ಉಳಿಸ್ಬೇಕಲ್ಲ ಡಾಕ್ಟ್ರೆ?
ಈಗ ಆ ಕಾಲನ್ನು ನಾವು ಉಳಿಸೋ ಪ್ರಯತ್ನ ಮಾಡಿದ ಮೇಲೆ ನಿಮಗೆ ಆ ಕಾಲು ಉಳಿತದೆ ಅಂತ ಹೇಳಿದರೆ, ಅದರಲ್ಲಿ ಈಗ ನಡಿಲಿಕ್ಕೆ ಆಗ್ತದೆ ನಿಮಗೆ ಆರಾಮದಲ್ಲಿ. ನಿಮಗೆ ನಿಮ್ಮ ಎಲ್ಲ ಕೆಲಸಗಳು ಮುಂಚೆ ಮಾಡಿದಾಗ ಮಾಡಲಿಕ್ಕೆ ಆಗ್ತದೆ ಅಂತ ಹೇಳಿದರೆ, ಅದರಲ್ಲಿ ನೋವಿರುವುದಿಲ್ಲ ಅಂತ ಹೇಳಿದರೆ, ಅಂತಹ ಪರಿಸ್ಥಿತಿಯಲ್ಲಿ ನೀವು ಕಾಲು ಉಳಿಸೋ ಪ್ರಯತ್ನ ಎಲ್ಲದೂ ಮಾಡಬೇಕು, ಯಾರೂ ಮಾಡಬಾರ್ದು ಅಂತ ಹೇಳುವುದಿಲ್ಲ. ಬಟ್ ಆ ಪರಿಸ್ಥಿತಿ ಆಗುವ ಸಾಧ್ಯತೆ ಸಾಕಷ್ಟು ಕಮ್ಮಿ.
ಪೇರೆಂಟ್ಸ್ಗೆ ಒಂದ್ಸಲಿ ಫೋನ್ ಮಾಡಿದ್ದು
ಖಂಡಿತವಾಗಿಯೂ ಇದು ನಾನು ಈಗಲೇ ನೀವು ಡಿಸೈಡ್ ಮಾಡಬೇಕು ಅಂತ ಹೇಳ್ತಾ ಇಲ್ಲ. ನೀವು ಬೇರೆಯವರ ಒಪಿನಿಯನ್, ಬೇರೆಯವರ ಅಭಿಪ್ರಾಯ ತಗೊಳ್ಳೋದಾದರೆ ಬೇರೆಯವರ ಅಭಿಪ್ರಾಯ ಕೂಡ ತಗೊಳ್ಬೋದು. ನಮ್ಮ ಕಡೆಯಿಂದ ವೆಯ್ಟ್ ಮಾಡಿ ವಿಶೇಷ ಏನು ಉಪಯೋಗ ಇಲ್ಲ ಅಂತ ನನ್ನ ಅನಿಸಿಕೆ. ಆ ಕಾರಣಕ್ಕೆ
ಆದಷ್ಟು ಬೇಗ ಬಂದರೆ ಒಳ್ಳೆಯದು.
ನಾವು ಟೈಮ್ ಕೊಟ್ಟು ನೀವು ಮತ್ತೆ ಬರೋದು ಎಲ್ಲ ಆದಷ್ಟು ಬೇಗ
ತಕ್ಷಣ ಏನಿಲ್ಲ, ತಕ್ಷಣ ಈಗ ಆ ಕಾರಣಕ್ಕೆ ಬೇಕಾಗಿ ನೀವು ಬೇರೆಯವರ ಅಭಿಪ್ರಾಯ ತಗೊಳ್ಳೋದಾದರೆ ನನ್ನಿಂದ ಏನೂ ಅಭ್ಯಂತರ ಇಲ್ಲ. ಬಿಕಾಸ್ ಟ್ರೀಟ್ಮೆಂಟ್ ತಗೊಳ್ಳೋರು ನೀವು, ಖರ್ಚು ಮಾಡೋರು ನೀವು, ರಿಸ್ಕ್ ತಗೊಳ್ಳೋರು ನೀವು. ಸೊ ಈ ಕಾರಣಕ್ಕೆ ಬೇಕಾಗಿ ನೀವು ಬೇರೆಯವರ ಕಡೆಯಿಂದ ಅಭಿಪ್ರಾಯ ತಗೊಳ್ಳೋದ್ರಲ್ಲಿ ನನ್ನ ಕಡೆಯಿಂದ ಏನು ಅಭ್ಯಂತರ ಇಲ್ಲ. ಬಟ್ ನೀವು ರೆಡಿ ಇದ್ದೀರಾ? ನನ್ನ ಪ್ರಕಾರ, ನನ್ನ ಅಕಾರ್ಡಿಂಗ್ ಟು ಮೈ ಒಪಿನಿಯನ್ ಇಲ್ಲ ನಿಮಗೆ. ಆ್ಯಕ್ಚುಲಿ ದೇರ್ ಇಸ್ ನೋ ಅದರ್ ಆಪ್ಷನ್. ಯು ಹ್ಯಾವ್ ಟು ಗೋ ಫಾರ್ ಆ್ಯನ್ ಬಿಲೋನಿ ಆಂಪ್ಯುಟೇಷನ್ ಇನ್ ದಿಸ್ ಕೇಸ್.
Okay. Setting was chaotic. You take this, no problem.
Like there was no proper who took the lead, like one sir, like one ma'am, like one when in between he was explaining, other one was interrupting among the doctors.
So you did not understand who is the lead doctor?
Yes, lead doctor. And the both were standing. They were not in the same eye contact level. Like the both doctors were on.
Very good.
There is a reason for that.
Yeah, I will say. We'll come back to that. We'll come back.
That is not.
I know. We'll come back. Anything else, plus or minus?
And even exact scenario was not explained to the patient directly. The amputation was like told in before the complications as such. Then there was no bystander along when explained directly to the patient. It was explained that he has to undergo later on. Who's close relative rather than the neighbors and who is coming.
Okay. Now they want to respond and then we'll go quickly follow. Yeah, sure. Yeah. You want to tell something about what standing and sitting?
No, this is not nothing. But I did ask for a bystander.
No, standing and sitting.
Standing, I think it's a bedside. Basically, the scenario is bedside. The patient is lying down.
Okay, you assume that the patient was lying down and they just came to the bed and you called this one. Okay, fine. Yes, sir.
Probably the best option is for the doctor to sit down, to have the same level of the patient rather than keeping a standing position, because patient will feel subordinated and you will be a master there.
I don't say this is right or that is right or this is wrong or that is wrong, because world is so wide. Everybody can have their own perceptions. At times that could be right, at times this could be right. That's what at the initial beginning we told, there are few persons here who are better faculty than what we are. We are only opening up a Pandora's box for you to think at situations that could be right, this could be right. There's nothing right. This is the way to go forward. Hope all of you are clear. Sir is also right, you are also right, you are right. Anything else?
A doctor asked the expectation from the patient. Like that is important. What is patient expecting out of the treatment?
Good.
Which is positive.
I have one comment, quick comment. He did tell about taking second opinion. How many of you actually offer second opinion? When you tell, you can even seek second opinion. This is what I feel. Are you open to? Do you actually tell that? Raise your hands. I can see 3, 5, 6, 7, 8, 10 hands. Please make sure this is a world where there is lot of doctors, lot of options. In one street you have 3 medical colleges. It's high time that we tell them very openly and tell them, you are free to take second opinion. This is best what we can offer. And there was one question they asked, if you go to other hospital, will I be fine? You can tell you what you know. There could be centers where they could probably offer, or there could be centers. There is no centers which, being truthful at that particular point of time is the best thing to do, because patients always will come back if you are truthful. If not for that ailment, they will come for tomorrow for some other ailment only to you. As long as you are truthful, as long as you are very open. If you say no, there is nothing else, and then they go and do something which actually saved their life, not only you lose that patient, you lose 100 more patients out. One bad patient is like your 1,000 visiting cards of you which you have printed and kept in a pocket to be distributed. I mean, this is what life is as a practitioner. So be very open, be very careful when what you talk. Anything else, Harsha, you want to tell?
No, the real life scenario kind of thing where the bystander comes running around and said, what happened? This is very common. We start sitting and already finished 5 minutes talking to the patient, somebody relatives pitch in and talking. So always wait, give a time. Never ever talk to them on the corridor, especially breaking bad news. Never ever in coming out of ICU, they are standing with you. What happened? They will call you and tell you something, today's bad thing happened or whatever. Don't do that. Always sit in your room and talk to them. 1, 2. Always wait for them to tell, is there anyone is coming? If they have come late, let them sit outside, not to come in. If you have given the option, then they came in late, give time for them, tell them that we will talk to you, but we have already talked to them, you can't check with them, we will come back to you tomorrow, please come back. So that's...
Just to add to that.
India, our culture is that every day there is a new relative.
We have to accept that. It's a part of our culture. We can't help it.
That's the point I was trying to make as well. Who is the most appropriate person to be with the patient? That is something that we need to think about as well. In this scenario, the bystander seemed flustered when he came in, but of course he settled down as the interview went on. But sometimes patients' families may be more anxious than the patient themselves, and is that the right person to provide support to the patient and be there while bad news is given to the patient? That is something that we need to think about as well. And like Sir said, you see who is the most important person in the family, who is the decision-making person in the family, and involve them in breaking bad news early on. That perhaps might reduce some of those issues.
That becomes a problem. I think the patient won't know the truth, but the doctor will know all about the patient.
Even neighbor is also a family. So many times.
This also, particularly the amputation, was a scenario where, normally we say for breaking bad news, take your time. But here is a situation where you don't have too much time. And it is also a situation where you need to have good rapport with your colleagues, where you want to ask for a second opinion because it is medically safer. When you are taking a limb away, you have to have 2 consultants signing on it as well. So it is almost necessary that you ask for a second opinion. In the heat of the situation, it is not a situation where you have breathing time as well.
The first postnatal examination of a newborn baby boy born to a primigravida mother. During the assessment, you notice that the baby shows clinical features suggestive of Down syndrome. Your task is to communicate these findings to the parents.
Please.
Good morning, doctor. I'm Niveda. What is wrong with my child? The doctor told me to come.
Yes, please. I'll tell you about it. Please come. Please sit. How are you feeling now? You're all right?
I'm good.
So, my name is Dr. Dhritiman. I'm a junior resident in the Department of Pediatrics.
Hello.
So, during our routine rounds, I found that there were some few things that were not looking normal in your child when compared to other children. Have you noticed these changes in the child after the delivery?
No, doctor, there's nothing wrong with my child. My child is completely fine.
Okay. During your antenatals, before your pregnancy, were the scans done regularly?
Everything was done.
Did the doctor tell you any problems were there in the scans or anything like that?
The starting few scans, everything was fine. Then we have some financial problems. So I think the last scan at the 6th month we didn't do. Anyways, everything was normal.
Okay, so you have not done the last scan?
Yeah.
Okay. So what has happened is during the delivery, the baby was born normally, as you know. We have attended the delivery. But 24 hours later, that is today, when we examined the child, we found a few abnormal findings in the child. That is, which when compared to a normal newborn, it looks a little abnormal. So if you take all that into account, it fits into something called as Down syndrome. Okay, so what is this Down syndrome is?
So I have my sister, my husband is out of town.
Yeah,
Can I call
yeah, sure, you can call her.
Grishma, can you please come? Good morning, doctor.
Oh, good morning. Okay, so how is she related to you?
She's my sister.
Okay, so what do you do for a living?
I'm housewife.
Okay.
I've studied till 3rd class.
Okay. So I hope you can understand what I'm telling.
Yes.
Okay.
I'll try my best.
Yeah. So thing is, like I told you earlier, when we examined the child, we found a few abnormalities in the child's facial features. That as I was telling, we found a few abnormalities, and it fits a genetic disorder. I hope you know what genetic disorder is. So genetic disorder is the baby is born with a few problems, inherently born with a few problems. So because of that, when you look at all the features together, it fits something called Down syndrome.
So it is a genetic disorder. So to confirm this, we have to do a few blood tests, a few scans, and then we can confirm and tell that it is Down syndrome or if it is some other syndrome.
But doctor, when children are born, they have small eyes, some small, that will resolve in 1-2 years, right?
Yes, but
there's no problem as such. Why are you talking that my child is only so,
Yeah. So thing is, most children have these features like little variations, but in this particular syndrome, it is very evident. So it is ideally advisable that you go ahead and do this set so that we can confirm. If the tests come out negative, well and good, you don't have to worry about it. But if the tests come out positive for Down syndrome, then this child will require further test as the child grows. It is not something that is going to go away. So this child may have to live with it for the rest of his life. As the child grows, he'll require treatment, he'll require investigations, and he'll require follow-up regularly.
So you're saying my child has some problem which is not solvable?
ಅದು ನಾವು ಹೇಳಲಿಕ್ಕೆ ಆಗೋದಿಲ್ಲಮ್ಮ, ಅದು ಯಾರಿಗೆ ಸಹ ಬರ್ಬೋದು. ಇಟ್ ಈಸ್ ಅದಕ್ಕೆ ಜೆನೆಟಿಕ್ ಡಿಸಾರ್ಡರ್ ಅಂತ ಹೇಳೋದು. ಅದು ಹುಟ್ಟುವಾಗ ಅನುವಂಶಿತ ಪ್ರಾಬ್ಲಮ್ ಅಂತ ಹೇಳ್ತಾರೆ. ಸೊ ಅದು ಹುಟ್ಟುವಾಗಲೇ ಬರುವ ಪ್ರಾಬ್ಲಮ್, ನಿಮ್ಮ ಅಕ್ಕನಿಂದ ಬಂದದಂತ ಅಲ್ಲ, ಅದು ಯಾರಿಗೆ ಸಹ ಬರುವ ಚಾನ್ಸಸ್ ಇರ್ತದೆ. ಅದಕ್ಕೆ ನಾವು ಹೇಳೋದು ಒಂದು ಬ್ಲಡ್ ಟೆಸ್ಟ್, ಜೆನೆಟಿಕ್ ಟೆಸ್ಟ್ ಅಂತ ಇದೆ, ಅದನ್ನು ಮಾಡಬೇಕಾಗ್ತದೆ. ಆ ಜೆನೆಟಿಕ್ ಟೆಸ್ಟಲ್ಲಿ ಏನಾದರೂ ತೊಂದರೆ ಉಂಟಂತ ಬಂದರೆ ಅದನ್ನು ನಾವು ಡೌನ್ ಸಿಂಡ್ರೋಮ್ ಅಂತ ಹೇಳ್ಬೋದು. ಫ್ಯಾಮಿಲಿಯಲ್ಲಿ ಇರಬೇಕಂತ ಇಲ್ಲಮ್ಮ, ಅದು ಶೀತ ಜ್ವರ ಆಗಿ ಬರೋದಲ್ಲ, ಫ್ಯಾಮಿಲಿಯಲ್ಲಿ ಇರ್ತದೆ ಅಂತ ಅಲ್ಲ, ಅದು ಯಾರಿಗೆ ಸಹ ಬರೋದು. ಅದಕ್ಕೆ ನಾನು ಹೇಳಿದ್ದು ಈ ಟೆಸ್ಟ್ ಮಾಡಿದ ಮೇಲೆ ನಾನು ನಿಮಗೆ ಹೇಳ್ಬೋದು. ಈಗ ನಾನು ನೋಡುವಾಗ ಹೀಗೆ ಉಂಟಂತ ಹೇಳ್ತಿದ್ದೇನೆ, 100% ಈ ಮಗುವಿಗೆ ಉಂಟಂತ ಹೇಳೋದಿಲ್ಲ. ಪೂಜೆ ಮಾಡಿ ನಾರ್ಮಲ್ ಆಗ್ತಿದ್ರೆ ಎಲ್ಲರಿಗೆ ಇದೇ ಮಾಡ್ಬೋದಿತ್ತಲ್ಲಮ್ಮ. ಬಟ್ ಈಗ ಈ ಪ್ರಾಬ್ಲಮ್ ಉಂಟು, ಮಗುಗೆ ಈಗ ತೊಂದರೆ ಇರುವ ಚಾನ್ಸ್ ಉಂಟು. ಅದಕ್ಕೆ ಟೆಸ್ಟ್ ಮಾಡೋದು ಒಳ್ಳೆಯದು. ಯಾಕೆಂದರೆ ಇಫ್ ವಿ ಡೋಂಟ್ ಡೂ ದಿಸ್ ಟೆಸ್ಟ್ ಆ್ಯಂಡ್ ಇಫ್ ಲೇಟರ್ ಇಫ್ ದೇರ್ ಆರ್ ಪ್ರಾಬ್ಲಮ್ಸ್ ದೆನ್ ಮಗುಗೆ ಈ ಡೌನ್ ಸಿಂಡ್ರೋಮ್ ಫಸ್ಟ್ ಉಂಟಾ ಇಲ್ವಾ ಅಂತ ನೋಡುವ. ಇದ್ದರೆ ಮತ್ತೆ ಎಂಥ ಪ್ರಾಬ್ಲಮ್ ಬರ್ತದೆ ಅಂತ ನಾವು ಮತ್ತೆ ಡಿಸ್ಕಸ್ ಮಾಡ್ತೇವೆ. ನಿಮಗೆ ಬೇಕಾದರೆ ಸೆಕೆಂಡ್ ಒಪಿನಿಯನ್ ತಗೊಳ್ಬೋದು. ನೀವು ಡಿಸ್ಚಾರ್ಜಿಗೆ ಪ್ಲ್ಯಾನ್ ರೆಡಿ ಉಂಟು. ಸೊ ನೀವು ಹೋಗಿ ಬೇರೆ ಡಾಕ್ಟರ್ಸ್ ಹತ್ರ ತೋರಿಸ್ಬೋದು. ಇಲ್ಲಿ ಹಿಂದೆ ಬಂದು ಇಲ್ಲೇ ಟೆಸ್ಟ್ ಮಾಡ್ಬೋದು, ಅಲ್ಲ ನಿಮಗೆ ಬೇಕು ಎಲ್ಲಿದ್ದರೆ ಸಹ ಟೆಸ್ಟ್ ಮಾಡ್ಬೋದು. ಮಗುದು ಕಂಡೀಷನ್, ನಾವು ಏನೆಲ್ಲ ಮಾಡಿದ್ದೇವೆ, ಏನು ಟೆಸ್ಟ್ ಮಾಡಿದ್ದೇವೆ, ಏನು ಟೆಸ್ಟ್ ಮಾಡಬೇಕು, ಅದೆಲ್ಲ ನಾವು ಬರೆದು ಕೊಡ್ತೇವೆ ಡಿಸ್ಚಾರ್ಜ್ ಸಮರಲ್ಲಿ. ಸೊ ನೀವು ಮತ್ತೆ ಡಿಸೈಡ್ ಮಾಡಿ, ನೀವು ಬೇರೆಯವ್ರ ಹತ್ರ ಮಾತಾಡಿ ಡಿಸ್ಕಸ್ ಮಾಡ್ಬೋದು. ಇಟ್ಸ್ ನಾಟ್ ಎನ್ ಎಮರ್ಜೆನ್ಸಿ, ಈಗಲೇ ಮಾಡಬೇಕಂತೇನಿಲ್ಲ, ಬಟ್ ಮಾಡಿದರೆ ಒಳ್ಳೆಯದು. ಹೌದು, ಇಲ್ಲಿ ಮಾಡ್ತಾರೆ, ಇಲ್ಲೆಲ್ಲ ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಟೆಸ್ಟ್ ಮಾಡ್ತಾರೆ, ನಿಮಗೆ ಬಿಟ್ಟದ್ದು. ನೀವು ಇಲ್ಲೇ ಮಾಡಬೇಕಂತ ಏನು ಫೋರ್ಸ್ ಮಾಡ್ತಾ ಇಲ್ಲ, ಬಟ್ ಹೀಗಿರುವಾಗ ಈ ಟೆಸ್ಟ್ ಮಾಡೋದು ಒಳ್ಳೆಯದು. ಖರ್ಚು ಈಗ ಇನಿಷಿಯಲಿ ಸ್ವಲ್ಪ ಖರ್ಚು ಆಗ್ತದೆ, ಮತ್ತು ಮಗುದು ಎಂಥ ತೊಂದರೆ ಉಂಟು ನೋಡಿ ಅದರ ಮೇಲೆ ಬೇರೆ ಟೆಸ್ಟ್ ಮಾಡು. ನಾವೆಲ್ಲ ಟೆಸ್ಟ್ ಒಮ್ಮೆಲೆ ಮಾಡಲಿಕ್ಕೆ ಹೋಗೋದಿಲ್ಲ. ಓಕೆ,
Good performance. Yes, well done. I was discussing backstage. At the end, it becomes 100% enactment or 100% clinical improvisation in soft skills. All have become perfect in doing the things. Yes, answer.
Yes, sir. Doctor made patient to sit and then started doing conversation. That's
Pardon?
Doctor made to sit the patient, sir, first.
Okay, you make the patient comfortable by asking them to sit on the chair and then start the conversation. Yes.
One more bad thing is that doctors himself would have called for any other relative instead of mother calling.
Okay. Hope all of you get. It can be either ways, but then you always take the lead. I mean, as a clinician, we take the lead to call because you don't want to waste your time again speaking the whole story, especially in casualty, in ICU. It is better to call 2 or 3 people who are daily in contact with you. Call them, talk to them together rather than one person, and then one more person comes after 5 minutes. As Harsha said, 5 minutes later they'll come. It becomes, okay, next.
The doctor also explored what the mother knows already about the Down syndrome.
Good to know where to start from. Yes.
And then explained in a sequence what is a future plan in plain language.
Plan of action, yes.
And he also got another person on board to support the mother.
Okay.
And then and when the doctor was not sure what to say, he admitted the ignorance and then said,
okay, at times trying to be honest by trying to say, I am not aware as of now. Yes. Okay, is also a good thing to do.
And given a chance for a second opinion because it is a cold case.
Okay.
Then
any flop side? I mean,
emotions and empathy, we consider the voice modulation could be a little more modified, like it was more of a monotonous voice, and the moment of silence was not much given for the patients to
It's all right, but this scenario, because of real scenario, probably would have been different, but I agree. One thing is, looking at the background, we are not checking the background before we going and talking to them. He asked about in between, what do you do for living? So sometimes the knowing the background, as much as information, if you know about that patient when you talk to them, that is very positive. So when you say that you are doing this and etc., is there anything else you want me to tell or anything you want to add about yourself? Then they know that. So he's interested, he has talked, he knows about my problems. So knowing background check before, that is a setup where you and understanding. That's two extremely important steps in the breaking bad news. So you need to know the family, know the profession what they are in. The information, how much you give also depends upon the profession they are in also.
One thing to improve upon probably is that the person who went to support the mother was very anxious about what to be done next and what will be the long-term prognosis of the Down syndrome. But the doctor has not explained further. So keeping the relatives anxious until the diagnosis is getting confirmed rather than reassuring the patient what to do.
Okay. But I think primarily because of paucity of time they were trying to do. But it's a good point to note. Anything else from other batches?
Yeah, even though there is a bad news, what is the positive? Don't worry, we are here to help you. There is a team to help you. If there, we can take care of this baby. That's kind of probably reassuring words will make them comfortable.
Okay.
The manner of conversation was excellent. Yeah. Just one minor point I wanted to highlight is when the sister came in, it's always best to identify the sister's name as well, because after this you will be documenting the breaking bad news, and it's important to document who was present. So always important to find out the name and how they are related. You asked how they are related, but the name as well, because documentation purpose that will become important then.
This very much true, because as Ravi sir said that time, today before the surgery one person bystander will be there. After your procedure, when there is a complication, somebody else will come. So you should know whom you are. You'll say somebody else had come, but who? Unless you document in the case, this particular person was so and so related and we have spoken, can we at least talk to them that we have explained, reassured, confirmed? That's always possible. But if you don't document, you are not going to remember. At least I don't know. I can't remember so nicely whom I have spoken, what is the name and what is the relationship. Becomes little better to document.
It has happened to our Dr. Satish Rao sir when he was in court. He was asked who was present, and he said patient's brother was present. And the patient said, I've got 5 brothers. Which brother was present? And the name was not documented. So it can become a problem if you don't document who exactly and how they're related.
During COVID times, the relatives were actually hired relatives.
They were not even real relatives.
Oh.
The patients would come from faraway places, dump their patient here and run away back, hire somebody from Ullal and say, you attend the counseling every day and give us a call and tell us. And we came to know this because every day we're telling this person, the so-called relative, saying that your patient is serious, your patient is more serious, your patient is even more. Every day we're telling them more and more. On the 5th day we said your patient has died. Then the real relative calls up and says, every day you were saying patient is very good, now suddenly how the patient died. And then we showed them how we went on counseling and how we were saying it's very bad. And then those people said that this person here has given them wrong information. So we are communicating bad news.
Translator has become an interpreter.
He's communicating good news. So now we then had to think about, should we ask patients' relatives to submit Aadhaar card?
Sometimes goes to that.
It's difficult to stoop to that level, but then sometimes we don't know tomorrow what is there for us. Any other quick comments on that, or we'll go to the next scenario?
Last scenario.
Last scenario? Yes, please. Okay. New person.
This is scenario 3. You are Despite intensive monitoring and treatment, the patient suddenly developed severe desaturation and bradycardia and unfortunately could not be revived. Your task is to inform the patient's relatives about his death in a compassionate, professional and empathetic manner.
ಏನಾಯ್ತು?
ನಮಸ್ತೆ.
ನಮಸ್ತೆ.
ನಿಮ್ಮ ಹೆಸರೇನು?
ನಾನು ಲಕ್ಷ್ಮಿ.
ನೀವು ವಿನೋದಿಗೆ ಏನಾಗಬೇಕು?
ಅವ್ರ ಹೆಂಡತಿ.
ಅವ್ರ ಹೆಂಡತಿಯಾ? ಓಕೆ.
ಏನಾಯ್ತು ಡಾಕ್ಟರ್?
ಏನಿಲ್ಲ, ನಾನು ಡಾಕ್ಟರ್ ಸಿರಿ ಅಂತ. ವಿನೋದಿಗೆ ಟ್ರೀಟ್ ಮಾಡ್ತಾ ಇರೋ ಡಾಕ್ಟರ್.
ಹೌದಾ?
ಅವ್ರು ICU ಅಲ್ಲಿ ಇದ್ದಾರಲ್ಲ?
ಹೌದೌದು.
ಓಕೆ.
ಮೊನ್ನೆ ಬಂದಿದ್ವಿ ನಾವು ಇಲ್ಲಿ.
ಹೌದಾ? ಓಕೆ. ಅವರ ಕಂಡೀಷನ್ ಬಗ್ಗೆ ನಿಮ್ಗೆ ಏನು ಗೊತ್ತು?
ನನಗೆ ಸ್ವಲ್ಪ ಗೊತ್ತು. ನಮ್ಮ ಅಪ್ಪ, ಅವ್ರ ಅಪ್ಪ ಮತ್ತು ನನ್ನ ಮಗ ಇಲ್ಲಿದ್ದಾರೆ. ಕರೀಲಾ?
ಹಾಂ, ಕರೀರಿ ಅವರನ್ನು. ನಮಸ್ತೆ, ಕೂತ್ಕೊಳ್ಳಿ. ಹಾಂ, ವಿನೋದ್ ಕಂಡೀಷನ್ ಬಗ್ಗೆ ನಿಮಗೆ ಏನು ಗೊತ್ತು ಇಷ್ಟವರೆಗೆ?
ನಾವು ಮೊನ್ನೆ ಇಲ್ಲಿ ಆಸ್ಪತ್ರೆ ಬಂದಿದ್ವಿ. ಅವರಿಗೆ ಒಮ್ಮೆಲೆ ಕೆಲಸ ಮಾಡುವಾಗ ಉಸಿರಾಡ್ಲಿಕ್ಕೆ ಕಷ್ಟ ಆಯಿತು. ಮತ್ತೆ ಅಪ್ಪ ಹೇಳಿದ್ರು ಆಸ್ಪತ್ರೆ ಕರ್ಕೊಂಡು ಹೋಗು ಅಂತ. ಅದಕ್ಕೆ ಇಲ್ಲಿ ಬಂದ್ವಿ. ಅವ್ರು ಹೇಳಿದ್ರು ಸೀರಿಯಸ್ ಆಗಿದೆ, ಉಸಿರಾಡ್ಲಿಕ್ಕೆ ಆಗೋದಿಲ್ಲ, ಮಷೀನಲ್ಲಿ ಇಡಬೇಕು ಅಂತ ಹೇಳಿದರು.
ಹಾಂ, ಓಕೆ. ಸೊ ನಿಮ್ಗೆ ಆಲ್ರೆಡಿ ಗೊತ್ತಲ್ಲ, ಅವರಿಗೆ ಉಸಿರಾಟದ ತೊಂದರೆಯಿಂದ ನಿಮೋನಿಯಾ ಆಗಿತ್ತು. ನಿಮೋನಿಯಾ ಟ್ರೀಟ್ಮೆಂಟ್ ನಡೀತಾ ಇತ್ತು. ಮತ್ತು ಮೊನ್ನೆ ಬ್ಲಡ್ಡಲ್ಲಿ ಆಕ್ಸಿಜನ್ ಕಮ್ಮಿ ಆಗಿ ಅವರಿಗೆ ಉಸಿರಾಡ್ಲಿಕ್ಕೆ ತೊಂದರೆ ಆಗಿ ವೆಂಟಿಲೇಟ್ರಿಗೆ ಹಾಕಬೇಕಾಯಿತು. ಓಕೆ, ನಿನ್ನೆಯಿಂದ ಅವರ ಕಂಡೀಷನ್ ಸ್ವಲ್ಪ ಕ್ರಿಟಿಕಲ್ ಆಗಿದೆ. ಹೌದು, ಅವರದ್ದು ಹಾರ್ಟ್ ಬೀಟ್ ಸ್ವಲ್ಪ ಕಮ್ಮಿ ಆಗಿತ್ತು. ಇವತ್ತು ಅವರ ಹಾರ್ಟ್ ಸ್ಟಾಪ್ ಆಗಿತ್ತು.
ಏನು ಮಾಡಿದ್ದು?
ಏನಿಲ್ಲ, ಅವರ ಬ್ಲಡ್ ಆಕ್ಸಿಜನ್ ಲೆವೆಲ್ ಕಮ್ಮಿ ಆಗಿತ್ತು. ಅದರಿಂದ ಅವರ ಹಾರ್ಟಿಗೆ ಎಫೆಕ್ಟ್ ಆಗಿ ಹಾರ್ಟ್ ಬೀಟ್ ಸ್ಟಾಪ್ ಆಗಿದೆ. ನಾವೆಲ್ಲ ಪ್ರಯತ್ನ ಮಾಡಿದ್ವಿ, ಅದು ನಡೀತಾ ಇತ್ತು, ಒಂದು 30 ನಿಮಿಷ ನಡೀತು. ಆದರೂ ಸಹ ಅವರ ಹಾರ್ಟ್ ಬೀಟ್ ನಮಗೆ ವಾಪಸ್ ತರಲಿಕ್ಕಾಗಲಿಲ್ಲ, ಅವರನ್ನು ಉಳಿಸ್ಲಿಕ್ಕಾಗಲಿಲ್ಲ ನಮಗೆ.
ಅಂದರೆ ಏನು ಡಾಕ್ಟರ್, ಏನು ಹೇಳ್ತಾ ಇದ್ದೀರಾ?
ಹೌದು, ನಿಮಗೆ ಗೊತ್ತಲ್ಲ ಅವರ ಕಂಡೀಷನ್. ಅವರ ಬ್ಲಡ್ಡಲ್ಲಿ ಆಕ್ಸಿಜನ್ ಕಮ್ಮಿ ಆಗಿ ಅವರಿಗೆ ವೆಂಟಿಲೇಟರ್.
ಇವತ್ತು ಬೆಳಿಗ್ಗೆ ನಾನು ನೋಡಿದ್ದೇನೆ, ಅವ್ರ ಕಣ್ಣು ಓಪನ್ ಮಾಡಿ ನನ್ನ ನೋಡಿದ್ದಾರೆ.
ಹೌದು, ಅದು ಟ್ರೀಟ್ಮೆಂಟ್ ಎಲ್ಲ ನಡೀತಾ ಇತ್ತು. ಆದರೆ ಅವರು ಟ್ರೀಟ್ಮೆಂಟಿಗೆ ರೆಸ್ಪಾಂಡ್ ಮಾಡಲಿಲ್ಲ. ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಸ್ ಎಲ್ಲ ಕೊಡ್ತಾ ಇದ್ವಿ, ಆದರೂ ಅವರು ರೆಸ್ಪಾಂಡ್ ಮಾಡಲಿಲ್ಲ.
ಇದು ಸಾಧ್ಯ ಇಲ್ಲ. ಏನಾಯಿತು ಅವರಿಗೆ?
ಅವರ
ಏನಾದರೂ ಮಾಡಿ ಡಾಕ್ಟರ್ ಪ್ಲೀಸ್.
ಅಲ್ಲ, ನಾವು ಪ್ರಯತ್ನ ಮಾಡಿದ್ವಿ. ಅವರ ಹಾರ್ಟ್ ಬೀಟನ್ನು ವಾಪಸ್ ತರಲಿಕ್ಕೆ ಟ್ರೈ ಮಾಡಿದ್ವಿ, ಒಂದು 30 ನಿಮಿಷ ಟ್ರೈ ಮಾಡಿದ್ವಿ. ಆದರೆ ನಮಗೆ ಉಳಿಸ್ಕೊಳ್ಳಿಕ್ಕೆ ಆಗಲಿಲ್ಲ, ಅವರು ಟ್ರೀಟ್ಮೆಂಟಿಗೆ ರೆಸ್ಪಾಂಡ್ ಮಾಡಲಿಲ್ಲ. ನಾವು ನಮ್ಮ ಪ್ರಯತ್ನ ಎಲ್ಲ ಮಾಡಿದ್ದೇವೆ ಸರ್.
ಏನು ಮಾಡೋದು ನಂಗೆ ಗೊತ್ತಾಗ್ತಾ ಇಲ್ಲ.
ನೀವು ಧೈರ್ಯ ತಗೊಳ್ಬೇಕಮ್ಮ.
ಅಯ್ಯೋ ದೇವರೇ,
ಈಗ ನಮ್ಮ ಕೈಲಿದ್ದ ಎಲ್ಲ ಪ್ರಯತ್ನಗಳು ನಾವು ಮಾಡಿದ್ದೇವೆ. ಹಾರ್ಟ್ ನಮಗೆ ವಾಪಸ್ ಹಾರ್ಟ್ ಬೀಟ್ ಇನ್ನೇನು ಮಾಡಲಿಕ್ಕೆ ಆಗೋದಿಲ್ಲ. ವೆರಿ ಸಾರಿ.
ಏನು ಮಾಡೋದು ನಂಗೆ ಗೊತ್ತಾಗ್ತಾ ಇಲ್ಲ. ಅಯ್ಯೋ ದೇವರೇ, ಒಬ್ಬನೇ ಮಗ ಇರೋದು, ಅವನು ಸ್ಕೂಲಿಗೆ ಹೋಗೋದು, ಏನು ಮಾಡೋದು ನಂಗೆ ಗೊತ್ತಾಗ್ತಾ ಇಲ್ಲ.
10ವರೆಗೆ ಅವರ ಹಾರ್ಟ್ ಸ್ಟಾಪ್ ಆಗಿದೆ. ನಿಮಗೆ ಏನಾದರೂ ಹೆಲ್ಪ್ ಬೇಕಿದ್ರೆ ನಮ್ಮ ಹತ್ರ ಕೇಳಿ. ಆಯಿತು ಆಯಿತು, ಸರಿ, ಆಯಿತು ಆಯಿತು. ನಿಮ್ಗೇನಾದರೂ ಹೆಲ್ಪ್ ಬೇಕಿದ್ರೆ ಹೇಳಿ. ಟ್ರಾನ್ಸ್ಪೋರ್ಟ್ ಇದು, ಆ್ಯಂಬುಲೆನ್ಸ್ ಇದು, ಪೇಪರ್ ವರ್ಕ್ ಇದು, ಅದೆಲ್ಲ ನಾವು ಮಾಡಿಕೊಡ್ತೇವೆ. ಓಕೆ, ನೀವು ಧೈರ್ಯ ತಗೊಳ್ಳಿ, ಅವರಿಗೆ ಸಹ ಧೈರ್ಯ ಹೇಳಿ. ಆಯಿತಾ?
Patient sit and introduction of patient, like who is she, starting to setup was
yes. The setup. Okay, good.
Then
so you are now convinced that setup was the most important because it's the last scenario, right? Correct?
Yes.
Last. So we are summarizing in the same go. Setup is the most important thing. Please ensure proper setup before you start the spikes. Yes.
And she asked about patient, whether patient relative know about the patient condition. If she doesn't know, call other, like who knew the patient better.
Second point, very good.
Then explain sequence of treatment, what they did till now properly.
How they tried their best to save the patient. Yes, okay.
Then after breaking the bad news, she gave a silent, like to perceive the
allow the
patient.
emotions to drain off. Okay.
Then she, at the end, the follow-up care, like what help they need regarding paperwork or everything.
Okay. Even though it's a death, still there is something more to be done, like taking home, documentation, etc., billing, whatever. She's trying to offer. Right. Good. Then. Even in death, there is a ray of hope.
Yes.
I'll tell you why this is so important. Other day, I think you may be aware there was a cadaver donation, bone donation happening. And with all the efforts of me sitting there and telling my medical superintendent there with me, next to me, we wanted to ensure the death summary of the patient is ready before the patient takes off. And we had the patient shifted right from the cadaver donation in the OT to the ambulance. Shifted, yes, you can go. Where is the death summary? No death summary. What a sad story, you see. We are all fumbling. We fumbled for almost 30 to 40 minutes, then to realize that death summary was not written in a proper format. I mean, it occurs, in spite of everything it occurs, but then a good offering, even in the death, also matters at time. Yes. Anything else? Any other things you want to add? Negative side, everything positive. Right?
She could have asked initially if any other relative.
Okay, you could have offered if you want to talk somebody else together. Okay, good. Anything else?
Questions for which there are no answers. Questions asked which have no answers, for which you should not even attempt to answer. You can only keep quiet.
Any Harshad, you agree with that or anything?
Now, again, another thing was the party was a very understanding party. How many parties? Can we have a similar situation where the party is not so understanding? How would you have tackled that? So that is where, try and get some negatives from that perspective.
What he is trying to say is crowd management.
Yeah.
Unruly, angry, non-understanding patient party next to it. How would you handle better? Anybody, it could be from anybody. Yes.
So how do we prepare?
If you
Because this doctor was alone at the end of the day. Yeah, there was just one security who announced, and we don't even know whether he was in the room. If he was in the room, it was probably better for her to take permission for him to be there.
Yes, Ritik, we'll come back to it.
This happens to us frequently, sir. Suddenly, children go bad and we may not be able to save the child. So we expect things to go wrong. So we preempt.
What do you do then? We want to learn from you.
Yeah, we preempt the worst case. So we call the security in beforehand, lock the doors, and we tell the patient party that this is the thing. And we call a bystander who has been there regularly before also.
Yes.
I would have had a brief with the junior resident who called the patient party just before counseling. How is the patient party, how irritable are this thing? I would have definitely had a brief with the junior resident.
Okay, you can preempt, what is the response going to occur before even you actually begin the conversation by talking and trying to know from the other people who are in touch with the patient party. That is also a good thing to smoothly sail through that difficult situation.
Because they spend all the time.
Yes.
We actually practice it. It's very useful. They will have a better sense than us about the patient.
Yes, very good. Yes, sir.
Instead of counseling right after the death, I think we should counsel even before, even starting CPR only. We have to call the patient and tell them that patient is very critical, so that we give them time to.
I think what you said is perfectly correct, but there is a scenario. It's a scenario. It's a scenario. Yeah,
No. His point is, he said about talking to them at the time of resuscitation. Fair enough. Many people in our setting, they do, as soon as they entered into the ICU, they give very bad prognosis. So that if survived, the doctors are God. If they gone. So this in fact, I am told by my colleague that you don't tell them that child is serious. This is exactly what I have been told when I started.
This is particularly true of us surgeons. See, because if I've operated and the patient has gone bad, I don't want to give a bad prognosis by nature, because I've operated. I have that in me. So the moment the patient goes, there are all situations in that. The patient goes to ICU, goes surgery for some reason, and I would have told, the surgery's gone very well and this and that. And then intensivist, any intensivist.
Blame the
So by definition, intensivists are trained to give a bad prognosis. So sometimes I ask them, and you feel bad, and sometimes the patient will recover. A simple minor aspiration or something like that, a young healthy patient is going to recover. But even then, you see many of our intensivists don't give a very good prognosis because of that.
fair enough, that when gone, you transfer to the ICU, take time, understand, take time. That's a way of declaring, that's fair enough. But from the beginning, for everybody, blanket ICU, then why are you here? That's the question comes up. So you need to be factual.
Another situation was, we've all done all this and most of us work in a medical college protected scenario. Imagine the same thing in a small clinic and get to 3 points where there is only one doctor and one Aya or something to help. And the same thing has happened. What would you do?
And imagine you're North India where people are rougher than South India.
And there's 20 relatives waiting outside. Any points?
Call your colleagues.
You're not in Bangalore, you are in Puttur.
Call your colleagues before you break the news. Call your colleagues.
Absolutely.
Till the last minute, and then we dump it in a very non-empathetic manner on the patient and the patient's elder, and therefore they really get shocked. I think a very good, valuable advice would be that never miss an opportunity to counsel and talk to the patient or the patient's relatives, because you get a chance to break it in pieces and build up to a particular climactic situation.
Keep on updating.
So in your small clinic situation, so you need to have good relations with your colleagues around. Any other?
Learn martial arts.
Sorry?
Learn martial arts.
Security guards, bouncers.
And we do not
have relationships with the local bouncers.
One thing to tell in terms of breaking bad news, we don't involve nurses often. I always involve the nurse who's looking after that child whenever I break bad news. Even in ICU setting, we should have involved the nurse to be with us, whoever's in that. So they will comfort. Once you leave the ward or the ICU, the nurses will reinforce what we have said to them. So always, whenever this scenario happens, the more the numbers are, especially, they should not talk, but they should be there. So then they can take it forward, what we have follow-up wise.
That's exactly one more thing I've noticed on the rounds as well. Some complication happens, just a post-op complication, which is something bad, and the doctor tells something else. The nursing team or the allied healthcare team is not consistent with the same approach to the patient. So when there is something, communicate with all your allied healthcare workers that the communication is going to be the same. Third thing I was going to say is make sure you have membership of AMC and things like that. Yeah. They will run to you for help. Correct.
Keep an exit route ready as well. I mean, if they get violent, then you just run from the place.
Yes.
Everyone on good role plays. Give yourselves a big. We all did very, very well in terms of demonstrating good communication skills. But we all know that we are being observed, we are being video recorded, and Vaswani sir will say ethics is about how we perform when we're not being observed, when nobody is watching us. So you need to continue the good skills that you already have and practice it every day when nobody else is watching, and that is what will make real difference to patient care. One important aspect of communication, so far we've been talking about communication with patients, but communication is also about working within teams and how we communicate with each other within our team and with other teams within the hospital. So just think about, okay, good communication skills are required, we know the basics of communication, but what is specifically required for good communication, interpersonal relationship with team members and with other teams? Anything specific that you can think of, what needs to be different or what needs to be extra? How do we communicate with our nurses? How do we communicate with our junior doctors? Is it always verbal? Clinical care. Documentation is one area that we write down, and that's one thing that we need to be aware of, how we document. You know the requirements for good clinical documentations, your eligibility and all those things, dating, timing and all that, signatures, all that we are aware of, right? But what's important is when we document, we don't always communicate that we have documented to the team members. Explain, even if we come for rounds or to see a reference, referral, we see the patient and we document and we just walk off. So it's important to make sure that people looking after the patient is aware of what our diagnosis is and what our treatment plan is, including the nurse in the ward as well. So documentation and communicating the documentation to the relevant people is something that's really important and doesn't always happen. We see it among our PGs as well. They go, they see and they document and they walk off. And sometimes when we go and want to review the patient, the treatment plan is not followed. It happens quite often because the team has not been involved or informed, or the nurses are not informed. So it's always a good practice to close that communication loop. It happens in scenario-based situations as well, emergency situations or OT situations or any kind of intervention situations. What is closing? How do we close the loop? Anyone? What's the communication loop and how do we close that communication loop?
Person says it back.
Person says it back. So you say, yes, ISBAR. Yes, ISBAR is another thing you're familiar with. We have a short video, will kind of highlight all those things that you're familiar with, but we need to be mindful of that at all times as well. So closing the communication loop is, you have said something and the other person should make sure that they have understood and they say it back to you. So that way you have understood that whatever you wanted to communicate has been received by the other persons. Only when it is received in the right way, then the communication is complete. So we have to make sure that the communication is complete and that feedback communication loop is closed. So documentation, closing the communication loop, and ISBAR communication. What's ISBAR communication? Identify yourself and the person. Describe the situation briefly. Then describe the background. Then your assessment. What is your assessment of the situation or the patient condition? And then R is recommendations. What are your recommendations, or what would you like for other person, whoever you're communicating with? So if you're referring the patient to someone else, their recommendations as well. So it can be both your recommendations and their recommendations. That is ISBAR communication. The advantage, what's the advantage of using ISBAR? Yes, that's there. Any other thing? It's like having a common language when you communicate. You have a common system of communication. So everyone knows how to communicate with each other. So our communication becomes succinct and concise, and it can be done in a shorter period of time. So that's the biggest advantage of having a system of communication with teammates. And if we practice this, and especially with our postgraduates as well, if they practice it, our inter-team communications also improves a lot, and therefore patient care improves. Okay. So we'll any questions on that? Any thoughts on that before we watch a video? We've got a 9-minute video just summarizing what we've done.
Communication is the key to effective teamwork and the delivery of safe patient care. It is fundamental for decision making, team coordination, and in maintaining situational awareness. Human factors science tells us that the inherent limitations of our memory, the effects of stress and fatigue, the risks associated with distractions and interruptions, and our limited ability to multitask ensure that even skilled, experienced providers will make mistakes. Effective communication methods create a well-understood plan of care, and this can greatly reduce the chances of error and consequently patient harm. Communication can be divided into 4 components. What? This is the information to be communicated.
The fact that we've been pushing out for 2 hours, there's no dissent.
How are you going to communicate?
Would you mind just grabbing a theatre pack with a consent form while I do that and coming back with it?
Why are you communicating this? Who are you communicating with? There are different types of communication that we use every day. Written communication. This form of communication needs to be clear, legible, precise, and informative, as otherwise the information can be open to misinterpretation. Verbal communication and non-verbal communication. Our facial expressions, tone of voice, gestures, and eye contact help us to convey emotion and reinforce our verbal communication. The best form of information transfer occurs during face-to-face conversations. This form of communication is especially important for expressing concerns and finding resolutions to conflict. Models of communication. Beth is a junior obstetric registrar in a tertiary hospital. She has reviewed a patient in the maternity assessment unit and diagnosed preeclampsia at 37 weeks gestation. The patient's blood pressure is 160/100. Beth documents her plan in the patient's notes for a CTG and for a stat dose of labetalol, which she prescribes. She then leaves to review an unwell patient on delivery suite. Beth is bleeped 1 hour later by the triage midwife. The patient's blood pressure is now 170/110. She asks whether the labetalol was given as prescribed. The triage midwife was not aware of the written plan made by Beth, as she had been called away to attend another patient, and therefore had not been able to read or confirm Beth's plan. Why might this have happened? Communication can be difficult due to both internal and external barriers. Internal barriers are those which affect us as individuals, such as language differences, our culture, our expectations of the situation, and our past experience. External barriers are those around us, such as background noise and distractions. In this scenario, Beth was using one-way communication. This form of communication is relatively quick. However, there is no immediate feedback, and the receiver may not pay adequate attention to the instructions given. So, what could Beth have done differently in this scenario? By talking to the triage midwife, Beth can explain her assessment and plan for the patient, and this invites the midwife to ask any questions or clarify any information. Two-way communication involves both the receiver and the sender, forming a closed feedback loop. This form of communication allows for checking and correction of details, allowing both parties to work together to achieve a mutual understanding and prevent any misinterpretation of the original meaning of the information. Open questions should be used by both parties, using what or when questions, rather than those which invite yes or no answers, which are likely to lead to an automatic response and be potentially biased. Using open questions involves the recipient and means they must think about their response. Graded assertiveness. As any healthcare professional working within the NHS, we are exposed to increasing stress and workload. The intrinsic limitations of our memory, our environment, and the impact of stress and fatigue can all influence our communication with others. Safe and effective delivery of healthcare requires communication between individuals with different roles, training, experience, and perspectives on care. But within healthcare, hierarchy often prevents people from speaking up. The ability to speak up to express concerns is a key safety behaviour we should all have. Not speaking up, especially in junior team members, has been shown to be a contributing factor to many patient safety errors. Using the PACE tool could allow any healthcare professional to challenge any action or behaviour they may feel is inappropriate or unsafe. Let's look at an example. Sarah is a midwife and has called the neonatology doctor to attend a Category 2 caesarean section. The baby has been born, and the neonatologist is attempting to resuscitate the baby. The heart rate remains below 100 beats per minute, and the neonatologist is unable to inflate the lungs with no chest rise visible. Sarah is helping the neonatologist by listening into the baby's heartbeat and checking the oxygen saturations. Sarah is becoming increasingly concerned about the baby as the neonatology doctor has become task-focused and believes that they are successfully resuscitating the baby. What would you do in this situation?
Is the chest rising? James, I really can't see the chest rising. James, the chest isn't rising. The heart rate isn't improving. Can I take over? James, this is not working. The chest isn't rising. The heart rate isn't improving. I'm putting out a 4-2 call. Please can I take over?
By using the PACE tool to challenge the unsafe actions and behaviour of the doctor, Sarah has been able to stop the situation, allow for reassessment, and ensure the patient's safety. Handovers and SBAR.
How many of you actually believe that one way of documentation is by using WhatsApp group? No, because this is the reality. That is, I know that's mandatory. In the real world today, especially when working in a unit, how many actually believe that WhatsApp group is a very good tool in doing this job? Or how many of you believe, who doesn't believe that? How many of you believe? Raise your hands first. You are functioning in that way, or you only assume that that's a good thing to do? Okay, how many of you believe it is not? Yes, 1, 2, very good. 3. How many of you think that is both? Yeah, right, good. So it can, that's what I was trying. These are all tools. Either you document or you put it in a WhatsApp group or your phone call, everything is a tool. As long as you use it cautiously, it can function very well. Or like Sharat said, it will not. Can you give an example why it will not?
No, I think if the team has agreed set of rules, then it's okay. But like if you want to communicate with me in WhatsApp, then you're gone.
Okay, right. Because if not, you are. If, for example, there is one person and there are too many residents, and they expect this chief to tell for everything, yes, no, go, whatever it is. He is not he is not assumed to hold the WhatsApp 24/7. It's not possible. But for somebody else, it could really function, because if there are too many people, it can't communicate to everybody, or everybody may not have access to the case sheet all the time. That could act as a little bit of, to break that, the difference. It all depends on how you use it judiciously, and they should not take it for granted for everything. Any other comments, sir? Ravi sir? How many of you actually had problem using WhatsApp groups?
It is not a closed loop communication. Again,
It depends. It can be closed group, or it depends on what's happening in a unit. I'm just talking a team in a hospital setting, or not other things. When there's a team in like for example a unit. Some of you may not be functioning in that way, but then like for an OBG, there's a unit. Yes?
Sir, very good for the non-critical decision making communication.
Correct. Perfect.
But when the critical decision is made, we have to immediately approach someone. Like
That is the decision that we assume everything we can do over WhatsApp is not right. You are open to give comments. I'm just putting my comments.
Day-to-day follow-ups.
Yeah, sometimes simple thing like giving discharges. I have seen the patient, it is good to be discharged. Some common advisors. These are things which can go better in a WhatsApp group. Doesn't need any hi-fi this one. But there are other things, yes.
if there's any confusion, you can put into the group and
seek clarification.
Yeah.
We should be careful who's in our group, who leaves, who joins.
Yeah.
So like Pete Hesketh will be informing when we are attacking Iran.
Okay, that's a little bit about this. And we move on to the last session. Who's going to take it? Please, go to Ravi and before we break for the lunch.
Way behind time, we're now right on time. So Karen and I are going to handle the last session. Karen was not here in the morning when the introductions were done, but you all know her. She's professor in the Department of Surgery here at your place. And she's been instrumental in getting the case scenarios ready for this session. What we will do is, before we break for lunch, when are we breaking for lunch?
Whenever it's ready, sir. Whenever it's ready, sir.
Okay, whenever it's ready.
Whenever they feel like you can take a break.
Okay. So we will do some brief one-way talking. Then we will share the case scenarios with you. Hopefully you can quickly eat your lunch, come back, and within the official lunch break, try to enact your scenarios and get them ready so that we can save time in the post-lunch session. So we are going to talk about what is called as shared decision making. Before we do that, we'll just have a few slides on doctor-patient models, doctor-patient relationship, and what types of doctors we could be. This belongs to Yogesh. Okay. So this session is going to be about knowing about doctor-patient relationship and knowing about shared decision making. So doctor-patient relationship is a contract. This contract starts the moment the patient walks into the clinic or the OPD and your work starts from that point of time. Some implied aspects are there. We always believe that the patient is going to speak the truth. If we start believing from day one or from the first moment that all patients are always lying, it's going to be a very bad point to start on. So one assumption is that all patients are speaking the truth. The second assumption is doctor will do everything in the best interest of the patient. Third is doctor will keep all the information confidential. Doctor will maintain respect for the person. And consent is implied when asking personal questions, physical examination, maintaining case sheet, discussing case with others if need be, drawing blood for investigations, routine treatment modalities. We don't need a written informed consent for these things. These are implied. Imagine you're traveling in a train and you ask the person next to you, if it's a woman, when did you have your last menses? She's probably going to hit you. But in the same question, if I ask in an OPD setup, it's very natural. Because it's implied that this doctor is going to ask me some personal questions also. Like I might even ask the patient, how many pads do you use in the 2 or 3 days bleeding that you have? I won't get the same reaction as I would as I'm sitting in a train. So there's implied consent for a lot of things that doctors, we take for granted, but which will be very unusual outside the OPD setting, outside the doctor-patient setting. If it goes beyond this, then there would be, further levels of consent. So this is implied. If I was to examine the patient, if I were to undress the patient, examine, I need oral consent. And if I need to invade the body by doing some surgery, I need written consent. So levels of consent will go on increasing depending upon what type of situation we are in. Of course, there's trust, because without trust from both parties, no contract will work. Trust is presumed because both parties want patient to be relieved from the suffering. And either party can refuse the contract if there's conflict of interest or lack of affordability. We know that from the legal point of view, doctors can refuse seeing patients if they feel that the patient can't afford their treatment. As long as they put up their rates on display openly, and if the patient comes inside and the doctor feels that this patient can't afford my treatment, he can refuse. Okay, we talked about trust, we talk about equality, but we know that this is all really a myth, because a doctor-patient relationship is always imbalanced. There is always more power in the hands of doctor and less power in the hands of patient, because one, patient is suffering, patient is not mentally completely sound or receptive for everything. Patient feels insecure. Patient is desperate because he needs relief and cure. So all of these things are going to make him emotionally unsound. Emotionally, he will feel a little vulnerable and less powerful. The doctor, on the other hand, has all the knowledge, the technical expertise and the skills, and this tug of war is always in favor of doctors. What does this mean? It means that from doctor's point of view, doctors have more responsibility because doctors have more power. And as Uncle Ben told Spider-Man, with more power comes more responsibility. So then we have to behave more responsibly because there's an unnatural amount of more power within our hands in a situation like this. Okay, when we talk about doctor-patient relationships, it's all about control. Who is controlling? And we as doctors are often very fond of keeping all control with us. So you see the traditional models of doctor-patient relationship have more controls in us. So all the models that we're going to be coming up with are based on who is controlling how much. So these are the 4 models: paternalistic, informative, interpretive and deliberative. It doesn't necessarily mean that paternalistic is the lowest or the worst form and deliberative is the best form. There are different situations where you might want to behave differently. There are times when you might need to behave paternalistically, but there are times when you should try to behave deliberatively. Best model would be deliberative, but please understand that all patients and all people are different, and there are different contexts and different situations, and you might need to move the balance between from one to the other. Let's have a look at them. So if we draw a 2x2 table and we see how much is the control, low control, high control, and who are the people controlling, whether the patient is controlling or not. So if we see this, physician control, patient control, low and high. So where the physician has a high control and the patient has a low control, it becomes a paternalistic doctor-patient model. This is the model that we are most commonly seeing in our setup. What do we mean by paternalistic? Paternal means father-like. pater is the Latin word for father. So paternal is a description of what a father-like person would be. And the behavior would be paternalistic behavior. Right, we all remember when we were kids, our fathers decided everything for us. My father will decide who I'll get married to. I have the power to vote the Prime Minister of the country into, but I don't have the power to decide who should marry me. Because in my family, my father was the most powerful person. So in this doctor-patient relationship, the doctor is the absolute king, absolute authority, and not to be questioned. So doctor will tell the patient, this is what I'm telling you, you have to accept this. If you don't like it, you can go away. Right? That's the paternalistic model that culturally in our society is how we are. Because our culture at family level behaves in what is called as a bapocracy, or a father-oriented or father-centered, kind of world, we bring that into our professional world also, and we behave paternalistically in that relationship. If the physician control is low as well as the patient control is low, that means both parties are not controlling, it's an informative model. And if the physician control is high and the patient control is high, then it's the best model, called the deliberative model. Let's have a look at each of these models once again. Okay, we talked about this. This is parental model, also priestly model. Physician uses skills to diagnose and stage disease, then plan treatment that is most likely to restore patient to normal or at least provide relief, and authoritatively inform patient when, where, and how of the treatment. That too, if the patient is lucky, the doctor will tell some. Most of the time, doctor will not even bother to tell, and he'll say, this is it, don't ask any questions. It is assumed that patient should be thankful to the doctor for all the clinical decision making, even if they are not agreeable. There is a tension between autonomy and well-being and choices and health outcomes. Physicians stress on the latter. Physician acts as the guardian for the patient, and the concept of patient autonomy is at best a question of assent. The informative model is one where both the patient and the physician are having low control. Okay, so what happens here is the physician simply provides information to the patient and says, you take decisions. I am not going to help you or guide you or assist you in any way. This was the model that was very familiar in the US in the 70s and 80s, where information was simply given to patient or dumped on the patient, as I was told in the morning, the information dumping. So it's also known as the scientific or the engineering or the consumerist model. The physician provides relevant information about disease and treatment options, including success rates, complications, etc. And patient is supposed to choose what he or she wants and expects physician to carry out the choices. Now, in a world where we are getting more and more multicultural, it becomes difficult to follow this model. Like many people in the US, many doctors in the US who are white, were having difficulty when they were confronted with patients who were Asian in background. So they would leave the information to the patient and say, choose. And the patient, being an Asian or Oriental person, would say, doctor, you decide for me. And the doctor would say, I can't decide for you, I'm not you. And then the patient would say, no, but supposing you were in my position, what to do? The patient doctor will say, I'm not in your position. Now, supposing I was your husband or your wife and your son, what would you do? I am not your husband, your son, or your wife. Here is the information. You decide, come back to me, I'll do what you want me to do. So that's the situation where the information is simply used as a means for communicating, and no assistance is given beyond transferring the information. The informative model is suppose that the patient's values are clearly defined and that the patient knows these values well. So there's an assumption here on the part of the doctor that the patient knows his own value systems and they are well defined and available to everybody who is involved in this. What the patient lacks are the facts which the doctor is expected to provide, and the patient then expected to match his values to the best treatment option. So everything is being left in the hands of a person who is not very well versed or informed about what he should be doing. Okay, that's why the control levels for both the physician and the patient are low. And the physician is just a tool to provide the information. Patient is provided the means to exercise options. There is no role here for the physician's values. No requirement for physician to understand the patient's values. And the autonomy concept is patient control over medical decision making. Okay, so that's how the paternalistic model from the 50s and 60s in the US moved into the informative model in the 70s. Then came in the interpretive model. The interpretive model builds on the informative model because the physician has to assist the patient to elucidate and articulate his values. So here now the physician is not just simply passing on information, but also helping the patient explore the patient's own value systems. Okay, then the patient is helped to select the medical intervention that best serves to achieve the patient's values. They can reconstruct the patient's goals, aspirations, commitments and character, and here the physician acts more like a counselor. So this role is supposedly slightly better in terms of control because the patient is given more control, but the doctor still lacks that much control because there are no doctor's values being brought into the situation. The best model, at least on paper, would be one which is called as the deliberative model, where both the physician and the patient are holding high control. Here what is happening is the physician helps the patient determine and choose the best health related values. The physician delineates information on patient's clinical condition, then helps in elucidating the type of values embedded in the treatment options. Here what is happening is that the doctor's value system and the patient's value systems are trying to be aligned. The focus is on persuasion, not coercion. Physician acts as a teacher or a friend or a mentor. And the concept of autonomy is one where prioritizing health values, assessing worthiness and implications for treatment. So when we talk about values, what exactly do we mean by that? It's very difficult when I say try to align your values with the patient's values. What I'm trying to say is the patient may have a outlook and we may have a different outlook. And that may be causing a clash between the doctor and the patient. And so then the doctor needs to try to align his value system with that of the patient. Let me give you an example. Maybe back in the 80s and 90s, when we didn't have recombinant insulin, a doctor felt that a diabetic patient, especially a type 1 diabetic patient, has to receive insulin. It's life-saving and therefore, according to the doctor, extremely high value. But the patient was thinking that this is insulin prepared from a pig or from a cow and therefore not good for me. So the patient's value systems are very different. And the patient might even refuse the insulin treatment because the doctor is trying to force him to take something which he might think is non-vegetarian. Okay, so this is how different value systems would be in clash and they would need to be aligned. Another example would be, let us say, a situation where the patient would refuse antibiotics because he thinks it's against life. Okay, or he thinks that it is prepared from fungi, which he may not like and may not want to have anything from that kind of a fungus's excreta put into him. So then the doctor needs to align his value systems with that of the patient's value system. So are we clear about what we mean by value systems? And that's how we need to move from one model into another model. Sometimes patients who are extremely unable to take decisions by themselves need to be assisted. So we need to tilt towards a paternalistic model. Sometimes when the patient is very assertive and a strong person, very individualistic person, we might want to move into a deliberative model. So we can keep moving from one model to another. So when you are doing your communication skills, you have to decide what type of model you need to follow depending on how you are assessing the person at the other end, whether it's the patient or the relative, how receptive they are and what is their mental makeup, how strong are they. And this is something that we have to do on an everyday basis. Some patients are weak, some patients are very strong. So we have to decide this. When we talk about how much we tell the patient, we have a problem here. I remember a time when a middle-aged lady came to my clinic and I saw her and I checked her blood pressure and found her blood pressure to be high. So I told her, madam, your blood pressure is slightly high, but I won't start treatment for you. We'll wait for a few days, we'll repeat your blood pressure once again and see. Now I thought I'm telling her the truth. And half an hour later I get a call from an army colonel who says, doctor, what have you told my wife? She's completely shattered. She's refusing to eat. So she took the news in such a bad way that she was completely depressed for a long period of time. So I thought I was telling her the truth, but actually it turned out to be something wrong for her. Another example was when the patient came to me with heart attack and we treated the patient, and when I sent them back home, I told the daughter that heart attack might happen again, but it may cause pain in different places, not necessarily only in the chest. It can go to the shoulder here. I told them everything about atypical variations, different ways in which the chest pain can radiate, and sent them back. So I thought I'm doing a good job. I thought I covered everything. The patient got back pain a few months later, ignored it because they thought it was not heart pain. It was actually a heart pain referring to the back. Eventually patient died, but at the last minute while going to the hospital, they went to the hospital, that doctor there said that your first doctor should have told you that even the chest pain of ischemic heart disease can be referred to the back. They should have told you this. So the patient's daughter called me back on the phone to say, you never told us that heart pain can be referred to the back, and we ignored this pain for 3-4 days, and my father became worse, and by the time we took him to the hospital, the doctor there told me, had you come earlier, we'd have been able to save your father. So we have to always think of how much to tell the patient and the relatives and at what stage in life, right? So sometimes patients can be mentally weak, that even a small blood pressure, I think, can cause them to get severe depression. So that's something that we need to keep assessing all the time. So this is the background about doctor-patient relationship and the various models that we need to establish. And the last session that we're coming to now here after the break, after the effective communication model and the breaking bad news, is shared decision making. So shared decision making obviously means we're not behaving paternalistically, because paternalistically means I have all the information, I control everything. But shared decision making is involving the patient or the relatives in whatever decision making that we're doing. And we get opportunities at each stage. Your first stage, you talk to the patient, you get to know the history, you examine this patient, you have certain doubts in your mind. Share your clinical decision making with the patient, saying, this is what I feel you have, this is what we're going to do, these are the investigations we're going to look at, and then we take it forward from there. So you got your first opportunity to communicate with the patient. The patient goes for investigations, comes back with the reports, you see the reports, you revise your diagnosis based on the reports, you might re-examine the patient, you get a second opportunity to communicate with the patient, saying this is what we found, now we need to go to the next higher level of more and more investigation. So the patient comes to you with weight loss and cough with hemoptysis, chronic smoker, you might say, okay, this might be a malignancy, but this could be infection. So in the first stage, in the first communication, you tell the patient there are 3-4 possibilities. Get the first round of investigation and comes back with the reports, you get the second round of counseling, you say, okay, I can see a lesion in the lung. It might be a malignancy, but we don't know, we'll have to check further. It seems less likely to be an infection. So you got a second chance for doing communication. You send a CT scan, the CT scan report comes back, it's looking more and more like a malignancy. You get a third opportunity to give a communication about this. And then you finally say we might need to do a bronchoscopy or a biopsy, and then find out what the lesion is. By this time, the patient is getting mentally prepared to understand that this might turn out to be something bad. So, like you saw in the earlier sessions, the breaking bad news is not, for the case of scenario, it is just a one moment thing, but invariably breaking bad news, you get a lot of opportunities where you can go escalating your levels to informing what the bad news is to the patient. That's a good way of breaking the bad news. So never miss an opportunity to communicate and talk to your patients whenever possible. I have another example I would like to share with you. I moved to Mangalore in 2003, and I didn't know Malayalam. I still don't know Malayalam. I know medical Malayalam, but I can't talk weather and politics with a Malayali. But those days I knew very little of Malayalam. I like to think that I am very good at languages. I know many languages, including Indian and foreign languages, but Malayalam has defeated me. Now I have, for the moment, shelved my hope. I will, when I retire at 70, I'll pick up the Learn Malayalam in 30 Days textbook once again and try to master Malayalam. But till then, it's the language that's beaten me. I can speak Telugu, Kannada. I'm not a Kannadiga. I'm basically a Sindhi from North India. But I can speak all languages, many languages in India and also foreign languages, but Malayalam, no. Anyway, so here we have this patient in my unit. We've diagnosed a bronchogenic carcinoma from Kasaragod. I leave it to my PG. The mistake I made, which Harsha told you about, is that the senior person in the department should be breaking the bad news. I thought I can't speak Malayalam, so I left it to my PG to break the bad news about the bronchogenic carcinoma to my patient, and I walked away. and patient was discharged. Patient comes back after 3 months and he's shouting at me. He's got admitted to my unit. Next day on the ward rounds, I'm standing next to the nursing counter and he's blasting me in Malayalam. 100 words per minute. I can't make out what he's saying. Those words are all washing all over me. But from his facial expression and body language, I know he's angry, upset, and he's shouting at me for. So I waited. Finally, he vented out all his anger. Then I asked my PG, what is this all about? My PG said, sir, he went home from here after previous discharge, had an upper respiratory infection, went to see the local doctor. The local doctor found our discharge card which says bronchogenic carcinoma and referred this patient to Regional Cancer Center, Trivandrum. So patient takes a train from Kasaragod to Trivandrum, and he sees a big board outside which is Regional Cancer Center. And then starts wondering, why has my doctor referred me here? Goes inside, gets broken the bad news. Then he asks the doctor there, when was my diagnosis of bronchogenic carcinoma made? And the doctor in Trivandrum tells him this was made in Yenapoya. So he comes back home, catches a train from Kasaragod to Mangalore, makes sure he gets admitted on my unit day, and catches me the next day just to get angry with me because I did not break the bad news to him correctly. Now I asked the PG, why did you not tell? I told you to tell this. He says, sir, I was about to tell. The wife said, don't tell the patient, my husband will die of shock. And so the PG took the escape route. At the moment the wife is saying, don't tell my patient, this is the best situation for me to not tell. Because breaking bad news is not something that comes naturally or easily to us. And so he took the easy way out and said, I won't break the bad news to the patient, but he told the wife, and the wife kept the information to herself. So this sometimes can backfire on us if we don't do it correctly. Do we break here or so we go on to, okay. The next part is, Karen, you want to? Okay, so now we're going to move on to shared decision making, which is a process whereby clinicians collaboratively help patients to reach evidence-informed, value-congruent medical decisions. The process is especially relevant in screening for conditions in which there is a close trade-off between harms and benefits. So when the therapeutic window is small, it's the best situation for doing shared decision making. If something can go wrong, it's always good to be talking to the relatives and taking decisions collectively. It's essential for implementing weak recommendations that are congruent with patient values and preferences. So as we saw, there's a paradigm shift in the doctor-patient relationship from a paternalistic model to a more deliberative model and what is called as a collaborative model, because it's between both the patient and the doctor for making the shared decision making. So there's a share approach suggested by the HRQ, which says the S is seek your patient's participation. That's the first step. H is help your patient to explore and compare the treatment options. A is assess your patient's values and preferences, reach a decision with your patient, and evaluate your patient's decision. So this is called the share model. Let's go through once again. Seek your patient's participation. So when we do the case scenario in the afternoon session, we're going to be looking at seeking your patient's participation, exploring and comparing treatment options that are available, assessing your patient's values and preferences, very important point, reach a decision with your patient, and then evaluate the patient's decision. Evaluation basically means like a feedback mechanism. There's also a 3-talk model, which helps professionals structure conversations and ensure the decision making is truly collaborative. So it breaks the SDM into 3 stages: the team talk, the option talk, and the decision talk. Initiate the conversation by introducing the idea that the decision needs to be made together. Invite the person to participate and explain the options available. The second one is the option talk. Present the different choices in a clear, balanced way. Use simple language and visual aids to support understanding. Like was discussed in the earlier session, you can have, flip charts, you can have comics, you can have cartoon characters, you can even show something on YouTube. You can use enhanced methods for making comprehension better. And the third stage is decision talk. Explore the person's preferences and help them consider what matters the most to them. Support them in making an informed choice. Always try to make it look to the patient that he took the decisions. Even if you might be guiding him along the way, make it look like he took the decision. If you remember when we were students in MBBS days, what was told to us is that, or at least in the PG level, in the exam is, a good student can guide the examiner into the area that he feels strong in. So that's the kind of process we want to use here with the patient. Another method is the brand questions. Brand is a tool that encourages individuals to ask 4 key questions when making decisions. By asking these questions, professionals can help service users to consider all aspects of a decision, leading to a more informed and confident choice. What is brand? B is what are the benefits? R, what are the risks? A, what are the alternatives? And N, what happens if I do nothing? Right, so that's the brand method. So you could use the share method, the 3-talk method, the brand method, or combinations of these to make shared decision making in the clinical setup. So that's the background that we have about this. We can now break for lunch, and you have how much time? 40 minutes for lunch? What's the time? 30 minutes for lunch. If you want to go early, you come back early. But you'll also, within this time, we'll be giving the case scenarios to you. Can we distributing the case scenarios to them? So they can have lunch and prepare their scenarios, or would that cause indigestion in them? Okay. At the risk of causing peptic ulcers for you, we'll give you the case scenarios also.
Okay. What we have realized in our practice is in every patient at multiple levels you are talking to them. It's not like we had a scenario where you spoke and you're done with your work. At every step, every day you are talking and you're facing different problems with the same patient. And that's the idea. We have a common scenario here. And each of you will be facing a different problem while talking to the patient or the bystanders. And how you are going to, involve yourself when you're counseling, keeping in mind the ethical values, the social values, the cultural values, the financial, all these aspects in mind, how you are going to help the patient in decision making. That's our idea with the scenario. Kindly note, I understand that not many of you are surgeons. So you don't have to think that we are going to assess your knowledge. It's only your skill of communication that is going to be assessed here. So the scenario is of a 28-year-old male, Mr. J, who was brought to the emergency department after an RTA, road traffic accident. He was riding a motorcycle and was struck by a speeding bus brought by the onlookers. On arrival, he was noted to be in a drowsy, inhibited state. On examination and imaging, he had a right side flail chest with tension pneumothorax, right clavicle fracture, fracture of the pubic rami. The emergency team did not waste time. They inserted a needle thoracostomy and an ICD on the right side. The orthopedic team applied the clavicle brace and advised immobilization. I am sorry if I missed something here for the pubic rami fracture.
That's okay.
So coming to the group activity, as I told you, Mr. J develops newer problems which need to be addressed, and he and his family, so that they have a favorable outcome. And each team will be given a different problem. You have to prepare a role play to address this situation in a best possible method. Here we will not allow the 10 minutes preparation time. You can work during your lunch and discuss. Again, this is not a test of knowledge. Yeah? I think all your acting skills are very good. So we'll just put it to play again. He needs help, but our family has very strong beliefs against blood transfusion. He himself would have never wanted it. I am his wife, but I have been only married for a short time, and such decisions are usually taken by his parents. They are on their way and should be here in about an hour. Please, if possible, wait till they arrive. Okay, so this is a scenario. Who's coming forward? The next team will evaluate them. The next team will evaluate.
Good afternoon. I am Dr. Srinath, treating your husband, Mr. J. May I know your name?
I am Grishma.
Okay.
What happened to my husband, doctor?
I hope you are aware of his current situation.
Yeah, we met with an accident.
Am I audible? Okay.
We met with an accident actually, and already one doctor has told that there is air in the lungs and they had put an injection. But another doctor has told he might require a blood because there is internal bleeding.
Since he has sustained multiple fractures, he has internal bleeding and his hemoglobin level is constantly falling. And if with this rate, if we don't manage actively now, he may lose his life also. So we need to do an urgent blood transfusion.
But doctor, like our family, as like my husband's family, they don't usually are okay with taking the blood, like transfuse the blood. And I have recently married few months, so the beliefs are very strong in his family, and he himself wouldn't have agreed for the transfusion. So I think my in-laws would be better to take the decision.
But at the rate the BP is falling, hardly we have 1 hour left to resuscitate him.
Is there any other way, if not blood, if
Now we can manage with the plasma expanders or can use some IV fluids and we can manage till 1 hour. But after that we can't guarantee. Even now, even if we give blood expanders or saline infusion, we can't guarantee that he will survive. So what he needs is urgent blood transfusion.
Do you want to call somebody else?
I'll call my in-laws actually. I've already informed them. They might be on their way.
Phone not reachable.
Doctor, these are my in-laws.
Hello, good afternoon. May I know how are you related to the patient?
Hello, doctor. I am the father of Mr. J. What happened? It's been told he needs blood transfusion.
Yes, because of multiple fractures, he has internal bleeding and his BP is constantly dropping. So he needs urgent blood transfusion.
But according to our family beliefs, we are not okay with it, doctor. And actually, I saw my son. He looks okay only. I can't see any bleeding as such. There are some, there are some wound over the body, but I don't see any massive blood, any blood loss as such. So I don't think it is necessary. Please, you take any alternative modes of treatment.
His hemoglobin has dropped from 12 grams to 5 grams now. So it is, unless there is some blood loss internally, it will not drop like that. And if it continues, it is very difficult for him to survive. So we need urgent blood transfusion.
Oh, doctor. Initially, it was told just they'll put some tube in the lungs. Initially, they didn't mention anything that they need blood transfusion. Now, why suddenly you are telling all this? Actually, we don't want to agree for this.
Initially, there was a blood accumulation in the outside the lungs. To improve the bleeding, the breathing, the blood was drained from the outside the lungs. Now, since his his hemoglobin is dropping, his blood level of hemoglobin is dropping, he requires immediate blood transfusion. So if you are not agreeing, then you have to give a written consent saying that we are not agreeing for blood transfusion and whatever consequences happen, we are only responsible for that.
Is there any other way of treatment, medication, something that you can increase the blood or we can give him some other?
Not possible. So unless we give the blood transfusion, it's not possible to resuscitate him.
Right now, we can't agree, doctor. You do something for now. We'll have to discuss and then give you a consent. Or else we want to take the patient to somewhere else, other hospital.
For the time being, we'll start him on IV fluids. We'll give him saline and plasma expanders, but we can't guarantee that he will survive with all those things unless we give immediate blood transfusion. So if you are not willing for any of these procedures, you can give a written consent that we are not willing for anything and you can proceed. And you are always...
His life is conditioned.
No, I can't see any blood over him. We'll take to the nearby hospital. Anyway, there are 3 medical hospitals nearby. We'll take to the other hospital. I don't want to sign also. I won't. Why should I sign?
Okay, it's up to you. And if you don't want any blood transfusion, you will discharge against medical advice and you can take him to some other hospital for second opinion.
Okay. We will want to take the patient to other hospital.
Okay.
I like how they have gone through the scenario, telling about the different possibilities of how we can, instead of blood, use a different option. And what they could have emphasized on is
Risks of,
risks.
risk of not transfusing was not emphasized well enough. I mean, here is a risk of a real risk of patient dying in the next 1 hour or so. That probably could have been emphasized a little more. And yeah, other than that, I feel it was very well done. Only thing is, I have a little bit of a problem with using a consent as a threat. This is something that we discussed among ourselves also. It can be risky for us using consent as a threat, but I think mildly we can. It was not aggressive at all. It's a real life situation, and I feel she considered it really well. Not being confrontational in taking a consent, but at the same time protecting yourself from legal implication. But one more thing that happened is the patient party did not agree to consent also. I really don't know how to handle that. But we will probably have to record that under these circumstances we have.
One thing is the familial beliefs, what they were having, it was very strong. But we can consider two things here. One is the wife who has come from a different family, different setting, and here there is father and mother. So here, I don't know, maybe for the acting, the father looked more dominating, and he was the one who was making more speech there. So wife had no saying, and even the mother had no saying there. So I think we could, yes sir, but I think even the wife was the same right to take a decision, because it's a life and death of the husband for her also. I think we can given some time for them to discuss among themselves, come into a conclusion, that would have been better, I think.
I think time was given by the doctor. He said 1 hour I can somehow push with IV fluids, but come back on the decision.
And also transferring to other hospital, we have to also mention the risk of while transferring to other hospital. On the way the patient may die. So that we should also be emphasizing. Such a riskier, shifting the patient is also should be emphasized.
Should have counsel that similar situation, if there is any anecdotal scenarios, you would have given the information. Similar situations, similar like you had been given those, all of the same religious, we have given to save their life. Or giving an option to speak to somebody there itself, like their father, in the sense, the judge or father or maybe whoever is there from there itself, and come back and good.
Any other tables like to comment? Long press.
Not about the performance, just to take the point that the father was dominating for decision making. I think here we have to go by the hierarchy of responsibilities, because after the adult it will come spouse first as the responsible person. If spouse is not there, then the children will come, then parents will come. If no parents, then friends will come. I think that is the legal way of hierarchical fixations for the responsibility. So when there is a dispute between wife and the father, then the weightage has to be given to the wife decision rather than the father, because we have to protect medico-legally as well in this kind of decision making.
So what do you do if one gives consent and the other does not give consent? I mean, it's open. Even I have this doubt. If two close family members.
From a legal standpoint, the wife gets more weightage compared to the father, because he's married in an adult.
Yes. But why? What I suggested that you wanted to take
social is different. The wife is going to be always submissive to the father-in-law, but legally speaking, if it comes to a legal standpoint, the wife has more weightage than the father. So if the wife is consenting and the father is not, then you can go with the wife's decision.
We had one patient who had actually filed a case against us because he's a big bleeding mania. So we had admitted him, and mother has given the consent because it was an involuntary admission. And she was taken as an advance detective, and she gave the consent. Later on, wife came on day 2, day 3. She came and told that you have kept my husband without our knowledge, and she filed a case against us, and there was a court notice saying.
So the wife has more weightage there than the mother.
And treatment is
conflict like this, magistrate. We have to inform the magistrate who is 24 hours on duty. Because then only we will be get protected in this kind of situations.
We are thinking in terms of patient. If someone is there to support that treatment, we actually, it's better we go for them. It's more than the religious past beliefs and all. The current scenario is what I am thinking.
So what she's saying is, in her value system, religious beliefs don't become important compared to health values. No, it makes sense. I mean, nothing wrong with that. That's a particular value system that you have where...
What if it's other way around? Wife is not ready. What if wife is not ready for giving consent, but parents are giving the consent? Can we give for the benefit of the patients?
I would, in that situation, just to be on the safe side, legally speaking, inform the magistrate.
Otherwise, you will face consequences later. Even if patient survives, they can file case against you. But if you inform the magistrate, you will be protected.
So there was a scenario where the patient is not agreeing for the procedure, but all their relatives are willing. So it's a real scenario because patient is having acute MI and the patient is needs actual angiogram and angioplasty. Yeah, he's in sound mind, but but he is afraid of surgery. But that was a scenario, and the patient attenders told, you sedate him and do the procedure, and we actually did that.
So we call this deception. Deception happens day in and day out with doctors. Doctors, from the time they wake up to the time they go to bed, they are always telling lies. Okay, it's a part of our professional occupational hazard to tell lies, because we are not supposed to take away hope from any patient. So we're always going, even if we may be knowing in our mind that this is a hopeless case, we can't say it's hopeless because as long as there is life, there is hope. So many times we find ourselves in situations where we're telling lies, but open deception like this is not ethically, a sound principle to follow. I deceived my mother and my father. So my father was recommended to have a bypass, but he said no. His value system was that when God sent me to earth, he sent me with a perfect body. I can't go back to God with a big scar on my, and he's an MD pathology, but practicing, he was retired from the railways, he was a division medical officer, but he said no for CABG. He couldn't walk 5 steps without putting a sorbitol under his tongue, resting, then again walking 5 steps, putting a sorbitol. This couldn't go on. So I said, we'll take you to the hospital and we'll just do a coronary angiography. We'll not do anything else. So he agreed. And the railways was going to give free treatment. There was no question of financial problem also for us. So we took him to the hospital, to Bombay hospital. And once we admitted him, we told the doctor, go ahead and do the bypass. So they did the angiography, they found huge blocks, they did the bypass. After that he even came out, he never ever forgave me. Till the last day of his life, he did not forgive me for deceiving him, for taking him up for surgery. And after the surgery, he became very good in terms of walking. But in his mind, he kept cursing me, saying, you cheated me. So that's something that we need to think about. My mom, interstitial lung disease, got admitted here under Kishore Kumar in Yenapoya Specialty Hospital. She's deadly against steroids. This is another idea that my father put into her brain. My mother was a teacher, but my father was anti-steroid person, anti-vaccine person. I mean, for an MD pathology, he was a very funny person, but whatever, God rest his soul in peace. So my mom said no steroids. She wasn't recovering. So finally, I spoke to Kishore and said, we'll give the steroids without my mom coming to know. So we did that. She got better. When she was discharged, he wrote steroids on the discharge card, and she looked at it and said, you've been giving me steroids? She threw all the tablets away and got discharged and went home and did not get better, of course. She died. It was subsequently much later, but she was, so we may be thinking, because I was not willing to align her values with mine, and I was forcing my values onto her and onto my father. And something that's very difficult for us to come out of, and come into a situation where we need to appreciate and respect the other person's values and be able to live with it and say, okay, if this person doesn't want me to do anything, then as a doctor, I'll just put my hands behind my back and wait and watch. That takes some amount of guts to do it that way. So, good. Also one thing to notice is, much of what is happening, not only in the presentation and also in the discussions afterwards, is a question of sharing information. Like we didn't tell this, we didn't tell about risks of blood transfusion, we're not talking about, did we try to explore the values of the patient and the relatives? Why is it that the father is saying no for blood transfusion? Right, there's this, we didn't mention it in the slides, but there is Jehovah's Witness, there's a subsect of people who are extremely famous for not accepting blood transfusion even in the death situations. And we have to understand that that is their belief, because their belief says that if anybody gives blood transfusion, if anyone receives anything which is not part of his body into his body, he will never go to heaven, he'll only go to hell. So if that is their strong belief, then we have to respect that belief. Even if we remove that fellow's blood out of his body and then give it back to him, they will not accept it. Even autologous blood transfusion not acceptable in there. So we have to respect that religious belief and try to work around it. Like he said, like Harsha said, Harsha was the one who said, let's get some value system involved. Let's call some Maulvi. He didn't want to say father. He knew we were talking about Jehovah's Witness, but he said, let's call some Maulvis, let's call some priests, let's call some fathers. And so we're now trying to assess the value system of the father and trying to get ourselves aligned with his value system by bringing in some other people who might help us in the negotiation. And that is a very strong point that we should look for, right? Rather than I'm the one who decides and you have to listen to me, or you're the one who decides and I'll do whatever. Maybe we can bring in a third person also. Yes, Yogesh.
So the important point I wanted to add is the team very well, credit them for that, brought in somebody to document that thing. The mistake probably, and probably what was seen threatening by the patient's family, was they called it a consent. Yeah. So we need not word it bluntly as a consent, but at the same time for us, we have to avoid funny situations and us being in the dock later when that guy dies. If some party comes up and says, why didn't you save his life? It was your duty to save his life. So we can say that our science and our rules make us want to do this. So if we don't do this, we are going to be blamed. So if you don't want to, we respect your values, but let us please document it together. I will sign it, you sign it. That's it. Maybe is there something to protect us?
Yeah, I mean, look, as long as you document, there's a 99% chance that you won't land in trouble. It is the patient's right or the relative's right to take you to court. But the court will not go against you if your documentation has been correct. Right, so most of the times, unless you're unlucky, of course, then it's something.
And you need to have a witness on your hospital side.
Of course. I mean, it's usually audiovisual recording in these ICU setups, so it's
even if they don't sign, we are still protected.
Yeah. Yeah. So another point I'll just make before we go to the next session, if I have your permission, 1 minute. I don't know in your hospital, but in my hospital, I find my PGs and my SRs writing negative consent, and then they take sign. There is no such thing as negative consent. Consent means agreeing for something. Refusal of consent or refusal for a treatment is called refusal. So writing negative consent seems to be a little antithetic in this situation. Now, what are your comments? You all have this concept here? Yeah, so there's no negative consent. Please tell your PGs and your SRs and they should remove this idea of negative consent from the mind. It can't exist. You can't have something called negative consent. Yeah, refusal. You can say refusal. No, negative consent as a concept is wrong, sir. Consent means agreeing. You call it refusal for treatment. Yeah. Yeah.
Okay, team 2. The CECT abdomen shows free air, likely traumatic hollow viscous perforation. Exploratory laparotomy strongly indicated. At this point, patient is still not in a condition to provide informed consent. His young wife was the only family member. The parents again absconded. She appeared visibly distressed, anxious, and emotionally unprepared to make decisions about the high-risk surgery. So what she says is, doctor, I understand the surgery is important, but I'm so worried. His parents are the ones who usually take these decisions and they will not agree with the surgery. In our family, we turn to traditional healers, Ayurvedic and naturopathy remedies. I don't know if I should go ahead on my own. I feel I should wait for them, but they are not to be found. please help me understand what's safe for him.
Yes, sir. Hello. Good evening. I'm Dr. Yashwan.
Yes.
Your name?
So my name is Naveen.
Yeah.
I'm the wife.
Okay. You are, ma'am? Okay. Okay. I assume there is no small miscommunication in the team. Okay.
Yeah.
I understand that I am the doctor who is being in charge of your husband, and as we know, like as we understood your concern, that your family believes of this Ayurvedic and traditional healers is more preferred than the allopathic treatment what we are going through. But as I can say that I am not an expert in that field to comment about how the Ayurvedic or the traditional healing techniques would work on him to give a good prognosis or better with his conditions or not. But what I can explain you right now is, as we can see that the investigations, the imaging what we do, there is a thing which we have picked up which shows there might be a probability of some visceral injury. It means some organs might have been injured, and the immediate next plan has to be, we have to operate, means laparotomy, means we have to open the abdomen and see what has happened, and we have to do the correction surgery. So I understand your condition. I know that you are concerned that parents are not there, their flight has been delayed. Is there anything else you can think about right now to take a decision about?
So can you talk to his parents through the phone, if that is not a problem?
See, that also we can facilitate to talk to them over the phone. So if that can give us a better idea so that we can proceed faster.
I just call them.
Okay.
Ring, ring.
Hello.
Yeah, I'm Dr. Yashwan.
I'm a patient's mother. What happened?
Currently I think as your daughter-in-law has explained you few conditions that he is in hospital and he is already on few treatments, and we did few radio imaging which shows some injuries to his visceral organs, the probable injuries, and we are planning to do a laparotomy, means we are opening the abdomen to see some any injuries are there or.
Is there any risk you are opening abdomen and I'm getting scared?
I understand that you are over the call and we are not able to connect. No need to.
Is it cured in Ayurvedic treatment? We have a doctor there. He is also good in all this. Should I consult him, sir?
I told the same thing to your daughter-in-law. I am not sure about this Ayurvedic specific treatment. It is not my field of expert. Probably I can tell what we can do from our field from here. But
sir, is it emergency that we should do treatment in your field, or we can still go there?
See, the current condition, if you keep delaying, there is a risk that patient might have more and more infection because of the same. So the probability of him getting better will subside as time goes. But anyways, if you have to discuss with them, you can take a call, but you have to revert back to us as soon as possible.
Sir, I'll discuss with my husband and also the doctor over there. And we'll get back to you in 5 minutes.
Yeah, sure. No more drinking.
So we have agreed to do the surgery.
Okay.
You can go ahead with the surgery.
We will arrange for the consent and we'll go ahead. Okay.
Sir, is there any risk in this surgery if we do?
See, the risk of these surgeries, if we don't do the surgery, there is much more risk than we operate for the patient. Because if we leave the patient after getting to know about all these things in the imaging, we can't leave just like that, because the more risk is there if we don't do the surgery.
Will you observe him continuously, sir? Will you see him
Yes, we will monitor him.
Please update us about the condition.
Definitely, definitely. Thank you.
Communicating on the phone to the parents, not advisable, but it's an emergency, and
all the more an emergency.
I would suggest they should know the ground reality, what's happening there.
So, chemicals injection, we have to
Try to make her understand that.
Take their opinions.
Can we put the phone on speaker so that we all have a shared decision, like what the parents have to tell, what the wife has to tell, what the doctor is telling, so that everyone of us understand?
Are you okay with that?
Even that is phone better than talking.
Talking to the wife here who's present, and she is simultaneously communicating or transmitting it to the relatives. Makes sense. Yogesh, any comment?
Yes, recorded.
Yeah, okay, you could in addition record it also.
From the person who is signing, one who is the.
After the one who's signing is the wife in the front and not the.
So once you get the sign, just show it.
Therefore, we should be concentrating only on the person who's present.
And we can write telephonically consulted with the whatever person's name and we can.
In my opinion, might be risky because the chance of communications going wrong is higher when there is no face-to-face communication. Right? So, as you were told in the earlier sessions, verbal, non-verbal, gestures, there are so many things that are going to help people in making decisions when they are talking even in an ideal face-to-face communication, there's so much chance of miscommunication. It becomes much more when the person is not there. Yes, sir.
So, but with the increasing things are going on, this request to speak to the relative on phone is become very, very common. And is often misinterpreted as when we are telling that no, we don't speak to over phone.
We are arrogant.
These days.
We are arrogant.
Because every OPD, at least one person will request to speak to some son is there in the Corona somewhere and all those things. And most of the time, the comprehension will be better with the person who is speaking over the phone than because elderly people are coming with the patient's wife or the husband who don't understand much. Because we are facing it, because I was strictly no to it, but after it being very common, we feel that we are in ground as our guide said, maybe on the compassionate basis, we may have to eat more. That's what I feel.
What we are helping is only the decision, shared decision, but the consent is given by the person who is present here, and she is very closely related. So there will not be any problem with the legal issues. Only the decision making we are helping, guiding them. That is the only idea is that.
So the issue here is that the person on the phone can discuss with the person who's present on the phone, but the person who's present will finally summarize and give us a decision collectively from their side saying, I've talked to my in-laws on the phone, and this is what we feel, and this is what we're going to sign. And then she signs.
Exactly. As long as somebody is there or the patient. Now, translate, this is a life-threatening surgical situation. This happens to us routinely in the OPD, where the parents come to make an elective surgery decision and the caregivers at the time of surgery are not in the country, or the people who are going to finance the surgery are their children who are based in corporate situations abroad. I would not look at it as threatening because we do it on a routine basis, especially because the guy who's on the phone helps collate the situation for an elderly person who may not be able to remember the particulars, helps check certain things, and plus reinforces whatever they've done from their internet search, that what we are telling is right, and probably is going to coordinate things around the surgery as well, financially as well as logistically. So as long as we document it.
So there was no idea from our side to say that we should not allow this because it becomes threatening.
No.
I think is not at all the issue we're looking at. We're looking at the drop in communication or the loss in communication is likely to happen with people talking over the phone. The person over the phone is not somebody who you can make sure is that person who really claims that he or she is that person. Right? So the wife may call X, Y, and Z and say he's my father-in-law, but he may not be the father. Right? And then finding out and getting to know whether that person really is who he is difficult. So the question is, it's always good, it's always sensible that the person who's sitting there in front of you and talking to you face to face is the one who's going to be taking all the decisions, rather than, you could always reinforce with somebody else, nothing wrong with that. But it's not a question of threatening issues or anything like that. It's just a question of how well can we communicate to somebody who's not present in front of us. Any other takes on this?
It will violate all the principles of communication when we are talking over the phone. Because you don't know what is his emotional status, we don't know his educational status, We don't know their motivations, and we don't know how strongly their bond is. So there are so many. So you have to give the freedom for the wife to talk whoever they want to talk it, and she should be responsible for final decision making.
Makes sense.
In this scenario, the decision was quick. But in real life situation, there might be a lot of delay in treatment because of the discussion and delay in making the decision. That has to be documented and taken consent of.
Well, we must give them at least 4 or 5 minutes time to sit and think and maybe discuss with somebody else, call the phone and get back. You cannot say, decide right now.
Yes, sir. But if they're taking more than like half an hour, 1 hour, in emergency situations, maybe it has to be documented.
Sometimes we have this problem, right? We want to give plasmapheresis, which can be life-saving, but it's very expensive. And they say, give us some time to think about it, give us some time to arrange money. We have to give them time. And as somebody said, they can use plasma expander, they can use some other alternatives. They can try doing something else which can buy them time. But we have to give the family some time to think. It's not, you and I can take this instantly because we're living in this day in and day out. For a patient or his relatives, it's something very difficult to decide. They might need some time and we should give them time. Does video call have an edge over a local call? Of course it has an edge because you can see that person there. But I would still think that it's better to talk face to face in your presence, where we can explore much better and much more valuable. Again, it's up to you. It's up to you.
No, there are extreme situations where, in fact, we faced incidents where there is no relatives at all. Patient had a road traffic accident and brought by the emergency service. So in those cases, 2 consultants will agree for an emergency surgery, and then if you have any contact number, inform them over the phone.
So when there is no relative, it's very clear. The law is on our side. In a life-threatening situation, you have to go in and save the patient. But the problem here is that there is a relative who is not able to take decision because she just recently married, she has to in-law, etc. etc. When there is no relative for giving consent, then you can go in and do whatever surgery you want to, and then take consent later. Okay, but when there is a relative available, the law says that the consent should be taken.
But during COVID time, we used to have this video consents and stuff, right?
Because of pandemic time and the medical emergency act.
Yeah. So that time it is fine.
It is under the act, yes.
Under the act.
Actually, many a times when they don't understand drawing and explaining to them and then telling you share this drawing, many a times we do that. They share those images with their family members and replicate whatever we told them. It's easier for their understanding many times, these visual aids and things. Anyway, team 3. Yeah. So the same scenario, there is a hollow viscous perforation, and here now they have given consent for surgery, and you are further going ahead and telling maybe he needs a temporary stoma. Doctor, I understand the surgery is to save his life, but the thought of stoma really frightens me. He's so young, he works in IT, very particular about how he looks. I worry what people will say. In our community, there is so much stigma about having a stoma. I'm afraid it will shatter his confidence, it will affect his job and his relationship. I don't know if he will be able to accept it. Can we not try something else? Can we not operate without the stoma? To get consent for surgery, you have already struggled. Okay?
Good morning, doctor. So, sir, you said that my husband needs to go under some surgery. What is it exactly?
Hi, I'm Dr. Shreyas Reddy. I'll be the operating surgeon. So hopefully you've got enough information from the other team members regarding the fractures, the chest injury, and you've understood. So later on when the CT was done, what we have found out is there's a hole in the intestine. It could be the large intestine or the small intestine. So we've already been counseled regarding the need for surgery, that is laparotomy. So you're worried about the stoma, so I'll put it across to you in simple terms. So once we do the procedure, intraoperatively we'll decide if the bowel is swollen up, that is if there's a lot of edema, we would like to close the bowel, we would like to do a primary closure as well as we would like to divert the fecal matter. Basically if we don't do that, so stoma is basically exteriorizing the bowel loop and then so that the fecal matter comes out. In case we don't do that, later on he may have other complications. So why we may have to do it is to avoid further complications such as what do you call it as fecal peritonitis, where he may go in for the BP may drop, the pulse rate may increase, and complications may further, it will complicate the situation.
But sir, what exactly is this stoma? Like, how is it going to work? What is going to happen?
As I told, there's a hole in the intestine. So once we repair it, we'll get a part of the bowel outside so that the fecal matter comes out and it will be collected in a bag. So that we give enough time for the bowel, the repaired area to heal. Otherwise, there are possibilities that...
That hole you can't do, patchwork, some patchwork you can do. Some patchwork to close the hole. You can't.
So first of all, I would like to know your identity.
I am a patient's...
Sorry?
A patient's brother.
Okay, patch, we may repair that particular area, but after that, for the patch to work, we need to do a diversion stoma, as I told. Divert that part of the bowel, so the fecal matter, that area, repaired area, so even after applying the patch, it may give off. So the fecal matter will leak into the abdomen. Then there's a condition called fecal peritonitis where he'll go into, the BP may drop, there will be high rates of infection. So we may have to go in for that procedure, which will be decided intraoperatively, and then the fecal matter will be collected in a bag. And regarding other concern, it is not permanent. So permanent, it's done in other conditions where we may suspect cancer, but in this condition, usually, first of all, intraoperatively, if we decide we are going to do it, it is a temporary procedure.
For how long it will be? Like the insides will be outside the body, is it?
Yeah.
So for how long it will be? Because he's young and we haven't even started the family, so how it's going to work?
So post-operatively, we will assess him again, and usually it will be kept for around 8 to 10 weeks.
After that it will be fine. After 8 to 10 weeks he'll completely cured.
We need to do a second procedure where we'll close the stoma, we'll reconnect those cut ends, and then more or less he'll be in a normal situation.
So how will he poop till then?
I already told you, the fecal matter will be collected in that bag, which is called stoma, and from time to time you have to empty it.
The smell and all won't come.
It's a very good question, because stoma care is a very important aspect. The stoma care will be thoroughly explained to you, where the bag has to be taken off and that area has to be cleaned. And currently there are multiple people, the stoma care experts are there. With the number, I'll share it to you. They'll come to your house and they will clean it on regular basis or show you all how to do it.
So how much financially this is going to cost? Because he just started with the job and we are not that financially stable right now.
So do you all have any insurance or any schemes with you all?
No, not as such.
I have insurance.
Okay, so there's an insurance team. So we'll discuss with them regarding the cost. And
yeah, but
regarding the
approximately, because again and again we'll have to call somebody from outside to clean, and there's going to be an 8 to 10 weeks.
So roughly post-procedure, in case it doesn't require ICU admission, it will be managed within maybe a smaller amount, but in case he needs ICU admission, as I told you, sometimes we may have to keep him in ICU for a day or two. So that time the cost may be higher. And you may also be thinking about that part as a stigma. So
Yeah, because he meets a lot of people and I don't think he will take it very well because he has to work and I don't know how will he take it.
So since you mentioned he's an IT professional, does he have the option of work from home?
He does, but now he meets a lot of people as he's started a new job, so he has to go to the office regularly.
So as I told you, we'll be closing that stoma after 8 to 10 weeks.
So 8 to 10 weeks he cannot go to the office, is it?
For the first 1 month at least, it's better that he takes rest. After that, even if he has to go to the office, they'll be covered. The clothes he puts on will be covering the stoma and it won't be visible.
Smell again, what he mentioned.
Usually, if there's no much, if it's properly maintained, as I told you, we'll be training you all, and the stoma experts also will be showing how to clean it. There's very less chances of it giving it a bad odor there.
What are the complications if, like some care which we have to take from our side and the complications which can happen with that?
There can be infection.
So
and
how to take care of all those?
If it's not cleaned on regular basis, the fecal matter can come in contact with the skin, the surrounding skin. Then the skin may peel off, what you call excoriation. And then he may develop fever. Then the bad smell which your brother is worried about, that may come into play.
So you're telling this is the best option currently?
So as I told you, there may be a possibility. So intraop, if we feel we don't have to do it, we may go for a primary closure and go ahead with it. But in case we need a stoma, we'll go ahead. So that if we don't do that, later on the sutures or the stitches what we apply or the patch what we put may give off and he may need a second surgery and he may go into other complications such as peritonitis.
Okay, my niece is a doctor. I'll ask her and tell. She is MBBS first year. Okay, I'll take her opinion. How much time we have for deciding?
Since multiple teams have already explained to you and it's already taken time, it's an emergency. Your niece can come and meet me.
Can we do something else till that time? Can we do something else apart from? Do we have any other option?
No, as I told you, it's an thing which will be, what you call, intraoperatively we'll be deciding it. And if needed, we'll go ahead with it.
Okay, then we decide on it.
Saying anyway he works from home. That was amazing.
And that's what is called evaluating the values. And that's also the you are right, more searching on the values. She was very much concerned about her husband's looks, what the opposite people say. That can learn about good name, smell.
Basically rehabilitation, the post-op also patient doesn't worry about what you're going to do inside. What is going to happen after that is their worry most of the time. I think we need to address that also.
Yes, people
So the good aspect is that the doctor has explained the necessity of the stoma and what will be its consequences and complications of the stoma as well. And then the communication aspect, especially with the bystander who was putting his layman's concern and options like a patch, the doctor didn't get offended. He took it in a good spirit and explained very well. Then he reassured the patient, the wife many times by saying that it was a temporary one and has to be, and will be able to reverse it later. And in fact, once the doctor said it's a very good question, so that he is encouraging for the wife to articulate more and more to address all the concerns which is there in her mind, rather than inhibiting her to come out with her concerns. And he even went to the financial issues and as well as the option which is already commented about alternative option like working at home. So in that way it is complete and comprehensive, especially in an emergency condition. The points to improve upon, I didn't see the basic aspects of the communication like introducing the role of the surgeon as well as the patient. Okay. And then the anxiety of the wife is well expressed, but has not been addressed by the doctor by consoling with some words initially. And she has to ask it twice what is the stoma, and that indicates that the message has not been conveyed properly. So when the patient or the relatives are asking the same question again, then we got to reflect on, are we really communicating properly or not? Sometimes we might have used technical terms which are not comprehended. For example, at once he said we will do primary closure. That is a technical term which ordinary people may not be able to comprehend it. That's it, yeah. Thank you.
Be covered by clothes, it will not be visible, so your husband need not worry about his image. So there was some exploration of the value system there, but she was very worried about the long-term effects. She would have said, is there going to be a scar there? Are you going to do plastic surgery to cover that? Those options that could have been covered so that the wife would have felt more confident. There's no long-term permanent issue here. Good. Next, scheme 4. And scheme 4 assess.
Yeah, now the patient is fine, doing well, and he's conscious. And the physician is now prescribing insulin. Patient becomes anxious and defensive and says, "Doctor, I have been on OHAs for years and it has worked fine for me. I have heard once you start insulin, you're not going to stop. So you're going to make me dependent for life and I don't want these injections. I will work on my diet, I will take tablets, I will do yoga, but I don't want insulin."
Good afternoon, Mr. J. I am Dr. Nahel from the Department of Medicine.
Good afternoon.
I have come here to treat your diabetes because you have been on your treatment for diabetes for long. So I have been called to check your diabetes. How are you doing now? Are you okay?
I'm fine, I'm doing great, sir.
After your unfortunate incident, I'm happy that you are recovering well. See, I found the case sheet. It is showing that your blood sugars are persistently high, around 280 to 300, even though you have been on tablets before this for diabetes. Now, maybe because of the surgery, maybe you are recovering, you are in the ICU, but you are not able to walk well. So maybe that is the reason your blood sugars are a little high. Thing is, we have to bring down the blood sugar to the normal level now. So the right option would be to switch over to the injection type of therapy. So injection is not very painful injection. It is a very small injection we will be giving, maybe 3 or 4 times a day. That will help you to recover. So what is your opinion about that? Because this is...
Since it's been 10 years, sir, I am taking only tablets. Nothing happened to me till then. So I don't want to continue with the...
I absolutely understand your concern because previously you have been working very hard. You are a young fellow. So maybe that was the reason you have been very good with your tablets. Since you are in hospital and you had a major surgery and you are not able to walk around properly, maybe the reason you have a increase in the blood sugar and you have a major surgery is done. And
if that is the case, after getting discharged, I can do exercise. I'll stop eating rice.
Absolutely. You can do the exercise. You can do all kinds of therapies after once you get discharged. So the thing is, now you have to be on. We have to start on insulin so that your blood sugar is under control, and that will help you to recover fast. Thing is, if you don't start the insulin, it may prolong your recovery also. So instead of staying in the hospital for 1 week, you may have to stay in the hospital for more than 1 week or 1 month, and it may complicate your wound. Chance of infection may get is more. So to prevent all those things, I recommend you to start the insulin therapy.
I heard that injections are very painful, and if you start taking, it has to be continued for lifelong. So
injections are not very painful because our sisters are well trained in giving the injections, and you will not be feeling much pain. And if you are feeling pain, we have other options like insulin pens are available. That is even less painful. And there is nothing.
Do these injections have complications?
Usually these injections will not much complication because our sisters are well trained for this, and we will be taking all the precautions to prevent any kind of infections coming because of this insulin injection. And thing is, since you don't have a failure of tablet treatment, this is insulin started just because of the transient period. So most probably we will be discharging you back to OHA once you are recovering, once you are able to walk around and all. We'll be trying to switch over to tablet before you discharge.
Won't it get recovered by yoga or other exercises?
As of now, it is difficult to get recovered because you are not able to do yoga and exercise now. So once you have recovered from this condition, you are going back home. Once you are able to start yoga and exercises, we can switch over back to, probably we will switch over back to tablets and stop the insulin therapy. That is what our plan of treatment. So I hope you have understood.
Yeah, but it's been many days. It's been 2 weeks now. I'm on injections and all. It's very painful.
This injection we are giving just to the skin only. We are not giving any painful injections. So this will help you recover very fast. That is one advantage of taking the insulin now.
Okay, I'll ask my relatives' opinion. I'll let you know.
Thank you. Thank you.
Doctor, can I have quick comments quickly in 30 seconds so that we can finish?
Doctor has introduced himself well, started the discussion well, and he's told the reason for him to have diabetes, need for insulin, and also he made a statement, in my opinion, insulin is the best choice. What do you think? So there was an open-end question, and they facilitated a good conversation also. And he told the complication, if he doesn't take the insulin, it will lead on to infection. So all the matters were touched up well.
You have done better. There are two things this patient is worried about. One is the insulin never going to stop.
And both were addressed. He told sisters were well trained, and he told once he's back doing his routine activities, we'll be able to stop the injections.
Any other comments, any other things? Supposing he was to say that today's modern injection, like he talked about the pen, but he didn't say that the size of the pen is so thin that it causes him less pain than a mosquito bite. That's something the patient can relate to because he would have had a mosquito bite. It's saying less painful is abstract, saying even less painful than a mosquito bite, and it's something which is more acceptable to the patient. And what about stopping, not stopping, permanently required, not required? Did you address that issue?
Yeah, sir. Spoke upon that.
Once your sugar is
Once he gets back to his routine, we can try switching back to HGs. Sir.
Ravi sir, just this one. I know this is not truly part of this. When you start communicating, I think there are other tools which we have not touched upon. Your non-verbal clues, I mean, which were actually not used in this conversation. He could have made more voice variations. It was looking more monotonous. These are things which you have not touched upon, but very important in part of communication, especially when you are talking, explaining at detail. Otherwise, it becomes, doesn't register.
Like in the previous one about the stoma, some gestures or some drawing that will enhance the comprehension. Okay. Karen, want to add comments?
No, sir, no. But I appreciate that he said that once you are normal and discharged, you can go back to your yoga and naturopathy and we can taper. That he said, we can try reducing your insulin. At least he didn't shut the patient down, telling no. Okay, shall we go to the team 5, sir? Because, yeah, now this patient suddenly has gone bad. He's developed surgical site infection, multi-organ failure, and now he has ended up on a ventilator with vasopressors, broad spectrum antibiotics, etc. And now the family questions to you, doctor, please tell us honestly, is there any real hope or should we take him home and prepare him for the final journey?
Good afternoon. You are Mr. J's relatives, right? Yeah, can we move to the counseling room? Yeah, I'm Dr. Loyson. I'm the operating surgeon for this patient. I think you are Mr. J's relatives, right? Yeah. So I think you must have been seeing him in the ICU recently. You must have seen today morning also. So we have been regularly seeing the patient also. So sir is the critical care physician who is taking care of the patient. He will explain to you the recent developments about the patient.
How is he, sir? How is he doing?
I'm Dr. Prajwal. I'm seeing him every day for the last 2 weeks now. So as you know, he's come to the hospital with the accident. After that, he had a major surgery. So after that, he's developed an infection. Okay, we have done everything possible, giving him the best antibiotic. We are trying to control the infection. But what has happened is slowly, day by day, his condition is deteriorating. Condition is going down. And now he's developed some organ issues also. He's developed kidney failure, he's developed liver failure, counts are not coming under control. So daily the antibiotics are also hiked up and we have put him on a higher antibiotic. But still his body is not responding to the treatment which we are giving. We are trying the best possible medications, but it's slowly deteriorating and he's on ventilator also. So he's developed a pneumonia also. So this condition doesn't look so good and day by day is deteriorating, slowly deteriorating.
Okay, sir, but already so much we have spent, sir. Recently I was married, then so much since 2 weeks in the ICU we have spent so much money. Scheme also, that previous doctor said they will get it, and that recently from the billing they called me. They said scheme is also over, ಈಗ ಏನು ಇಲ್ಲ. And my in-laws have sold the land, I've sold all the family jewelry, everything, sir. Now what to do, sir? What do you think we should do? So long he's in the ICU, no improvement, means I don't know. And my in-laws are not, they're saying we are praying continuously. There might be some hope. I don't know what to do, sir.
Look at my sister, sir, not had bath, not slept. Look at her face. Sir, my father has sold all his land. We have lost everything for this treatment.
If we stop the treatment, we are going against God's will. What can we do? We can't stop.
What do you think we should do, sir? You said he was improving, now I don't know. Huh?
See, he was improving, but he's developed infection, which is not responding to any of the medication. One thing is, you guys also have cooperated for all the treatment. You guys also have cooperated, and we have done best possible. There is nothing left to do. So we are still, we have a small hope, but I can tell it's only like 10 to 15%, because he has multiple organ failures. All his organs are going for a shutdown. If it was one problem, we could have addressed it. But since all the organs are failing, there is a very less hope. So I could tell only there's like a 10% hope.
10% hope also, if he survives, he'll be like he'll do everything, he'll go back to work. I also stopped working after marriage. My in-laws are very religious. They said they can't work, nothing. Now where we'll go for money, sir? He'll be normal, back to normal fully, sir.
See, since he has multiple issues, the recovery chances are very less. So you have two options, because you have financial constraints also. Since I'm giving this option because he's very young, he's only 28 years old. If it was so you can either continue the treatment, we'll keep him on ventilator, continue antibiotics, but this recovery, if at all anything has to happen from here, it would be a miracle. Okay? And even if he has to recover from this condition, it'll take at least another 15 days. So it'll add on to your financial burden. And even after spending so much, there is no guarantee that he will recover and go back home walking.
So I prayed every day, sir. I believe in miracles, sir. Sir,
yeah,
do something.
But he is deteriorating slowly day by day. So you have two options. Either continue the treatment in the same way, but there is no guarantee. Or if it is, the bills are coming too much, you can discharge him and take him to a government hospital so that your financial burden is reduced. Or you can discuss among your family, and you can let us know if you want to withdraw the care, because there's only like 5 to 10% hope.
How to withdraw, sir? Sir, imagine your son in the ICU. Will you stop treatment, sir, or will you continue?
See,
I've been seeing you from the initial stages, or from casualty. I've been seeing you, I've been treating you. I know you all have given full effort to take care of the patient. You have financially everything, emotionally you have invested everything to improve this patient. And we planned for the surgery to save his life. Everything has happened, but some unfortunate situations, it was an accident, and he had sugar also, which were uncontrolled. Eventually it has led up to this. We have seen many patients like this. Obviously we can understand what you are feeling from your side. You don't have to take any guilt from your side, right? You have put your maximum. You can trust us, we have put our maximum also. So you can,
Sir, our priest has said this 1 week is very bad for him. After that he will improve. So what to do, sir?
What do you think we should do, sir? You tell us.
See, we are giving our maximum treatment, so we are not going to withdraw treatment. We are just discussing the current scenario with respect to your financial and emotional, concerns. So we can continue the treatment. You can tell your decision. We will continue the treatment, try our best to save his life, and we'll give all the supportive measures. And further decision, you can discuss with us, and you can let us know also.
So treatment ನಿಲ್ಲಿಸಿದ್ರೆ ಏನಾಗುತ್ತೆ?
See, he is on critical supports. If you stop the ventilator or injections, he is going to die. He's just surviving because of the ventilator. Yeah, so 3 options are given to you. I think you can discuss and get back to us what is best for you and the patient.
Most of the times the ICU patients are like this. One day you say something is good, next day they are down. Third day they are on the way out.
Yes,
introduction and events, he not only addressed the current situation, but throughout the prognosis, throughout the course of the hospital, the doctor has communicated well, so that patient has an idea. And also the approach of surgeon and intensivist, both as a team counseling the patient, I think is a good option, and is better for the patient to understand, rather than intensivist and surgeon separately counseling the patient for the condition. And also to remove the guilt of the patient for withdrawal from the patient was also addressed by the surgeon, is a positive. And apart from that, documentation was, I think,
that patient party is ready.
Not a point. Why should I?
Very much individualistic. I would emphasize on even if you wanted to pay, chances are extremely unlimited.
So, but the priest is saying this 1 week is the guideline. They are what hopes after 1 week.
I don't want to destroy the belief. So, if they have full faith in that and they are prepared to take the penalty, the brunt of the financial load that is going to fall on them. If they are prepared to take it, then I wouldn't want to break it. But I would make it very clear that it's extremely unlikely that things are going to be in their favor.
You would rather use the ventilator for some other patient who has no chance of improving.
This is difficult.
Nothing left word was used that could have been avoided. No other treatment option left word was used that could have been avoided.
So, two observations. I'm not sure whether we can objectively tell the chance of survival is 10%. So, 0% or 100%? Yeah. So, put it in such a way that it is more of, okay, minimal survival chance is there, or it is getting, smaller and smaller. So, I don't know how 10% kind of, how the patient takes. That is one. And discharging the patient because the financial constraint is getting higher and higher. So it has to be put in such a way that because the risk, the chance of survival is reducing, and because it's probably the last few days left, then you are planning for discharging. Just because the finance is coming down, so you don't put on the finance side. Let them decide. So what I didn't probably like is the surgeon or the consultant telling, okay, because your money is getting over, your schemes are getting over, then you take home the patient. So that is something can be taken as a negative side also.
So you have to be careful about not giving that impression.
Yeah, exactly.
Yeah. How many of us felt that the doctor was too eager to push the patient out, saying, yeah, no. So you should be careful that we don't give that impression. We should not take the decision on behalf of the patient that it's time for you to go home. And time for your home decision should be taken by the patient or the relatives.
Okay.
Everybody, wonderful. And team 5 gets the best applause for us.
Of whole day. We are just waiting for the dean to come back here. He's having his food another 2 or 3 minutes. Meanwhile, we would like to hear few observations from you where we can improvise this session, what we have done today for next time. I know you're going to take official feedback, but then 1 or 2 people or 3 till sir comes can give us few inputs.
Couple of points, because this is a medical school and the program is meant for the faculties. And in my short exposure here, what I found is the problem between communication between faculties and the students. So that has to be addressed. Especially I found that the students are not verbalizing, hardly asking questions, hardly interacting, and it is a master-servant relationship. Yeah, teacher-student relationship. It is more like a master-servant rather than a co-workers. So because this is very important, because we are the role models. It depends on your interpretation how you take it. Because that is what we have to model, especially in a medical school rather than in a hospital setting. So,
just to add to that, I think that's totally a different program which is being done by them on a regular basis. This is an addendum to that because this is part of the hospital requirement and nothing to do. I know it's a medical education cell, it should have been hospital education cell, but both mean the same. That there's a lot of programs for that. Probably you also might get a chance later on in the coming days.
Actually, while counseling the patient, actually consultant will be counseling the patient. So during that time, even PGs can be there, so that they learn the words which we are using. So when they go out, they'll also use and whatever how to handle the situations like that.
No. Different. That is ours.
That is not that.
Different.
But it's also
Okay, agreed.
suggestion.
I think make an habit to all of consultants. Please ensure that postgraduate sits next to me or next to you or stands next to you when you are counseling, so they learn good things. And I have one important suggestion. I think this is from the faculty. Actually, it's not from me. Now that you have at least 1% or 2%, whatever you learned from morning, is there a possibility for you to roll this down to your postgraduate? Because what is happening in spite of all these efforts, finally they are the one who's going to run the show in emergency department. Elsewhere, where we are, all the whatever bad things we are hearing for ourselves is, welcome sir, Dean and the Vice Dean. So what we are hearing is, please be seated, it's okay, please be seated. What we are hearing is the problems when our postgraduates start doing the counseling. My request is, can we at least this time, this batch, we'll all join together. You yourself can be faculty for that. At least 3 departments, can we do this for the postgraduates? Can someone take the initiative? 3 departments, who are the maximum here? Medicine, how many are you here? Raise your hands. 1, 2, 3. Can you do? We'll help you out. We'll come. Yeah? 4 are there. Yeah, 4 are there. You can do general surgery. How many of you are there? 1, 2, 3, 4. I think 5. You have Karen ma'am there. No, my request is you conduct a 1 day, 2-3 hours of program. It could be split into 2 or 3 sessions. It could be completely different from what we are doing. Not necessarily the same stereotype you need to carry on, but you can do in your own way so that the postgraduates also learn like how we learned. It's impossible for the MEU cells to do this for every department and every postgraduate. And second thing, postgraduate keeps on changing every 3 years. So we wish this becomes an academic event from the department itself. Who is the other department? 1, 2, OBG? OBG, how many are there? 1, 2. Only 2 is enough, right? We are small people. OBG can also do. One more department. Pediatrics. Okay, pediatrics and ortho. 5 departments will do this time. We will monitor, we will help you out with whatever additional staff faculty or requirement, resource person, internal, external, whatever it is, and other expenses, if so, anything, we will help you out. But we want you to rule out so that the students also learn, especially the postgraduate. Okay.
One more thing, I was just thinking, I wonder how this sounds to all of you, because there's a lot of members from different departments. If you look at communications effectively worldwide standards, they talk about a 360 communication. So we've talked and done extensive modules, even with trainees now on, as in medical students, on doctor patients. We should also probably do something on colleague to colleague communication. Communication with juniors, communication with seniors, communication with paramedical staff, and probably think about how we come across to them sometimes. Either reprimandative or too loose sometimes, either way. Just a suggestion. Your thoughts?
We have come to the end of the workshop on decoding effective communication skill in patient care. As I said in the morning, we have conducted similar workshop that was half-day workshop. And we asked the feedback from the participant, and they said half-day is too less. That's why, based on the feedback from the last year, we have changed to almost a full day. Okay. And the second thing is, the participant, we are silently observing, including the resource persons. You are too good. And nowhere any of the faculty is not participating. Almost everybody was involved, and they were very much contributing in any of the sessions. I don't think so any. Okay. So for this, anyway, MEU means generally I will not waste much time in inauguration and all. I don't believe it. It should be a purely academic session. It is a brief valedictory session. I have invited Dr. Sandeep Rai sir. He is Dean KSHEMA. Welcome you, sir. And Sukanya madam, almost madam doesn't need any introduction. Backbone of my team, MEU and curriculum team. Welcome madam. And welcome to all the resource faculties sparing your valuable time from external members and internal members, and all your colleagues. I will be first distributing the certificate to the participant. I am assuring you that when IQS is here, Dean is here, I will be assuring you in the PBS you will get 1 day credit off for this. That is also one hidden agenda, I know that. Okay. So I will be calling the names. As you can come across, you can come here and collect the certificate from Dean and Vice Deans. Dr. Grishma Rai from General Medicine. Dr. Nehal, Dr. Meghna, Dr. Rohan, okay. Dr. Sonakshi Mago, Dr. Samantha, Dr. Prajwal K, Dr. Srinath, Dr. Vaishnavi, Dr. Akhilesh, Akanksh, Dr. Akanksh, Dr. Suhan, Dr. Sridharan, Dr. Loyson, Dr. Niveda, Dr. Punjabi Nirmal, Dr. Alden, Dr. Mohammad Ansar, Krishna Sharan, Dr. Bharat, Dr. Siri Kandavar, Dr. Giridhar, Dr. Krishna Priya, Dr. Pujita, Dr. Dhritiman, Dr. Maria, husband wife ibbaru bandiದ್ದಾರೆ. Dr. Shreyas, Dr. Yashwant, thank you all the participants. Now I'd like to request the resource faculties. It is a small token of appreciation, taking your valuable time and helping us to conduct this workshop. I would like to request Dr. Ravi Vaswani sir. Dr. Harsha Prasad, Dr. Yogesh sir, Dr. Vishwaranjan. Thank you, the external resource faculties. I would like to request my own team, Dr. Vikram sir. He is the person behind running this show. Stay together for continuously with 6 hours in MEU. Dr. Karen. Dr. Shishir. HOD addakondu. Okay. Thank you all the resource faculties. Now I would like to request Dr. Sandeep Rai to speak few words.
No, initially itself he told me that I am not interested in having a valedictory function, this, that. Now he is asking me to speak. Thank you very much to the resource persons for coming here, adding value to us in this institution. We are very grateful that you have taken your time off and come here. Thanks to all the participants. I was so happy to see so senior people coming and sitting here and saying that I want to relearn what I have not learned, or maybe learn something new from communication from all the experts that have come. The juniors, of course, I'm very too happy to see them that this is the other skill which we don't teach in medical colleges. I think we should start having one segment where we start training our undergraduates on how to do communication. This is something which I am very interested in, and I have actually told a lot of people now. We'll slowly identify and we'll start taking communication classes for undergraduates itself, and we'll take that forward into the postgraduates too. So happy to see you all, and that the whole day went on very well. Thank you so much for being here. 3 cheers to all of you guys. Thank you,
Dean sir and Vice Dean for gracing this occasion. Thanking all the external resource persons and my own team for, I think whatever the knowledge you are having, you are percolating into our participant group. Thanking all the participants for actively attending this session, and don't just stop. Whatever you learned today, you should move on. As I said in the morning, we may not be a good teachers, but probably you are doing some wonderful job. Probably you may have to do still better job. Thank you one and all. Thank you my team, non-teaching faculties for helping me in this organizing this event. Now we'll have small group photo. We'll assemble for small group photo.